Please settle down and take your seats. We are going to start with the program very shortly. All those who are crowding the aisles are requested to please settle down and take your seats. We have a number of vacant seats on the right side of the hall. All those who are trooping in are requested to please up their pace a little bit and quickly find their spots to be seated. We will be starting the program very shortly, and I have a sincere request that our esteemed dignitaries who are joining us for this joint plenary session may please be seated in the front row at this point of time. I would request Dr. Jonathan Perlin, President and CEO, Joint Commission Enterprise JCI, to please be seated in the front row. And I request Dr. A. Mark Harrison, co-founder and CEO, Health Assurance Transformation Company, to also please be seated in the front row. Dr. Atul Mohan Kochar, CEO, National Accreditation Board for Hospitals and Healthcare Providers, NABH. I request you, sir, to please be seated in the front row. I request Dr. Madhu Sasidhar, President and CEO, Hospital Division, Apollo Hospital Enterprises, to please be seated on the front row. And joining them in the front row, I request Mr. P. Shivakumar, MD, Indraprastha Medical Corporation, to please be seated. And I would request our distinguished excellencies who are joining us to please be seated in the front row. We will start the program very shortly. And all those who are still considering on which seat they should occupy, whichever one you find quickly, please settle down. We will start very shortly. Ladies and gentlemen, I request all of you to please settle down. We will be starting the conference very shortly. Our chief guest has arrived and is just walking up as we speak. So, good morning to all of you and a warm welcome to all of you to the International Health Dialogue 2025. We are very privileged to have with us our esteemed dignitaries joining us today. I would request all of you to please give a round of applause and welcome some of our esteemed dignitaries on stage. Please give a round of applause and welcome on stage Dr. Jonathan Perlin, President and CEO, Joint Commission Enterprise, JCI. Request Dr. Jonathan Perlin to please come up on stage. Joining him on stage is Dr. A. Mark Harrison, co-founder and CEO, Health Assurance Transformation Company. I would request Dr. A. Mark Harrison to please come up on stage. Please give a round of applause and welcome Dr. Harrison on stage. Please welcome on stage Dr. Atul Mohan Kochar, CEO, National Accreditation Board for Hospitals and Healthcare Providers, NABH. Please give him a round of applause and welcome him on stage. Please welcome Dr. Madhu Sasidhar, President and CEO, Hospitals Division, Apollo Hospital Enterprises Limited. Please give him a round of applause and welcome him on stage. Please welcome Mr. P. Shivakumar, MD, Indraprastha Medical Corporation Limited. Please give him a round of applause and welcome him on stage. I would also request our esteemed dignitaries, the distinguished health ministers from Maldives, Guyana, Eswatini, and Fiji to please come up on stage. Please give a huge round of applause and welcome on stage His Excellency Abdullah Nazim Ibrahim, Minister of Health, Maldives. Please give a round of applause and welcome him on stage. Please welcome His Excellency Dr. Frank Anthony, Minister of Health, Guyana. Please welcome His Excellency Madhutiji Matsubule, Minister of Health, Eswani. Please give a round of applause. Please, I can't hear the applause. It's got to start now in a loud way, please. Please welcome him on stage. Please welcome His Excellency Penyoni Ravunava, Assistant Health Minister, Ministry of Health and Medical Services, Fiji. Please give a round of applause to our dignitaries, and very shortly we'll be welcoming our chief guest. Thank you all for being here early this morning. I request all of you to please take your seats. It will be very nice if all of you settle down. You will be comfortable. You will enjoy the experience more. Request all of you to please settle down and take your seats. We have some unoccupied seats on the right side of the hall. So all those who are in the aisles, please take your seats. We will be starting very shortly. I request all of you to please settle down, and I also request all of you, a humble request from my side, to please put your phones on silent or on airplane mode. When our speakers are on stage and speaking, you don't want to miss out on the insights that come your way. So I request all of you to please put your phones on silent and please settle down and take the seats. I request all of you to please settle down quickly. We still have a few seats which are unoccupied on the right side at the end of the hall. Request all of you to please settle down. I request all of you to please clear the aisles. Please take your seats and settle down. Thank you all for your patience. I request all of you to please settle down. We are going to start the International Health Dialogue 2025 in just a bit. I would request our distinguished dignitaries who are seated in the front row to please come up on stage. I would request Dr. A. Mark Harrison, co-founder and CEO, Health Assurance Transformation Company, to please come up on stage and take his place. I would also request Dr. Carsten Engel, CEO, International Society for Quality in Healthcare, ISQA, QUA, to please come up on stage and take his seat on stage. Please give a round of applause and welcome our distinguished dignitaries on stage. In just a minute or two, we will be welcoming our chief guest on stage as well. Ladies and gentlemen, please put your hands together and give a rousing applause to our chief guest, Shri Jagat Prakash Nadda, the Honorable Minister of Health and Family Welfare and Chemicals and Fertilizers. Please, it has to be a thunderous response because we are very, very honored and privileged to welcome our Honorable Minister for Health and Family Welfare, Chemicals and Fertilizers on stage. And joining him on stage, we have our other dignitaries as well. Please give a round of applause and welcome Dr. Preeta Reddy, Executive Vice Chairperson, Apollo Hospitals Enterprises Limited, Dr. Sangeeta Reddy, Managing Director, Apollo Hospitals Enterprises Limited. Please give a round of applause and welcome His Excellency Abdullah Nazim Ibrahim, Minister of Health, Maldives, His Excellency Dr. Frank Anthony, Minister of Health, Guyana. Please welcome His Excellency Madhutiji Matsubela, Minister of Health, Eswatini. And please welcome His Excellency Peony Ravunawa, Assistant Health Minister, Ministry of Health and Medical Services, Fiji. We begin the conference with a tradition deeply rooted in our culture, the ceremonial lighting of the lamp. The lamp signifies knowledge, wisdom, and collective pursuit of excellence in healthcare. I would request our chief guest, Shri Jagat Prakash Nadda, the Honorable Minister of Health and Family Welfare and Chemicals and Fertilizers, and our dignitaries on stage to please come forward to light the ceremonial lamp. Also on stage, we have a few students of Badri Bhagat Ved Vidyalaya, and we request our dignitaries on stage to please light the lamp so that our conference begins on a very auspicious note. Thank you all for initiating this auspicious beginning to the conference. May this light guide our discussions and inspire innovative solutions to a safer healthcare system. I would now like to I would request all our dignitaries to please take their seats on stage. Once again, please give a huge round of applause to our dignitaries who have graced us with their presence in the International Health Dialogue 2025. His Excellency seated here. I would now like to invite Ms. Sudha Raghunaraman. She's a celebrated Carnatic vocalist to please give us a melodious rendition of a devotional song. Please put your hands together for Sudha Raghunaraman.
गाये गणपति जगवंदना गाये गणपति जगवंदना शंकर सुवन भवानी नंदन शंकर सुवन भवानी नंदन गाये गणपति जगवंदना सिद्धि सदन गजवदन विनायक कृपा सिंधु सुंदर सबदायक कृपा सिंधु सुंदर सबदायक गाये गणपति जगवंदना मोदक प्रिय मुद मंगलदाता विद्यावारिधि बुद्धि विधाता विद्यावारिधि बुद्धि विधाता गाये गणपति जगवंदना मांगत तुलसीदास कर जोरे मांगत तुलसीदास कर जोरे बस ही राम सिया मानस मोरे बस ही राम सिया मानस मोरे गाये गणपति जगवंदना शंकर सुवन भवानी नंदन गाये गणपति गाये गणपति गाये गणपति जगवंदना जगवंदना जगवंदना
I would request Dr. Sangeeta Reddy to please felicitate Sudha ma'am with a small token of our appreciation. Thank you, ma'am, for your very soulful rendition. Thank you for coming here. Now, as we move forward, let us take the spirit of enlightenment into the session ahead with audiovisual curated to overview the International Health Dialogue 2025.
We have all seen healthcare evolve. Now, let's get ready to reimagine it. Welcome to the International Health Dialogue. Gear up for 2 conferences at the heart of healthcare transformation. This is where bold ideas and brilliant minds converge to reimagine healthcare. Powered by Apollo Hospitals for 12 years, this global movement unites pioneers in patient safety, digital health, and innovation. At the 12th International Patient Safety Conference, we're moving on to the next frontier of delivering care. With 3,000 plus delegates, greater than 300 speakers, and 70 plus sessions, the next era of patient safety will unveil. At Transforming Healthcare with IT, we're advancing to sustainable health systems. The digital health market is projected to hit $549 billion by 2028, creating a massive opportunity for healthcare innovation. With 2,500 plus delegates, 100 health tech innovators, and 70 plus top experts, we're pioneering the transformation of digital innovation in healthcare. Expect breakthroughs in AI, blockchain, cybersecurity, telemedicine, and smart hospitals. live demos, real-world applications, expert roundtables, and more. This is the First Hope 2025 conference, where global industry leaders discuss advances in operational efficiency and patient experience, the two pillars of modern healthcare. 2 days where global pioneers bring game-changing insights to reimagine healthcare. Let's shape the future together.
With great respect and enthusiasm, I invite Dr. Preeta Reddy, Executive Vice Chairperson, Apollo Hospital Enterprises, to please address the audience and give the welcome note. Please put your hands together for Dr. Preeta Reddy.
Namaste. Mornings like this will go down in the annals of history as something which has made a global change. I would like to acknowledge the presence and thank our Honorable Minister for Health and Family Welfare and Chemicals and Fertilizers, Shri Jagat Prakash Nadda ji, for his time and his constant support to the movement, the healthcare movement in India, and to make India definitely a better place to live in. Thank you, sir, for your presence. We have ministers from friendly countries, neighboring countries, and for all of you, I would like to thank you, welcome you all, and acknowledge your esteemed presence in this conference today. We also have gentlemen who head institutions who really make a change in the way healthcare is delivered in the globe. Thank you all for being here, and we're honored and delighted by your time, effort, energy to be speakers at this conference. And of course, my colleague at work and my sister Sangeeta, thank you for being the catalyst and the igniting flame for making things happen. Most institutions come into being because there's a crying need in society for something which has to be done, and in our case, it's healthcare. But most movements happen because people come together to make a global change for the benefit of mankind, and I think that is why we are all here together. We come together because we are under the torch-bearing theme of Heal in India. We're all proud Indians, and for all our guests who've come from multiple countries, about almost 100 countries are represented here today in multiple formats. Please join us in the movement, because we have to heal in India, we have to heal for the rest of the world, and the boundaries don't exist anymore. With technology, with passion, I think we can make a difference in the way healthcare is delivered, not only in this part of the world, but for the rest of the globe. There are two very significant initiatives here. One is on patient safety, and the other is using technology to make healthcare accessible to millions of people, make it quicker, deeper, and faster. And I think the coming together of these two significantly, and this has been the 12th year, and there has been a sea change. Every 12 months, things have changed, and that focus and passion to make a difference is what counts for all of us today. Honorable Minister, I promise you that with the coming together of so many people from different countries, we will make you proud as a leader in India, but we will also make a difference for healthcare globally. And I think that is the challenge. That is the promise of today. So I would like to thank you all for your presence, welcome you to India, and say that together we will make the globe a better place for our children and our grandchildren and the rest of the generations to live in. Jai Hind, and God bless.
Thank you, ma'am. I would now like to invite Dr. Sangeeta Reddy, Joint Managing Director of Apollo Hospitals, to please deliver the keynote address. Please give a round of applause and welcome Dr. Sangeeta Reddy.
Honorable Health Minister of India, Shri J.P. Nadda ji, ministers from various countries across the world, leaders, scientists, educators, technologists, healthcare administrators, doctors, nurses, and people passionate about creating affordable, accessible healthcare for all. Namaste, good morning, and welcome. Over the last 14 years, we have got together every single year except for 1 year during COVID. We've got together to help make healthcare affordable, accessible, available, compassionate, proactive. And each day, every single conference, people have come forward to share their thoughts, share their successes, share their hopes and their dreams. This year we do it again. But this year I have something special to say, and that is, we come as individuals to share knowledge. May we go back together as a combined team to help transform, to help heal the world. Nadaji, we are grateful for your presence. We are grateful for everything. We realize that there is so much to be done in healthcare. Many people are denied care. We need to innovate on vaccines. We need to focus on proactive healthcare. We bring together PPP. We thank the government for everything that you have done towards science, towards Ayushman Bharat. 55% of our population is covered under this free healthcare scheme. We look forward to more and more innovations. We look forward to PPPs where we are working, the public and private are coming together to bring healthcare and to technology and innovation. If the AlphaFold could create a methodology where we can predict disease, we can help to treat disease, and the pace of what is happening, what used to take decades to do, is now happening in weeks. It is time for us to be equipped to seize the moment and seize this opportunity. It is time for us to bring ethics to the highest level in healthcare. It is the moment in time where scientists and doctors will stand side by side and include patients and public into this realm of healing. Continuum of care has a new meaning. Connectivity and telemedicine is an everyday thing. The telephone connectivity, the digital public goods, combined with the data that we have, can unveil. This is the moment in time where we can dare to dream of a disease-free world, or at least a world where everyone has affordable, accessible healthcare. This conference is dedicated to this dream and this vision. This conference is a culmination, and like I said in the beginning, we come here as individuals with capabilities. May we leave as a combined team with a shared and common commitment, because we can. I'm not going to say much more now because there is so much to be said. And our Honorable Minister, who has really kindly graced us with his presence, has a flight to catch. But over the next 2 days, we will share these thoughts. We will connect with every single one of you. We will be as open, as innovative, as proactive, and as creative as we can to bring leaderships together and to make this impact. The healthcare workers who do so much, who I honor every single day, to bring together people who are looking proactively at preventive healthcare, and to seek science, industry, and governments to all come together towards this brave new world. Let us work, as my sister said, to heal in India, to heal from India using technology, IOMT, artificial intelligence, and to heal by India. Our government has kindly given us 10,000 more medical seats this year and a commitment of 75,000 new doctors coming in. So this will become among the largest global workforce. Let us work together, harmonize degrees, and dream of this disease-free world. Thank you all for being here. Thank you for your partnership and your presence. Namaste and Jai Hind.
Thank you, ma'am. Please join me once again in extending a very warm welcome to our Chief Guest, Shri Jagat Prakash Nadda, the Honorable Minister for Health and Family Welfare and Chemicals and Fertilizers. Please give a huge round of applause to him. We are privileged to have him with us, and we are also privileged to have with us the Honorable Health Ministers of various nations whose vision and leadership continues to shape the future of global healthcare. I would request our Chief Guest, the Honorable Minister Shri Jagat Prakash Nadda, to please felicitate our international health ministers who have graced us with their presence. I request you to please give a token of appreciation to His Excellency Abdullah Nazim Ibrahim, the Minister of Health, Maldives. I would request the Honourable Minister to please felicitate His Excellency Dr. Frank Anthony, the Minister of Health, Guyana. I request you to please present a token of appreciation to His Excellency Maduduzi Matsebula, the Minister of Health, Eswatini. I request you to please felicitate His Excellency Pionini Ravunava, Assistant Health Minister, Minister of Health and Medical Services, Fiji. I would now request Dr. Preeta Reddy to please felicitate our chief guest, Shri J.P. Nadda, a dynamic leader who has played a pivotal role in shaping healthcare policies and governance in our country. I would request our esteemed dignitaries to please take their seats, and I would now humbly invite Shri J.P. Nadda ji to please address the esteemed gathering. Please give a huge round of applause to Shri J.P. Nadda.
Dr. Preeta Reddy, the Executive Vice Chairperson of Apollo Hospital. Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals. My colleague in the Parliament and my dear friend, Member Parliament, Shri Konda Visheshwar Reddy ji. Dr. Carsten Engel, the CEO of International Society for Quality in Healthcare. Dr. Jonathan Parlin, the President and CEO of Joint Commission Enterprise. Dr. A. Mark Harrison, the co-founder and CEO of HATCO. Shiv Kumarji, the MD of Indraprastha Apollo Hospital. Atul Kocherji, CEO NABH. Our special guests, Excellencies, Ministers from Maldives, Guyana, Eswatini, and Fiji, and virtually connected experts and healthcare professionals, friends from the electronic media and print media, ladies and gentlemen. Good morning to everyone. It is truly an honor to be here at the 12th International Health Dialogue 2025, which is a landmark event in the healthcare excellence. I extend my warm greetings to all the distinguished delegates participating from various countries, the visionaries from India across the globe. Your presence signifies the spirit of global cooperation in healthcare. This year marks a significant milestone as the International Health Dialogues, a unique platform bringing together 3 flagship healthcare events under one roof. First is the International Patient Safety Conference, driving excellence in patient safety and quality improvement. The second is the Transforming Healthcare with IT, leading to conversation on digital health and healthcare innovations. And the third is Healthcare Operations and Patient Experience, focusing on operational excellence and enhancing patients' experience. Together, these events reflect the future of healthcare, where safety, technology, and operational efficiency converge to shape a healthier tomorrow. This is more than a conference. As Sangeeta ji said, it's a movement towards transforming healthcare in India and globally. The Government of India is also inclined to promote healthcare delivery which is holistic, inclusive, preventive, promotive, curative, palliative, and rehabilitative. We advocate the use of technology and digital platforms with health sector to ensure access to high quality and affordable health care. Recognizing the transformative power of digital solutions,
Namaste and a warm namaste.
we have rolled out Ayushman Bharat Digital Mission, ABDM, to unify India's healthcare ecosystem. ABDM provides a unique Ayushman Bharat Health Account, ABHAC number, which is a hassle-free method of accessing and sharing health records digitally, registry of health professionals and health facilities, and a unified health interface which enable a variety of digital health services between patients and health service providers, including appointments, booking, teleconsultation, service discovery. The same way, under the ABDM, Ayushman Bharat Digital Mission, over 750 million Aadhaar ID cards have been created, and about 500 million health records have been digitally linked with Aadhaar IDs for seamless access to the health data. 360,000 healthcare facilities and 570,000 healthcare professionals have been registered. I am confident that this mission will bring about a huge transformation in healthcare delivery. Under the visionary leadership of our Prime Minister Shri Narendra Modi ji, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, ABPM-J, was launched in 2018 with an objective of achieving universal health coverage. It is the world's largest health coverage and health assurance scheme, offering comprehensive secondary and tertiary care hospitalization benefits up to 500,000 per family annually. Recently, the scheme has extended to include all senior citizens of 70 years and above, irrespective of socioeconomic status. More than 610 million beneficiaries, that is about 40% of India's population, are covered under the scheme. More than 86 million hospital admissions worth 1.19 trillion rupees have been authorized under the scheme. In addition to these initiatives, we are focusing on primary and preventive health care through a huge network of more than 175,000 primary health centers, which we call as Ayushman Arogya Mandirs, and which is health and wellness centers, under the National Health Mission also. The Pradhan Mantri Jan Arogya Yojana, along with the services provided under National Health Mission and other schemes of Government of India, have led to the decline of out-of-pocket expenditure in total health expenditure from 64.2% to 39.4% in the last 10 years. In alignment with these policies and programs of the Government of India, Apollo Hospital has been at the forefront of providing patient safety, clinical excellence, and healthcare innovation. From leveraging technology for better outcomes to ensure quality-driven patient care, Apollo is showcasing what future of healthcare looks like. India is fast emerging as the healthcare destination for the world through Heal in India. We envision a future where patients from across the globe choose India not just cost-effective treatment, but for world-class solutions. With our skilled professionals, robust digital infrastructure, and a culture of care, we are poised to lead the global healthcare transformation. Platforms like international health dialogues fuel this movement, driving conversations, innovations, and partnerships that will define the next era of patient safety and healthcare delivery. I thank Apollo Hospitals and the organizing team for bringing together such an esteemed gathering together. I also thank Dr. Preeta Reddy, I thank Sangeeta Reddy ji, and I pay my respects and regards to Dr. Reddy, who has been the pioneer in healthcare and patient care. Let us all together, let us build a future where every patient is assured safety, dignity, and world-class care. Thank you very much for giving me a patient hearing. Thank you.
Thank you, sir, for your enlightening address. I request all of you to please strain your eyes to the screen. We have a very special keynote address by Dr. Pratap C. Reddy, Founder Chairman, Apollo Hospital Group. I request all of you to please stay in your seats and please give a huge round of applause to our chief guest, Shri J.P. Nadda, the Honorable Minister of Health. I would request for the playout of the keynote address by Dr. Pratap C. Reddy, Founder Chairman, Apollo Hospital Group.
Namaste and a warm welcome. It's truly my pleasure to witness the 12th edition of the International Health Dialogue. Today, with all the distinguished leaders and change makers from across the world and India, I am honored to welcome our chief guest, Sri J.P. Nadda ji, Home Minister and Health, Family Welfare, Chemicals and Fertilizers. As an outstanding level, as an earlier Health Minister, the future of healthcare is truly collaborative, and the International Health Dialogue 2025 is a testimony to India's growing influence in healing not just India, but the world. Over the past 40 years, I've been personally working continuously to establish India as a global hub for healthcare, and I'm very grateful to our Prime Minister of India, Sri Narendra Modi ji, enabling India's bold vision for universal health access with Heal in India. The International Health Dialogue 2025 is a global movement where we will always come together to innovate, care for one another, and push the boundaries in showcasing our clinical and scientific excellence in healthcare. International Patient Safety Conference has grown to become Asia's largest platform dedicated to enhancing patient safety and quality standards. With this year's theme, a new era of patient safety, IPSC focuses on harnessing new technologies and global best practices to build a culture where safety is non-negotiable. I'm very happy to introduce HOPE, the Healthcare Operations and Patient Experience Conference this year, first of its kind initiative that will focus on how operation efficiency and patient experience must go hand in hand. With IPSC, THIT, and HOPE collectively representing the International Health Dialogue, we at Apollo are taking a strategic step towards integrated healthcare transformation. Patient safety cannot advance without digital innovation, and operational excellence cannot be achieved without embedding both safety and technology. This is what Apollo has followed from day one. I welcome you once again and will look forward to the engagement and deliberations over the next 2 days. Together, let us embrace our collective vision of heal in India and heal the world. I wish we all work together towards making the nation and the world a healthier, happier homes. God bless.
We have with us a remarkable leader whose contribution to global healthcare and patient safety are truly unparalleled. Please join me in welcoming Dr. Jonathan Perlin to this podium. I request him to please address the audience. Please give a round of applause to Dr. Jonathan Perlin.
Namaste and good morning. It's a privilege and an honor to be with you here today, and we're gathered together because we know that our goal is perfection and healthcare is imperfect. It's really in that spirit that I want to extend my gratitude to the organizers of this extraordinary conference, to Dr. Sangeeta Reddy, Dr. Preeta Reddy, Dr. Pratap Reddy, to the ministers, and to each of you for working to make health and healthcare more perfect. That's really the first of my 5 points this morning, and let me just summarize those, is that if healthcare is imperfect, it's also brutally complex, more so than ever before, clinically, operationally, financially, and in my country, politically. AI, point 3, artificial intelligence, is the defining technology of our century. It has the ability to create a step change, a quantum leap in performance. At the same time, AI, point 4, is not just one thing. AI is a set of activities that can really allow us to embrace that step change. And that leads me to point 5, is that as health leaders, as health policymakers, as regulators, we have both the responsibility to assure the appropriate guardrails for the best use of AI, as well as making sure that we, as those who care for patients, who work in healthcare directly, define the way in which regulation occurs so that we can really take advantage of the extraordinary innovation. Now, I do have a presentation. If the slides are available, we'll go to those. If not, I'll speak from it. But let me start by just defining that our Joint Commission International is really a very international organization with some degree of activity today in 86 countries. I'm proud of the new team that we've assembled. Dr. Neelam Dhingra is here with us. She is our Global Chief Patient Safety Officer. You likely know her from her role founding the Patient Safety Unit at the World Health Organization. Under her leadership, we're introducing new programs, not only the standard accreditation, but in lower resourced areas, a pathways program for capacity strengthening to learn from some of the extraordinary advances that are being made in countries like India. Our vision internationally is that all people always experience the safest, highest quality healthcare across all settings. It really alludes to both performance as well as inclusion. Our work focuses on safety and quality and health, but also on the tools of performance improvement and achieving excellence. Now, if healthcare is imperfect, let me share with you the magnitude of that imperfection. According to a study by Andrew Auerbach at the University of California at San Francisco, in the United States, 23% of patients who die or deteriorate in hospital where they're supposed to be safe, do so because of a missed or misdiagnosis. That's really extraordinary. That study is only a year old, and that's from an academic medical center. How complex then, point 3, is healthcare? Well, let me put this in perspective. When the telephone began to become popular in the United States in the 1900s, early 1920s, there was a study as to how many digits a phone number should be. And those people who were trying to advance this technology actually went to the psychological literature to look at the number of variables that we humans could manage simultaneously. Turns out that we can manage about 5 to 9 variables at the same time. So they chose the intermediate at 7. You probably know that to figure out the number of combinations of variables, you multiply the number of variables by every successive number before it. So for 7, it's 7 times 6 times 5 times 4. And I know that you've already figured out that's 5,040. Okay. According to Dr. Bill Stead at Vanderbilt, in the average ICU, there are 1,300 data points every hour. There are 1,000 new pieces of information based on the monitoring of a patient in an ITU, and there are about 300 orders in effect. How big, then, is 1,300 factorial? Is it a million? Is it a billion? Is it a trillion? Not even close. That number is the head-spinning number of 3.16 times 10 to the 3,485th power. How big is that number? I want you to imagine every grain of sand on a beach. Not even close. I want you to imagine every grain of sand on the planet. Not even close. I want you to imagine everything that you know about astronomy. That number is bigger than the number of particles thought to exist in the universe. I can handle 7 factors. I can't handle 1,300. This is where AI can really help us. The complexity of modern medicine has surpassed the capacity of the human mind. That per an article in the New England Journal of Medicine this past year. And AI, as I said, point 3, is the defining technology of the century. Has the ability to bring clarity to things that are unclear. Has the ability to help us in the simplest activities like remembering immunization schedule. It has the ability to help us improve on routine tasks that are complex, like reading mammograms. It has the ability to capture our work as a byproduct of care and create the medical record rather than making that something that we do afterwards. Has the ability, as is done in Apollo Health, to provide similar information to patient and clinician at the same time so they align on the best of care. Has the opportunity to advance the life sciences. Did you know it took 2 years of work to elucidate the structure of the binding site for the anti-HIV therapy? 2 years. Well, it actually took 1 year and 50 weeks plus 2 weeks. The last 2 weeks, they gamified the folding of the structure and crowdsourced from millions of people an answer to what the structure would look like, and it was resolved. It was the first protein to be resolved that way and create a new target for therapy. In the first 6 months of generative language models being broadly available, 6,000 new binding sites for new medications were discovered. So we have a number of burning questions. What should we use AI for? How should we pay for AI? How do we address liability? But moving to my point, how do we regulate artificial intelligence? In the United States, we've seen things go wrong, and we need guardrails to prevent the untoward occurrences. For example, a large insurance company in the United States created an algorithm to improve heart failure treatments for Black and African American patients. Instead of improving, it actually exacerbated the disparity in care. Why did it do so? It did so because there is a bias in the training literature. The data on which it was created embeds the disparity that exists in our United States society. It amplified that. On the other hand, in my own former organization, which was a large health system with 63,000 beds, we created an algorithm to spot sepsis earlier, and we won an award because it saved lives. And I want to come back to that because it's so important to have technologies of that sort. But if you will, imagine a bridge over rough waters. On the one side are the guardrails to prevent untoward occurrences. Or the other, and this is a fear for me in the United States, is a fear of overregulation, which stifles the innovation that's so desperately needed for the step change not only in clinical performance, but operational performance and the affordability of healthcare. There is so much latent data in the collective memory of all of our experiences. For example, think about blood pressure medications. The average patient in the United States will try 4 or 5 medications before arriving on one that works. What happens to the first 3 or 4? They get thrown in the trash. We cannot afford to throw medications in the trash. And it shouldn't be a matter of trial and error. Embedded in the collective memory of healthcare are the data that would link the genome of the individual patient to the likely clinical efficacy of the particular pharmacology. And we need to be able to look into that collective memory to harvest it for improvements in care. In a paper by Karen DeSalvo and Michael Howell, they characterized 3 epochs and I'm saying epochs carefully as opposed to epoch the EHR, but 3 epochs of AI. The first actually has existed since the 1950s, probabilistic models. They're really if-then statements. If the patient is hypertensive, then treat. And that doesn't really need a lot of overregulation. Epoch 2 is very interesting. It's the deep learning that's used to train machines to do things that are repetitive and prone to error. For example, training a deep learning algorithm on 100 million mammograms for use in reading mammography has already proven more effective than low-volume radiologists. Low-volume radiologists makes far more errors. But what's important here in Epoch 2 is that the use case for the technology, reading mammograms, is the same as the use case on which the technology was developed. What about Epoch 3? Well, this is really interesting. The first 2 are really pre-generative. When you get to Epoch 3, we're really talking about the OpenAIs, the Gemini, the DeepSeek, et cetera. We're talking about large language models, foundation models. And there, as happened with the misadventure with heart failure that I described at the outset of my comments, the model was used for something other than what it was trained for. It was trained on general information and used for a specific use case, and it ran into problems. And this is where I think we need to regulate more thoughtfully. And when we get to something not in the paper, but what I would suggest is Epoch 4, agentic AI, where the AI actually will do tasks autonomously, we likely need even more support. So imagine now a patient in an ITU with sepsis. Sepsis is sort of a final common pathway for total body failure, often in the face of overwhelming infection. In sepsis, the blood vessels become leaky and the oxygen doesn't get to the end organs and the body dies. How do we recognize sepsis? We recognize it because the body is dying. We recognize the pulse rate going up. We recognize that the oxygenation is going down. But by the time we see these things, the patient is dying. In fact, for every hour of delayed diagnosis, the risk of death goes up between 4 and 8%. Imagine if you could turn that clock back hour by hour. Well, you don't have to imagine. You know, we know what the clinical syndrome of sepsis includes, but in my former organization with 63,000 beds, we took all the data from the collective memory and we looked at things like transfers, and we looked at things like demographics of the patients, and we looked at pharmacy orders, and the machine found variables that were not intuitive to humans. And on top of what was measurably benchmark performance in 1 year alone, the SPOT model, sepsis prediction and optimization of therapy model, improved the detection of sepsis by 23%. Well, let me tell you what that meant in some very real ways. Before that program, if you actually plotted on a 24-hour graph when sepsis was detected, it was detected at shift change. Now, sepsis, of course, doesn't happen at shift change. Sepsis happens all the time. But prior to the algorithm, the time where the data were put together was at shift change. And when you looked after this model was put into place, sepsis was detected around the clock, and the gain in time was between 4 and 6 hours. And for a syndrome where mortality increases by 4 to 8% every hour, this improved survival dramatically, a 23% improvement. Well, 23% is a number. In 18 months, that saved 8,000 lives. 8,000 people who got to see in a new year. 8,000 people who maybe celebrated an anniversary, welcomed a child or a grandchild, spent time with loved ones. We need to make sure these technologies are available. We also, point 4, need to make sure that they're used responsibly. And what is it we want in terms of the responsible use of artificial intelligence? Well, as patients, we likely want some agency over the use of our data, knowing that our information is private. Freedom from bias, as in the heart failure example, and some external verification that those conditions exist. Why? So that individual health care and population health are both improved. And so our responsible use of health data certification, which will grow into an AI certification, includes 6 elements. De-identification to assure privacy, data controls to assure security, limitations on use so that data are not monetized without some disclosure, transparency to the patient. But the 2 most important parts are not just the algorithm verification, but also a governance process. That governance process needs to have 3 components. The first component is an ability to assure that the algorithm is technically appropriate, that the mathematics are correct. Part 2, the algorithm needs to assure that the clinical knowledge is correct, that there's domain competency, for example, in heart failure. And perhaps the most important part is that there needs to be cultural competency as well, so that one can recognize and assure that there is freedom from bias and that the algorithm can be used well. So what kind of regulation for Epoch 1? Probabilistic, if then. Very, very light. If hypertensive, then treat. For 2, deep learning, like the sepsis model. I would say light as well. The use case is very similar. But when you get to full-on generative AI, Epoch 3, I would suggest that that governance process is absolutely critical, assuring that those 3 assessments are there, and certainly for agentic. In the United States, we've been the center of convening conferences on AI, and our Congress is very interested in the use of AI, both in terms of helping to prevent untoward events, but most importantly, to help us accelerate innovation and improvement. As Albert Einstein said, the level of thinking we have done thus far creates problems that we cannot solve at the level of thinking that created them. And this leads me to point 5, and my final point, which is that we as leaders have both the responsibility to assure the responsible use of health information, but even more, and Drs. Reddy, as is so apparent here in India, we need to be the agents of change because, as I said at the outset, and as you know, healthcare is imperfect, and even if we never reach the goal of perfection, the only right level of harm, avoidable harm, is 0, and we need to be those agents of innovation and change. And it's in that vein that it's such a privilege to be with all of you, and thank you for your innovation, for your leadership, and your passion for our shared mission for improved healthcare. Thank you so very, very much.
Thank you for illustrating for us the astounding capabilities of AI in healthcare. We are honored to have with us a visionary whose expertise and dedication have made a profound impact on the advancement of healthcare standards worldwide. Dr. Carsten Engel, Chief Executive Officer, International Society for Quality in Healthcare, ISQUA. I request Dr. Engel to please address the audience with his keynote address. Please put your hands together for Dr. Engel.
Namaste. It is an honor and pleasure for me to be able to speak here to you today. Patient safety. We are still not there. We are not at a point where patient care is as safe as we would wish it to be, as it can be, but we are at the point where we are able to create a roadmap on how to make it happen. For what is the problem? Is the problem that we don't know how to improve safety? No, we know a lot actually. How do I change the slide? Okay, as a very high level roadmap, we have the WHO Global Patient Safety Action Plan 2021 to 2023. I think there has been a little bit confusion about the slides, so I'll talk a little bit more freely. A recent report from the WHO demonstrated the point I made at the beginning, that we are not there. It's still the case that 12% of patients experience harm across medical care settings. As much as 12% of adverse events cause permanent disability or patient death. Unsafe care causes more than 3 million deaths every year, and around 2/3 of them occur in low and middle-income countries. Is the problem that we can't afford patient safety? I would say the data say that we can't afford not to. I would have shown you a graph of the world gross product from 2000 to 2021, and you will see that the actual product is 15% less than it would have been expected to be if there had been no medical harm. From year to year, the loss may seem moderate, but it accumulates to a very large loss over a period of years. So, we have this high-level roadmap on how to achieve a more safe care, the WHO Global Patient Safety Action Plan. It's a set of 7 strategic objectives, each with 5 actions, which leads us to 35 strategies that we should improve, and there are actions described in the patient safety plan at all levels of healthcare, at national level, at facility level, for stakeholders and for the WHO Secretariat. So, how are we doing in relation to this excellent roadmap? Well, not too well. You can see it on the slides that's actually on the screen now. It's from the WHO report on the World Patient Safety Status 2024. Notice that the outer limit of this radar diagram is unfortunately not 100%, it's just 70%. So there is still a way to go. Actually, strategic objective number 3, safety of clinical processes, is performing best, but still far from perfect. In the report, you will see data for all 35 strategies, and it's summarized across each of the WHO regions. As expected, there are regional differences, but no region has met the targets, and even in wealthy regions, there are strategies where the score is only on a basic level, less than 4 out of 10. Now, I come from ISQA, and I would like to show to you some ways in which ISQA works to bridge the implementation gaps. One of the principal aims of ISQA is to support accreditation, a tool that we know is a very important and effective tool for safety management, but we have other offerings as well. We established a patient safety task force, a group of experts in 2024, at the suggestion of the WHO Patient Safety Flagship. The task force establishes 1-year actions plan and is now close to completing the first year. Uniting for Safety is a coalition of organizations who all work to promote and improve patient safety and realize that identifying and collaborating on some shared priorities, aligning without competing, would provide mutual support, increase advocacy, and accelerate global progress. The priority for the first year of this Uniting for Safety coalition is measurement of patient safety impact. We know too little about this, but as you can understand from the speech Dr. Jonathan Perlin held to you just a moment ago, AI offers us a very good opportunity to increase our knowledge significantly so that we really know where we are and how we progress. And finally, we have some education offerings as well. We have the ISQA Fellowship, and in India we are perhaps best known for the webinar series that we offer in cooperation with CAHO. Back to accreditation, we mapped the alignment between the 35 strategies of the Global Patient Safety Action Plans with the standards that follow the ISQA principles for accreditation standards, and for 21 of the 35 strategies there was an alignment, and the remaining 41s on largely strategies that are not likely to be, where accreditation would not be the right tool to support them. So accreditation is one way you can locally use to help follow the global roadmap of the Global Patient Safety Plan. Accreditation supports prudent standardization and in addition guides the establishment of a framework for promoting safety, because safety promotion now is very much a question about leadership. We know what we should do, we need to know how we can make it happen actually. And this framework includes strong common aims, goals and values, clarity about responsibilities and accountabilities, and a strong framework to support team building, teamwork and team training. You can't create a survival guide, a book that will tell you how to do everything. Prudent standardization, I like to compare to having a good toolbox. That it must allow you to be flexible and adaptable when needed. You can't capture safety into a rule book, but if you have a well-equipped toolbox, you will be able to pick the right tool for the right situation. You will be able to adapt and adjust as needed while understanding what you can and should adjust and what you should definitely not adjust. Accreditation has been around for a long time, and in ISCO we are aware that accreditation needs to develop and to have and we have initiated a process to allow our international accreditation program, which is a kind of umbrella program for healthcare accreditation, to support and guide the development towards accreditation 2030. Not to replace everything that has worked well until now with something else, but to use a spectrum of approaches for different purposes. Standards should not just be a compilation of criteria that characterize a well-performing organization, but they should also set an agenda to achieve a defined aim. If something is written in a standard that will become an assessment against, it will surely be on the agenda. Examination of processes for compliance with requirements will be played down, while processes will instead be examined to understand why outcomes are as they are. Judgment will be based less on process compliance and more on outcomes, and reporting will focus on mechanisms rather than on mere tick-box style compliance. Instead of telling you what you should do, standards and the entire accreditation process will help you achieve what you want to achieve. The classical survey methodology will continue to be used, but more data sources, including quantitative data from a broad range of sources, will contribute to assessment, and no doubt AI will revolutionize the way in which we perform accreditation. Now a little bit back to the Patient Safety Task Force. We will soon publish a white paper, and the lead author is, by the way, Dr. Anuradha Pichumani, who is with us today. It is intended as a guide to guide on a facility level how you can translate the action plan into a roadmap for your own organization and facilitate what's happening at your own organizational level. Of course, there's no magic bullet that will achieve patient safety. You need a multi-pronged approach. You need prudent standardization, as I told you about, but as you need to leverage human factors, science to design safe processes, leverage the power of teamwork including teamwork with patients and families, build a culture of safety, build a resilient system. In complexity, you cannot have a pre-programmed, surely working system. You must build it up to be resilient, but of course with fail-safe components wherever needed. Co-produce safety with patients and families, improve using principles of change management and implementation science. That's something you should really be concerned about, but because change is not just a technical intervention, it is about making people change their ways, their beliefs, their habits. And of course, you should leverage technology, including AI. You have heard a lot of this already. AI can we know about a lot of AI-based tools that can improve clinical processes, but AI will improve risk management, quality management as well. We can identify errors and anomalies in real time. We can provide personalized and accurate predictions and preventions, early detection of adverse events, and we can improve, just a small but important thing, we can improve measures based on medical chart reviews. But of course, if we overly enthusiastically adopt AI-based applications that have not been sufficiently evaluated, there is a risk. We know that AI-based tools are prone to bias, hallucinations, and we need to ensure that the interfaces between the AI and the professionals and the patients will be using AI as well, is important. And of course, there are considerations of values and ethics. So we need good digital health governance. It's actually not different from clinical governance in other domains. We need direction with long-term goals, a framework of assessment, costing, implementation, monitoring and evaluation of use, involve staff and patients at all stages. Be sure to leave no one behind. Make sure that there's accountability. And while AI has a tremendous potential, it's not about automation, it's about collaboration between human and AI. And with this, I will conclude that a learning healthcare system is the road to safe care, and AI and a lot of tools will help us to become that. Thank you.
Thank you. Thank you for reinforcing the foundation pillars of patient safety. We are very honored to have with us Dr. Vinod Kumar Paul, Member Niti Aayog. I would request him to please come up on stage. Please give a round of applause and welcome on stage Dr. Vinod Kumar Paul, Member Niti Aayog. Right. We are deeply honored to welcome an extraordinary leader whose vision and commitment have transformed healthcare worldwide. Dr. A. Mark Harrison, co-founder and CEO, Health Assurance Transformation. Please give a round of applause and welcome Dr. Harrison. I request him to please give the keynote address.
Good morning, everybody. I'd like to express my deep thanks and gratitude and admiration for the Reddy family and for what they've put together here today. I think the idea that we're combining IT and safety and quality is exactly the right thing for this world at this moment. I'd like to sort of make my remarks extremely conversational with you. And I'd like to tell you a story, and I'd like to tell you a story about how my career and journey have evolved. And I think that will help you understand exactly why all of you are in the right place at the right time. Our world is at an inflection point, healthcare is at an inflection point, and you are the key players in changing things for India, but for the rest of the world as well. So I'm a simple doctor. I am a pediatric ICU doctor who had the privilege of serving in some good systems and taking care of lots and lots of kids. And I'm a person who's impatient, and I'm a person who seeks goodness for the people I care for and the people I work with, and as such have made change wherever I've gone. My path led from the bedside, hundreds and hundreds of nights sitting at the bedside of critically ill children, into executive leadership, not because I sought executive leadership, because I was impatient for change for the ones I could serve. And I could see the gaps that they experienced, and I could tell the pain that their families suffered when we didn't live up to the standards that they deserved and expected. That path led me from the bedside to an executive suite at the Cleveland Clinic, and from the executive suite at the Cleveland Clinic to Abu Dhabi, where I was privileged to be the founding CEO of Cleveland Clinic Abu Dhabi. There, I had an epiphany and an experience where I began to experience the diversity of the world in an incredibly powerful way. And I could see amongst the 70 different countries that our caregivers represented that the commonality for all of us was around our passion for healing our fellow human beings. From Abu Dhabi, I went to London and began to work on another project there and had exposure to the NHS in a very deep way and could see the desire and the power of the payer-provider model, yet all the imperfections associated with that great system. From London, I went to Intermountain Healthcare in the Western United States, famous for safety and quality, famous for operational excellence, but limited in terms of scope and geography. There, we went from a single state of care to 7 states, and we went from a revenue of about $5 billion to about $15 billion in a period of 6 years. More importantly, we went from average safety and quality to top decile safety and quality in just about an 18-month period of time, proving to me that it was possible, if we played as a team, to do extraordinary things for patients. We sought to make each person a story. When we reviewed safety and quality at Intermountain Healthcare, and we put graphs up, what I asked is that for the patients that we harmed and killed, we put little tiny figures of humans. I wanted each and every person to understand that when we made an error, it was a family that we impacted. It was a patient that we impacted. I became both inspired and frustrated by the application of technology at our system. I had the privilege of leading through the pandemic. I had the privilege of working as a large multi-state system to make sure that people had access to clinical trials, excellent clinical care, as well as an opportunity to take care of our own caregivers. What I found is amongst the 60,000 people who worked for me, we lost twice as many caregivers to suicide as we did to COVID. Why was that? People were exposed to death and destruction at an almost military scale. They were stuck in very difficult situations with angry patients and in some cases an angry society that didn't support them and led to their burnout. And we discovered that technology, although important, was imperfect. So coming out of the pandemic, I began to take stock of the headwinds that we faced, and I believe these are the same headwinds that you're facing right now. They're the fatigue of our healthcare workers. The system is brittle, and little bumps in the road, whether it's a supply chain problem, whether it's inflation, whether it's workforce shortages, all amplify to create a system that's very difficult to navigate for you and for me and for everyone we're meant to serve. That lack of coordination leads to some of the bad outcomes that Dr. Perlin discussed. Let me give you an example. I had a good friend, a gentleman who had a family history of pancreatic cancer and a known genetic predisposition for him to have it as well. He sought out the very best medical care that he could afford and that he could find, and he was told that he should have imaging of his belly every 6 months in addition to getting blood work drawn. He did exactly what he was told. He was at a great institution, a famous academic institution, and they said he was fine. One day, he developed jaundice and back pain and went in and discovered that he had massively metastatic pancreatic cancer. This is a gentleman who had 3 beautiful kids and a loving wife and a good career and was making a difference in the world. When we went back and had his studies looked at again, it was discovered that the radiologist had missed a small 1 centimeter mass in the tail of his pancreas that should have been completely resectable if in fact he had had an AI overread of the study. And his children, unfortunately that did not happen. He rapidly decompensated, he died, and he left his family alone. What we know is that technology can make a big difference. But what we also know is that point solutions and single apps don't really help. They provide increasing discontinuity and expense in healthcare, which is exactly what we don't want. So, okay, here we are at this moment. We have all the headwinds that I described, expense, workforce shortages, etc. But we also have a moment in time where everything is coming together so that we can all make a difference. What do we have? We have massive computing power. We have huge amounts of data. We have algorithms that can allow us to make sense of data in a way that we've never had before. And we now, and I know you're going to hear about it over the next couple of days, the opportunity to create agents, nurses, doctors, other professionals, who can assist our human caregivers and provide that one-on-one care to make sure that things don't get missed. Let me give you an example. There's a company that I work with that we've helped create. It's called Hippocratic AI. It has ingested the data of 12 large health systems and created assistants who can actually care for chronic care patients. These people can explain, these entities can explain laboratories, they can explain care pathways, they can make appointments, they can provide next steps for patients, and instead of a human who would cost, in our world, about $90 or $100 an hour to hire and support, it can be done for 19 cents an hour. Every single one of us can and should have people, have entities, have tools that allow us to have really great coordinated healthcare. Why is now the moment? The moment is important because we recognize in very stark ways that our system is failing those that we're meant to serve. I don't believe that Dr. Perlin mentioned, but about 10 years ago when the American healthcare system looked at how many patients per year were killed from medical errors, it was around 100,000. Recent data suggests that despite all of our hard work, it's now 200,000 people a year die. I suspect many of the same issues plague Indian healthcare. Now is the moment for us to show the humility, to change our operations, to lead with heart for the people we serve, to incorporate technology fully into everything we do, and maintain our humanity in an effort to make healthcare accessible, affordable, equitable, and to provide hope for people. Let me speak to you very directly as leaders. It's absolutely 100% clear that organizations do what the CEO or the boss says to do. Where you spend your time, where you use your words, where you put the emphasis, that's where your organization will go. And I suspect in this large room, there are millions and millions of people who are following you. If you tolerate poor performance, inhumanity, lack of forward progress, your organizations will as well. On the contrary, if you lead with courage and you act with courage and you act with humanity, your organizations and those millions of people will follow. I'd like to finish with a very short Arabic proverb, and what it says is, he who has health has hope. And he who has hope has everything. The everything for the 1.3 billion people in India and the rest of their neighbors around the world are in your hands. And my call to action for you is to lead that change. I look forward to seeing you at the conference. Thank you very much.
To formally extend our vote of thanks, I now invite Mr. P. Shivakumar, MD, Indraprastha Medical Corporation. I request him to please address the audience. Please put your hands together for Mr. P. Shivakumar.
Honorable Health Ministers on the dais, Joint Managing Director, Apollo Hospitals Group, Ms. Sangeeta Reddy, Jonathan, Mark, and Karsten, and others on the dais as well as on the audience. It's my absolute delight to stand before you and propose this vote of thanks and heartfelt gratitude on behalf of Apollo Hospitals for the Honorable Union Minister's presence earlier in the meeting and for his inspiring words to all of us to make India a very, very strong, healthy nation. I'd also like to extend my sincere appreciation to all senior dignitaries, policymakers, esteemed representatives from various governments across the world, healthcare institutions and regulatory bodies. Your support, participation underscores the shared vision we share to place patient safety at the forefront of healthcare. A special note of gratitude to my senior leadership in Apollo Hospitals, our chairman, Dr. Reddy, and Ms. Sangeeta, Joint Managing Director, Vice Chairperson, Ms. Preeta, Ms. Sunita, the Managing Director, and Ms. Shobna, for their continued efforts for spearheading this crucial dialogue year after year. The unwavering commitment to advancing patient safety and fostering meaningful discussions has been instrumental in pushing the boundaries of healthcare excellence. I'm sure all of us will find implementable solutions from the conversations that we are going to have today and tomorrow, and making tangible improvements that benefit every patient we serve. Thank you very much. Jai Hind.
Thank you. Please give a huge round of applause to all our esteemed dignitaries on stage. Thank you so much for your enlightening words. They do set a perspective for the conference of the day. We will continue with our session on global perspectives on digital health in this hall. The delegates who are attending the Patient Safety Conference are requested to move to the hall next door where the conference continues there. And we are very delighted that we have with us our distinguished guests of honor, the health ministers from Maldives, from Guyana, from Eswatini, and from Fiji. We request you to please remain seated. And I would like to invite on stage Dr. Vinod Kumar Paul, member Niti Aayog, who is also going to be part of this keynote panel on global perspectives on digital health. I would request Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group, to please welcome Dr. Paul with a token of our appreciation and felicitate him.
Good morning, everyone. May I request delegates of International Patient Safety Conference as well as HOPE Conference to please move to the plenary hall. Entrance is just the next door from either this level or you can also go from level 4. Thank you.
Right, we'll just give 1 minute for everybody to settle down. And we thank our distinguished guests who have addressed the audience. And if they wish, they can, of course, take their seats off the stage. But we request the Honorable Health Ministers from Maldives, Guyana, Eswatini, and Fiji to remain seated along with Dr. V.K. Paul. We are very privileged that we have global leaders in healthcare with us to discuss the evolving digital health landscape, where innovation is making a sustainable impact beyond the initial excitement and hype. Right. I would request Dr. Sangeeta Reddy to please felicitate Dr. Vinod Kumar Paul, Member Niti Ayog. We are very grateful to Dr. Paul for coming here, and we look forward to hearing his views on the global perspectives on digital health moving beyond the hype. Thank you, ma'am. A relentless advocate for digital transformation in healthcare, Dr. Sangeeta Reddy has played an instrumental role in shaping policy, fostering innovation, and ensuring that healthcare solutions remain patient-centric and accessible. I would request Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospital Groups, to please steer this discussion forward.
Morning, ladies and gentlemen. Let me begin by thanking all of you. I know many of you were disrupted by traffic. We had a lot of VIP movement. It was an early start. You've traveled long distances. You have, really been a part of this movement. I want to begin by saying a big namaste and a thank you. It's also my pleasure and privilege to be able to share the dais with health ministers from our neighboring countries. Let's give them a big hand. This session is also a very special session made so by the presence of Dr. V.K. Paul, our Member of Planning Commission specializing in health. His thoughtful nature, his deep insights, his passion for healthcare, and his ability to go straight to the point and call out what needs to change. Dr. Paul, we respect you. We thank you for your contribution, and we're very, very happy that you're here. I have the honor of calling upon ministers from various countries to request their insights, their thoughts. Your Excellencies, India looks to be a partner. India looks to share what we can in terms of knowledge. And we look to collectively come together for a safer, healthier world. We have gathered here experts from across the world because every single person here cares. I want to begin with a story. And this is a story many of you may have heard. And I think it's also coming so much to the forefront. Some of our guests are from Los Angeles, where there should not have been fires, but they were. So there was a large forest fire. And the bears started running, and the tigers ran, and the jaguar ran. And then the jaguar saw a hummingbird flying towards the fire and said, "What's happening?" But the jaguar kept running away from the fire. And then the hummingbird flew again away from the fire. And the jaguar saw the hummingbird fly back to the fire. He saw this 5 times, and then he said, "Hummingbird, what are you doing?" And the hummingbird said, "The forest has nurtured me. The forest has taken care of me. The forest helped me grow. How can I stay away when the forest is burning? I'm going to the lake and carrying water in my mouth and helping to put out the fires. Could the little hummingbird handle the enormity of the forest fire? Probably not. Can each one of us individually handle the enormity of global healthcare? Probably not. And you may think that we're saying at least, they helped a little. But actually some magic happened. Because the gods or the spirits or the forces that exist saw the effort of this tiny hummingbird, saying, I must do my part. The gods sent torrential rain. The fire stopped. This is the power that when each one of us steps forward to do our part, we can create change, whether directly or indirectly. Magic will happen. So that is your collective power. Please let's come together to make magic happen. That's what we're here for. Let each one of us do our part towards a safer, better, more evolved healthcare system. Let us use our data. Let us integrate our systems. Let us talk seamlessly. Let us focus on preventive, proactive healthcare. Collaborate with scientists. Push forward the path of new cures. Be empathetic and understanding of the pain of not just the patient, but the entire family. And change every pathway possible to not just cure and heal, but to prevent disease. There's a brave new world out there that all of us are creating together. That's what this conference is about. Thank you so much for being here. During the next 36 hours, you will hear about artificial intelligence. We will talk about ethics in its use. You will understand the pace of change and of evolution of artificial intelligence in clinical work, AI across the realm. But the fact that if the data is skewed, if the ethics are not appropriate, if the model is not explainable, if it is not sustainable, and we will find solutions. You will hear about science and technology and pathways and dashboards and analytics. You will understand that all of us together can make that change, and each one of us are a part of this collective future. We will focus on preventive healthcare in a way that we have never done before. But most importantly, we will understand global workforce shortages, new pathways, care enablement, operational efficiency, and methodologies to bring change. I want to take a minute to thank all the people who have helped put this together, all our sponsors and all our partners, and then call first to the dais to speak His Excellency Abdullah Nazim Ibrahim, the Honorable Minister of Health for Maldives. It's a beautiful country, and this minister has been instrumental in advancing Maldives' healthcare system. Born in Hinavaru, he pursued higher education in the University of Auckland. His career in public service began as the Deputy Minister of Education, and we know that education is so critical to healthcare. Thank you, sir, for being here. In recognition of his leadership and commitment, he was appointed the Minister of Health in 2016, a role he has held. And now, after serving as the Principal Secretary and the President on Public Policy, His Excellency Abdullah Nazim Ibrahim, may we please hear from you. Thank you, sir. Please come to the desk.
Bismillahir Rahmanir Rahim. Good morning, everyone. It's a privilege to address you today on a topic that is significantly influencing the future of healthcare, digital health. I am grateful to Apollo Hospital Group for organizing this event. Such collaborations are essential as we navigate the challenges and opportunities of digital transformation in healthcare. We all know that global disease patterns are constantly evolving with an increasing burden of non-communicable diseases posing significant challenges. The way forward to sustain quality healthcare will heavily depend on embracing technology right from preventive health to diagnosis to treatment. The COVID-19 pandemic underscores the importance of digital tools such as telemedicine, electronic health records, and AI-driven analytics in ensuring uninterrupted healthcare delivery. Today, digital health presents an unprecedented opportunity to create a safer, more efficient healthcare system worldwide. Digital technology has always brought forward the opportunity to introduce higher reliability systems that help address human errors which are persistent in our health system. South Asia is also embracing the benefits of digital solutions with the increased adoption of telemedicine and virtual care. While the Maldives is a small island nation, our commitment to digital health is ambitious and forward-thinking. Under the esteemed leadership of His Excellency President Dr. Mohammad Moise, the government of the Maldives is fully committed to leveraging technology and enhance healthcare system and improve healthcare delivery. Today, I am proud to announce we are getting ready to unveil the Maldives Digital Health Blueprint, a visionary framework designed to leverage technology to bridge healthcare gaps, improve access, and enhance patient outcomes. This blueprint is more than a policy document. It is a comprehensive roadmap outlining the development of a federated digital health architecture, ensuring interoperability across public and private health facilities. It introduces person-controlled personal health records, empowering individuals to manage and securely share their health data. A national telemedicine initiative set to be fully operational within months will ensure equitable access to healthcare, especially to remote island communities. Meanwhile, we already introduced digital platforms for primary healthcare, vaccination, and electronic health records on a live course platform. With these initiatives, the Maldives is positioning itself as a regional leader in digital health among small island developing states. While digital health offers immense potential, we must also acknowledge its challenges. Data security and privacy remain paramount. Patients must have full confidence in the confidentiality of their medical records. This necessitates strong cybersecurity frameworks, continuous system monitoring, and regulatory oversight. Moreover, technological errors, software vulnerabilities, and algorithms biases must be rigorously tested, validated, and monitored. As policymakers and global health leaders, we must work collaboratively to ensure the digital transformation enhances rather than compromises patient safety. Another critical issue is the digital divide. We must ensure that no one is left behind in this transformation. Digital health solutions must be tailored to local contexts, ensuring they are affordable, user-friendly, and accessible to all, regardless of socio-economic status, geography, or technological literacy. Moving forward, we must embrace a proactive, collaborative approach. To maximize the potential of digital health, we need to develop robust regulatory frameworks that foster trust and accountability, invest in research, innovation, and capacity building to empower healthcare professionals with digital skills and promote global interoperability, ensuring seamless data exchange across borders while maintaining stringent data protection measures. We look forward to strengthening partnership with India and global stakeholders to accelerate progress and share best digital health practices. I would like to once again thank you for Apollo Group for providing this opportunity and taking this proactive initiative. Thank you very much. Have a pleasant day. Wassalamu alaikum wa rahmatullahi wa barakatuh.
I'm honored to call upon His Excellency Dr. Frank C.S. Anthony, Minister of Health, Guyana. Frank Christopher Stanilis Anthony has been serving as Guyana's Minister of Health since August 2020. He earned his medical degree from the Russian People's Friendship University in Moscow and a master's in public health from the Hebrew University in Jerusalem. He has a distinguished career in public health. He has served as the Executive Director of the Health Sector Development Unit within the Ministry of Health, where he managed significant healthcare reform. His political career includes a tenure as the Minister of Culture, Sports, Youth, and he has been instrumental in advancing Guyana's healthcare system, particularly enhancing public health policy and administration. Your Excellency, we're honored to call you on stage.
Thank you very much for that warm introduction, Dr. Reddy. First of all, allow me to thank the Apollo Group for this invitation to be here and to thank all the other organizers who have helped us and keep the hospitality here has been fabulous. I want to first start by extending warm greetings from Guyana. For those of you here in India, you might know Guyana because of our cricketing heroes. You might know of Clive Lloyd, Rohan Kanai, Alvin Kalicharan, and more recently, Shivnarayan Chandrapal. They're all from Guyana, so if you didn't know where Guyana was, now you know. We share that passion of playing cricket, and I think that's one of the games that unify us all together. But I think in recent times, there are other new avenues in where we can get together. And that is, we share a passion for bringing our countries together. And more recently, we were extremely honored to host the Prime Minister of India in Guyana and the External Minister in Guyana. And with their visit, we have been able to sign a number of agreements in different sectors, but more importantly, we had several agreements that were signed in health. Guyana now recognizes India Pharmacopoeia, and we hope that with increasing collaboration, that we can look forward to collaborating in the area of digital health. Over the last 4 years or so, Guyana has been undergoing a massive transformation in its healthcare industry. We, as a country, as a small country, the government of Guyana provides approximately 90 to 95% of care for the population of Guyana. And we want to make sure that our population can have access to care across the country. It doesn't matter where you live. And we believe that digital health is one way in which we can improve that quality of care. We have started out over the last 3 years by improving digital health legislation. We have passed legislation dealing with data protection and protecting patients' information. And having passed that piece of legislation, we are now in the process of ensuring that we roll out a national electronic health record system. So by March of this year, we have a company that we have partnered with from the UK that would be assisting us in rolling out our electronic health records. We have also recognized that if we're going to do this, that every person in Guyana would need a unique identifier. And so that's a system that we have created. So with the new electronic health records, that we'll be able to roll this out seamlessly. Apart from that, one of the things that we've been working on is to extend care. And we started a project about 2.5 years ago of using telemedicine. Currently, we have 84 sites in and around Guyana, and already with those sites, we're seeing the benefits of having telemedicine because we can offer at these various sites teleconsultations, but apart from that, we can do various forms of diagnostics. So a village that is perhaps maybe 600 kilometers away can connect with one of our hospitals and get guidance from maybe a consultant or a doctor there so that they can help with the interpretation of ECGs or do an ultrasound and they can be guided. And if there's a need for us to do a med evac for that patient, then we are able to do that seamlessly. But telemedicine has helped us to improve care, especially in our rural communities. We're also using telemedicine in some very specific applications. So for example, last year we introduced telepathology, and one way in which that has helped to improve care, prior to introducing telepathology, it used to take us maybe about 3 to 4 months before we get the results from a biopsy sample. Now we have reduced that waiting time between 3 to 7 days. So this has improved care tremendously, and we are hoping that maybe we can partner with persons here who might be able to provide us with the analytics for telepathology. Right now we are using some providers in the US, but we are open to exploring other partnerships. We've also been digitalizing our imaging, and with the digitalization of imaging, we want to use AI to do the interpretation. We've heard a lot this morning about the use of AI and its applications, and we know that in India you have several systems here that can at least help with the interpretation, or maybe in the first read be able to take out those that are normal so that the radiologist can focus on those with pathology. And by doing that, we can improve the rapidity with which we can offer quality care. So teleradiology is something that we want to expand, and we are hopeful that we can have some collaboration in this area as well. We also have been using teleophthalmology, and again, I'm sure there are different types of systems that can help us to read these better. As we improve digital health in Guyana, one of the things that we want to do for our citizens is to make sure that everybody would have an app on their smartphone. They'll be able to use that app to make appointments, and when they go in to get those appointments, instead of having to wait a protracted time before somebody finds your paper record, they can use the app to pull up their records so that the providers would be able to get access to those records quite quickly so that you can be seen in a timely manner. So we are in the process of implementing this, and once this is implemented, we feel very confident that this is going to improve the efficiency with which we deliver care. Guyana right now, what we are trying to do is to make sure that we can deliver world-class health care to our citizens, and that is why we are making these investments in various aspects of care. Right now, we are in the process of building 12 new hospitals, 6 of which would be completed this year, and we'll be using digital health to make sure that we run these hospitals as efficiently as possible. So our presence here today, apart from sharing our experience, and I look forward maybe in some of the sessions to be able to do that, what has been our experience so far, because we are still learning and we are still developing systems. So what has been our experience so far? And we look forward to learning from you and other partners who are here about your experiences. And rather than reinvent the wheel, we want to take the best practices, the good practices that you might have, so that we can incorporate it into what we are doing in Guyana. We have already made a digital health strategy for 2025 to 2030. So we are in the process of implementing that. And right now we are currently working on an AI strategy in health. And once that is completed, we'll start its implementation. We have several partners that we have been fortunate to work with, and they've all provided us good guidance, but we hope that our presence here, that we'll be able to extend the network of partners and work with you so that we can provide better care to our citizens and also better care to the citizens of the Caribbean. Thank you so much.
Very happy to call upon His Excellency Matsibula, the Honorable Health Minister of Eswatini. Eswatini's Ministry of Health, he has helmed since November 2023. His career in public service is over 17 years, and before transitioning into politics, Minister Matsibuli holds a Bachelor of Commerce degree from the Regents Business School and a diploma in fraud auditing and forensic accounting from Cambridge International College, a diploma in auditing as well. He has been re-elected, first elected in 2018, re-elected in 2023, and under his leadership, the ministry is focusing on improving health infrastructure and accessibility. It includes plans to establish the country's first public radiotherapy center to treat cancer patients domestically. Honorable Ministers, we have in the audience many members of technology providers. There are service companies, there are solutions provision. His Excellency from Ghana was speaking about the appointment booking system. This is something we've been doing for a while now. So we'll be happy to invite all of you to please join us during the lunch session at the exhibition hall as well. There are over 300 exhibitors, multiple solutions available, and therefore we really look forward to sharing some of those with you. Thank you for traveling so far. Once again, ladies and gentlemen, our privilege to have in our midst the Honorable Minister of Eswatini, His Excellency Naduzi Matsibula. Please give him a big hand. Please come.
Program Director, allow me to write on the protocol already observed. My name is Naduzi Matsibula. I bring with me warm royal greetings from the Kingdom of Eswatini, a small country in Southern Africa between Mozambique and South Africa, with a population of about 1.2 million. It is an honor and privilege to be part of this gathering, and I value and appreciate the opportunity given to me to share and learn best health practices for better healthcare outcomes. On the subject matter, I will share Eswatini's experience or current position as instructed. It was in 2011 when the government of Eswatini embarked on a journey of establishing and implementing an e-government strategy which expects all ministries to incorporate information and communication technology in their daily business. The Minister of Health took the initiative to introduce the e-health in Eswatini in accordance with the World Health Assembly e-health resolution of 2005. Great efforts were put to transition from a paper-based data management system to digital health records, focusing on improving data collection and reporting of better patient management and policy development. Currently, the Minister of Health, in collaboration with the Minister of ICT and the Royal Eswatini Technology Park, RSTP, is implementing strategies aimed at enhancing digitalization in the health facilities through the Eswatini government wide area network. However, as a growing economy, the health sector in Eswatini is still faced with the need to adapt and fully digitize to enhance delivery health services. When it comes to policy frameworks which guide the digitalization of systems, strategies have been put in place to ensure a structured approach which is resilient and adaptable for future developments, as we know that the digital space is fast evolving. We have Eswatini National Health Information System Strategic Plan to 2021-2025. We also have Eswatini e-health strategy, and we also have Eswatini Communication Commission Data Protection Act of 2022, and Eswatini Digitalization Strategy 2024-2028, termed Government in Your Hands. Milestones covered so far. One is the National Data Repository, which is a centralized platform used for collecting, storing, and managing health-related data at a national level. This is very important for scientific research and epidemiological studies to inform decision-making and health strategies. Two is the Health Information Exchange. This is an initiative led by the Minister of Health Strategic Information Department to enable a seamless and secure sharing of health data across various health care systems, built on a multi-layered architecture. The HIE integrates electronic medical records, laboratory information systems, and mobile health platforms. Shared health record maintain consistent patients' records, improving workflows, reducing duplication, enhancing care coordination. 3, leveraging digital health technologies for safer prescription management, patient records, and diagnostic accuracy. Recently, WHO recommended the use of digital X-ray powered with artificial intelligence for TB screening to improve the TB case detection. Eswatini National TB Control Program has adopted chest X-ray and CAD AI for TB systematic screening to achieve 90% TB treatment coverage by 2026. Systems interoperability. Our client management information system is interoperable with various health systems, and we have realized benefits of interoperability. Improved patient care, efficiency in service delivery, reduced medical errors, better coordination among facilities, data-driven decision-making, and enhanced security and compliance. Systems and data security. The Minister of Health has achieved an acceptable level of data and system security through the following controls: biometric authentication, segregation of duties, database encryption, data backups, secure government network. There are implementing challenges, and they include connectivity and access. With a total of 342 health facilities in Eswatini, quite a significant number still do not have network infrastructure connection to enable both local area network and WAN communication capabilities. Investing in expanding network infrastructure is essential to bridge the digital divide. Telemedicine regulatory. During the COVID-19 response, this strategy was used and improved health services delivery. We have learned that there is need for regulatory policies in place to ensure patient safety, and that has delayed Eswatini from benefiting fully from telehealth. Client management information system coverage. With 70% of our hospitals already active on the digital platform, there are still facilities using paper-based health information management. Critical data are often never captured, and existing digital platforms and therefore lost, which affects our analysis and decision making. In conclusion, Eswatini believes that digital health is the way to go in improving service delivery and health outcomes. The management of public health emergencies such as epidemics requires a well-networked health system for alerts, notification, reporting, and response. Eswatini envisions a digitally inclusive future. For that, we are grateful to be part of this gathering to learn from better developed countries for better health outcomes in our country. I thank you.
We've been honored to have the privilege to take care of patients from many, many of your countries. But there's one country which is very far away, very beautiful, and very warm and loving people, the country of Fiji. We have been receiving patients from these countries, and I'm extremely honored to introduce His Excellency Penioni Ravunaiwa, who serves as the Assistant Minister for Health and Medical Services in Fiji. He has a background in healthcare administration. He's focusing on enhancing medical services and promoting public health initiatives, integrating digital health solutions, and improve patient care. We're working on telemedicine. There are multiple initiatives with the university. But most importantly, I thank you, Your Excellency, for the warmth and the positivity of your people whenever they come to see us. It's a great pleasure to have you with us. May we please hear from you. His Excellency Periona Ranuwawa. Namaste.
The distinguished guest, honored guest, esteemed delegates of the forum, ladies and gentlemen. Good morning and Bolavinaka to you all. This is my first visit to your great country, a nation that is known for passion of embracing unity and diversity. I bring greetings from Fiji. Allow me to begin by expressing my sincere appreciation for the invitation extended across the globe to the Pacific, which has allowed me to attend this auspicious forum on behalf of the government of Fiji as the Assistant Minister for the Ministry of Health and Medical Services. The relationship between the Fijian Ministry of Health and the Apollo Hospitals of India is a long-standing and a strong one, which has been in existence for many, many years. We have over a number of decades sent many Fijian patients to the Apollo hospitals in India and have been impressed with the quality, the expertise of medical professionals, and the services provided to our people. And we thank you for that. We have also received over many years specialist visitation to our country, offering medical specialists to Fiji, also to the Ministry of Health and Medical Services. They provide medical expert service to our patients in Fiji, and their contribution is greatly appreciated. Now to digital health. In an era where technology has reshaped various industries, healthcare must keep pace. Fiji recognized the significant potential of digital health to bridge existing gaps, ensure equitable access, and ultimately improve patient management and outcome. Our own learning from COVID-19 pandemic pointed to the necessity of digital health capability when physical movement were restricted by the spread of the virus. The implementation of necessary public health measures to contain the infection at that time. As an island nation, a very small island nation in the dot in the Pacific Ocean, there are more than 300 islands dispersed over our vast Pacific Ocean, and the use of digital technology has proven to be a game changer. At the height of the pandemic, the ministry instituted temporary telehealth and telemedicine capacities in the area of teledentistry, telepsychiatry, telepharmacy, which patients are grateful for as they provided continuity in their care. The ministry is now prioritizing establishing formal telehealth and telemedicine capacity for Fiji with the support of our partners. For Fiji, information technology and digital health is no longer a luxury. It is now an important tool for health service delivery in overcoming geographical barriers, enhancing efficiency, and empowering both healthcare professionals and our patients. Evidence from telehealth interventions shows that health systems that effectively adopt digital solutions can increase access to health services, decreases the time and cost associated with traveling for patients seeking care, also shortens the interval between the onset of symptoms to the management of care. This is particularly important for patients requiring coordinated care involving specialists and primary care providers. In acknowledgement of this, the Ministry of Health and Medical Services in Fiji developed and launched in 2023 a digital health strategy, Fiji Digital Health Strategy from 2023 to 2027. The Ministry has commenced implementation of the strategy, although the inadequate basic infrastructure, appropriate equipment, and low digital literacy remains a challenge to fulfill its implementation. According to the World Bank, Fiji Health Sector Review 2024 report that was released, 133 health facilities in Fiji are still not connected to internet. Moreover, facilities have been upgraded to high-speed internet lack the necessary computers and to utilize digital enhancement. Now, the fragmented implementation of digital intervention, along with the lack of skills and education among our healthcare workforce in ensuring digital platform and tool and the means that are intended to benefit of digital transformation have only been partially realized. Fiji's proposal to redesign health service delivery to address the health challenges faced by both Fiji and our Pacific Island neighbors, including harness the power of digital technology and the data for health. Enhance connectivity and the implementation of Fiji's 2023 to 2027 digital health strategy. We are hoping to facilitate transition towards digital patient record, non-communicable disease registry, telehealth services, timely consultation with clinicians at high-level facilities and online learning opportunities, including those in some of our very remote maritime islands. Fiji Digital Health 2023 to 2027, it promotes an enterprise architecture-based approach. This ensures that all digital solutions are patient-centered, are accessible, compatible, and interoperable and sustainable in the long term. By enhancing and by adhering to this structural framework, the policy will enable the integration of new technologies, enhance the optimization of human and financial resources, and improve the overall efficiency and resilience of our healthcare system. The successful implementation of this strategy will depend on a few things. One, ensuring that the basic infrastructure are established across all levels of care for health digital transformation. Number two, building a digital literacy among our healthcare workers and general population as well, enabling them to use and trust the technology while also understanding its limitation. Thirdly, employing dedicated human resources with the technical skills necessary to design, to maintain, and to promote effective use of digital technologies and systems in our country. At the end of the 5 years, the outcome of Fiji Digital Health Strategy, we are aiming to include a robust and a standardized architecture and infrastructure that can adapt a new demand and systems supported by organization capabilities aligned with the Ministry of Health and Medical Service digital health need. Initiating the replacement of existing patient information system or PETIS Plus with a system that provides a comprehensive electronic medical record or EMR functionalities, including clinical information to be available at the point of care. Full integration of key clinical support systems such as pathology, radiology, and pharmacy with the core EMR and other clinically related systems. In establishing an integrated communicable disease surveillance system along with a system that is support the environmental health. Also aim at increasing utilization of digital health system, resulting in reduced reliance on paper-based registries. Development of a new reporting system that collects data at source facility and create a user-friendly dashboard, scorecards, and geographic information system output for effective management, effective monitoring, and planning on various levels across the Ministry of Health and Medical Services. Expanded use of telehealth services to improve patient care, enhance system resilience, and with a hope to reduce the operational cost. Improve continuity of care through increased utilization of EMR at subdivisional and health center level, with targeted introduction of care management system for areas such as the maternal child health and the NCD screening. Looking into the future, Fiji believes that a well-functioning digital health in place, a system in place, will contribute in building resilience in our health sector. Fiji's rank in the top 10% of countries at risk of natural disaster, currently 14th out of 181 countries, and the country received its shares of tropical cyclone, heavy rainfall and flooding, and rising sea level with devastating impact on our coastal and coastline communities every year. By implementing these strategies, including crucial change and adoption of workstream, the Ministry of Health anticipates a wide range of benefits that will contribute to achieving its strategic objective. These improvements are expected to lead to a better health outcome for the Fijian populations, enhance patient experience, increase system and operational efficiency and resilience, and also improve safety and quality of care. We will work with our partners and collaborate with those who can assist us in the full implementation of our strategy. We will continue to venture into digital solutions across various public health sectors. Additionally, there is enthusiastic support from development partners and donors looking to fund our initiative. In conclusion, ladies and gentlemen, I wish to conclude by acknowledging and thanking Apollo Hospital for our partnership in the past and look forward to our ongoing partnership in the future. While information technology and digital health continue to advance in a rapid pace globally, smaller countries like ours, like Fiji, will find many benefits, and these developments are integrated into our current health system. And to add on, Fiji is currently aligning itself to the COP29 initiative of strengthening our investment in climate-resilient health facilities. Therefore, we will continue to rely on the expertise and experience of those who are advanced in this area for guidance and support through collaboration and partnership to build our digital capacities that will assist in the efficient delivery of healthcare services in our nation, and also to protect the integrity of our people. In prioritizing climate-resilient health system, focusing on capacity to anticipate, to prepare, and to respond to climate-related health risks while embracing sustainable practices and green technologies. This approach goes beyond physical infrastructure. It involves strengthening early warning system for infectious disease outbreak, selecting technology that best suited our local setting, and ensuring that health services remain accessible and functioning during all phases of emergency, including natural disaster. That is why collaboration like what we have here today is crucial. I thank you once again for the invitation to be here, and I'm here to listen, I'm here to learn, I'm here to connect, and I wish you all the same and a successful 2025 conference. Pinakabalebo, bo danebat, and thank you.
So ladies and gentlemen, you've heard from ministers from across the world. The time for AI is not in the future, it is now. The time for telemedicine has always been here, but is getting enhanced by the minute. We are collaborative, we are cooperative, we are thinking of a unified globe of a healthy population. It is my great pleasure to call upon the stage our Managing Director, Mrs. Sunita Reddy, who has joined us. She is Managing Director of Apollo Hospitals, but also the President of IMA. And this is the All India Management Association. Please do give her a big hand as she joins us on stage. She will be giving the concluding remarks for this session. She is a leader with great foresight who looks forward to a unified world, a healthier and a happier world, and who manages to combine the economic as well as the scientific, is continuously striving for the best in healthcare to be available to people all over the world. Welcome, Mrs. Reddy. I now call upon our very own healthcare advisor, guru, Dronacharya, Dr. V.K. Paul. He has been a continuous guide and an inspiration. He manages to combine forward-looking proactive thoughts with important policy and regulatory guidance. Dr. V.K. Paul is the member of the Planning Commission, the Niti Aayog. Please give him a big hand.
Good morning. Namaste. Excellencies on the dais, Ms. Sangeeta Reddy ji, Ms. Sunita Reddy ji, dignitaries, esteemed attendees, guests. First and foremost, my very warm welcome to all of you, and in particular our guests who have come from other nations, from abroad, from overseas. Very warm welcome on behalf of Niti Aayog and indeed Government of India. I wish to congratulate Apollo Hospitals for organizing this magnificent conclave. This event is very timely for India, it's very timely for the world. We are on the run-up to the SDGs globally, but above all, for India, in all sectors, we need to accelerate our progress in all sectors, including in particular the health sector, accelerate our progress toward a developed nation by 2047 at the conclusion of 100 years of India's independence. And such forum helps us to draw ideas, learn and position ourselves in terms of our work and missions. I also like to take this opportunity to pay my deep respects to a great son of India, Dr. Pratap Reddy ji, founder of Apollo Hospitals, for his vision, for his leadership, and for his impact on the healthcare scenario of our great nation. Very honored. India has had strength and a very deep ecosystem in information technologies. Building on that, under the leadership of the Honorable Prime Minister, we are witnessing digital India transformation of our nation. This is driven by our vision of knowledge-based economy and coupled with it, digitally empowered society. These are the driving principles for us. And we aim to ensure delivery of digital services, ensure access, ensure inclusion, empowerment, and privacy, and protection of the data that truly belongs to the citizens. For us, digital ecosystem is an important engine of our development now, but even more important as we move in the direction of our goal of Viksit Bharat by 2047. India's digital public goods are well known, and I'm just counting on a few of them other than the health sector, to which I'll come in a moment. We have 1.2 billion mobile phones and 75 lakh 0.75 billion people own smartphones. Our digital identity platform, the Aadhaar platform, covers 1.39 billion citizens, all of us. We have a unified payment interface which is used for 3,700 transactions every second. 3,700 transactions every second. And by the way, this amounts to 32 million transactions per day. Phenomenal. We have Umang platform for citizen-centric services, a GEM platform for procurement through competitive processes, DigiLocker to keep certified documents, DigiYatra to enable seamless pass-through at airports, and Diksha platform being used by millions for education. Our UPI that I was referring to for payments is being now owned up and being used in 7 countries: UAE, Singapore, Bhutan, Nepal, Sri Lanka, France, as well as Mauritius. In the health sector, building on this strength, and very early in the course of our evolution in this area, we have an overarching strong digital health ecosystem. Let me give a few examples. In the course of COVID, the CoWIN app was the most important enabler of converting vaccines that we produce on the Indian soil to vaccination. It's not the same thing. There are geographies in the world where vaccines became available, but they were not really getting to the people. For us, CoWIN played an important role. It gave digital certificates as you moved out of the vaccination site, and it imparted vaccination, helped in imparting vaccination to more than 2.2 billion individuals. Building on that, we now have UWIN, which is a new platform for universal immunization program. It works on 11 languages, and it ensures anytime, anywhere vaccination for our core childhood vaccination programs. We have a national telemedicine system, apart from several telemedicine systems in the private sector and even by state governments. The national telemedicine system is called eSanjeevani and came in the wake of COVID. It has given till date 347 million consultations every day. This platform is used by 250,000 persons for teleconsultation, saving fuel, saving drudgery, saving time, and we aim to improve its quality, its comprehensiveness, ensuring continuity in times to come. But this is serving our nation in a very big way. It logs on to up to 230,000 providers working through 17,000 hubs and so on. Third, India has transformed its primary healthcare system, and we are going further to have an aspirational, future-ready primary healthcare system that will take us to the goal of 2047 and well before that. We have transformed the sub-centers and primary health centers to 176,000 Ayushman Arogya Mandirs. 176,000 Ayushman Arogya Mandir. Each one of them have a telemedicine hub, and it functions. And through that, we hope to provide teleconsultation embedded in the primary health system and connecting it to the secondary system. A special mental health telemedicine system is called Telemanas. It works in 20 languages, embedded in practically all the states, and every day for mental health, 2,500 calls are made to this highly specialized mental health, high-quality counseling and referral enabler system that we have. Through the path-breaking and flagship program called Ayushman Bharat Digital Mission, which is our flagship core of digital health of India, we have created We have created 750 million Ayushman Bharat health accounts. This is my digital health identity. How many have been done? 750 million of us already have it. And very soon we will reach 1 billion. This little thing can carry my health records, and we are working on that. We have made beginnings, it's already being used, and as of yesterday, we had 490 million health records uploaded in the system. This is going to be extremely useful going forward. Lifelong record that can be shared at any point is our vision with regard to this. Last but not the least, our aspirational health assurance program, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which covers more than 600 million people. More than 600 million people uses cashless system, fully digitized cashless system on a daily basis. Every day there are 36,000 patients getting into the system, and a wonderful IT platform provides all the care. For disease surveillance, we get data from 200,000 locations. For all our national programs, from TB to lymphatic filariasis to non-communicable disease, and you name it, we have a digital portal. So entire public health delivery is really platformed on digital health system. Our challenge is now bring them all together, because they developed at different points in time, from maternal and child health to cancer care and so on. We wish to bring them together. I also wish to congratulate the private sector of our great nation. They have gone forward in their unique ways in providing teleradiology, telepathology, telecare, telehealth across borders. I'm very proud that this energy and this enterprise will grow with time. With startup, very vibrant startup culture, of which almost 20% or so are health-related startups. We have a great future as we move in the direction of future digital health goods, including those that are related to AI. I want to emphasize, as I move to my concluding statement, that under the leadership of the Honorable Prime Minister, during India's G20 presidency, we worked together and were very, very pleased as a nation that a global initiative on digital health came out of those deliberations and the ideation that happened at G20 activities under India's presidency. I am very proud to say that the World Economic Forum recognizes India's reach, depth, technical capacity, and capability to deliver digital public goods, and it has said, and I quote, "India can be a global pathfinder in digital health," unquote. This is something that came about 4 weeks ago. I want to mention that India crafted the legal ethical framework for telemedicine in a very timely manner in 2020. It's a good example for creating a legal framework for ethical and legally appropriate telehealth, and we can work in bringing it as a global template for other nations. I understand AI for health has been covered extensively in the last session. All I want to say here is, for India, for AI in general and for AI for health, we visualize ourselves to be not only the biggest consumer of such AI products, including AI for health. No, not just that. We wish to be the biggest hub of AI technologies for health and AI technology in general. That's a vision with which we are working. And my organization, Niti Aayog in particular, is looking at cross-sectoral development of AI in our nation. Be happy to connect with colleagues within India and beyond to build the ecosystem and initiatives in this regard. As I close, let me quote the Honorable Prime Minister. He said, and I quote, "I dream of a digital India where quality healthcare percolates right up to the remotest regions of India by e-healthcare," unquote. I have noted extensive inputs that we received from excellencies about how telemedicine, other digital technologies are taking root and are being scaled up in our nations. We'll be very happy to work with all of you and beyond for the following. One, let us share our digital health products. I give a call to all of us, to our countries, to other countries. Let us share our digital health products. Number two, let us co-develop digital health tools, including in particular AI-powered tools that serve our specific needs, adapted to our needs, our context, our capabilities, and our people. Third, let us deploy digital tools for health services across border, even at a bigger scale. We are already doing it. We should do more, share, use, reach out. And fourth, let's together strengthen international digital health architecture and governance such that the aspirations of Global South for the most advanced and ever-changing technologies in terms of affordability and scalability for digital health services are met by us together. We want to leave no one behind. These technologies are there for the people of the world. And let's work together to have an international ecosystem that ensures that reach of these services and ease of accessing healthcare by all our people. With these words, my deep gratitude. Thank you very much. Jai Hind.
So you've just heard Dr. Paul. Let's work together. Let's ensure that health reaches every nook and corner of the world. Thank you so much, Dr. Paul. Before I hand over to Mrs. Sunita Reddy for concluding remarks, I just want to take up on this one point which has been spoken by everybody, which is AI. Those of you who heard one of the first proclamations by President Donald Trump, he spoke of Starlink. When somebody said, please describe Starlink, the first description was how AI will be used in healthcare. At the recent AI conference in Paris, when our Honorable Prime Minister spoke about AI, the first example we gave was healthcare. Ladies and gentlemen, governments across the world, corporations across the world, leaders, public, scientists, engineers, everybody is looking at AI in healthcare. I have only one request. Let them not thrust healthcare AI upon us. Let us as healthcare leaders create the healthcare AI which serves our population. That's what we're here for. That's what we're going to do together. So with great pleasure, I invite onto this global audience for the concluding remarks, Mrs. Sunita Reddy.
Good afternoon, ladies and gentlemen. It is indeed a pleasure to be with you today for this very special conference. I have to say that coming from another conference, I probably have a very economic background to context to what I hear today. But it is indeed wonderful to be amongst these wonderful dignitaries on the stage. Dr. V.K. Paul, with this in-depth knowledge of healthcare, and all of the ministers who've come from different countries representing the best of healthcare, and more than representing the best of healthcare, people who are committed to raising the healthcare standards in each and every country. Today I would like to speak a little bit about the India context. India, as you know, is a very young country. It has been probably 77 years since our independence. We are young in many ways. We have the world's youngest population. So while people in other countries worry about how their aging will become, the aging citizens will become poor, in India we worry about how the young citizens will become rich. And that is the difference between India and the rest of the world. We have a huge advantage of a very large population. So when we came back to India about 45 years ago, this is how transformation has happened across India. The average life expectancy of the Indian was 57 years old. This was in the 1970s. Today, if you look at it, it is 76 years in urban India. And that is what the government, working with the private sector, has done. It has increased life expectancy. It has improved infant mortality by a factor of 10, improved maternal mortality by a factor of 4. And all of these contribute to a vibrant, healthy workforce that is committed to growing India. So India has grown at over the decade at 7%. This might have been a quiet year, but I think, with the innovation, the ambition, and the knowledge, we will grow by 8%. Growth in agriculture, industry, and service, but most important, in the human indices that matter most to every individual and which is foundational for the growth of the company. India's growth has been tremendous, and more so in the past 10 years under the leadership of our Prime Minister. This is, if you were to compare us with the EU is a combination of 27 different countries. In India, we're 28 different states which are almost like countries. Yet, because of our commitment to making sure that all of India grows, that India is not a sum of the different parts, but it is one nation. We have one digital system, one unique identification system, which is Aadhaar. We have UPI, we have digital payments. We have Ayushman Bharat, which now covers, which is a healthcare I'm sure it was covered in one of the earlier programs, but as you know, it is probably the world's largest insurance program that provides access to care for people even below the poverty line. So India is growing fast, but India is also growing with quality. It is not only technological adoption, it is about the work that has been done in the digital space, which I'm sure that Sangeeta has covered very in depth, and of course AI, which is really transforming healthcare. It is giving an opportunity, more than an opportunity, a quick diagnosis. We're able to use it in preventive healthcare as well. We're able to use it in cases to make sure that there is speed, there is scale, and there is efficiency in what the healthcare sector does. As we look at going forward, and I know one of our themes is Heal in India, and today I'm especially grateful for all of the dignitaries who've come from across the world to India. Please understand that India is not just about India. I think Mr. V.K. Paul spoke about the Global South. India cares about the Global South, and it shows that it cares in many ways. I think everyone spoke about telemedicine, where we are looking to connect the world with what we know in India. And India has done this. We've done it very successfully. Today we have patients from 147 countries. They come to us for not just cheap care, because it's at 1/10 of the cost, but quality care that promises the best clinical outcomes. And this is really the DNA of India, that we do things and we do it with quality, and we do it because every life matters. As we think of the future, as we think of Heal in India, I'm sure that with the current policies of the government, with the intention to cooperate with the countries that surround us, that this development is possible. India's focus on Heal in India is not just about, is because we have a very unique product. Heal in India is about not just looking at tertiary healthcare, big surgeries. It's also about preventive healthcare, which is a large area of focus, especially for the Apollo group. It's about an integrated healthcare offering that offers not only allopathy medicine and high-end care, but also Ayurveda, to make sure that we get the best outcomes for each and every individual, even before they become patients. So this is India, And this is how we would like to connect with the rest of the world. Start by using telemedicine, making sure that we're able to serve patients from every part of the world and share our knowledge. The third part of our quality journey is investment in research and development. Currently, this is where India needs to move up the ladder. We spend only 1% of GDP on research and development. We need to spend 4 to 5%. And I'm sure that with the collaboration with the private institutions, with our collaboration with different countries, with our understanding and learning that we have today, that we will be able to do this. While we've done AI and we've seemed to have done it really well, I believe that we will succeed in the large language models. I mean, what else will you expect from a country with 1.4 billion educated, very intelligent people, that we will be able to do this? I'd like to conclude by really picking out something from Charles Dickens. He said that we live in the best of times, we live in the worst of times, but the Chinese have said we live in the most interesting of times. And I think the interesting represents a very unique opportunity to do something that is meaningful for healthcare, to deliver quality healthcare across different sections of our populations, to make healthcare equitable, to use technology like telemedicine to make sure that we connect, that we create networks of care that will look after people in future generations. So with that hope and and the collective intelligence that I've seen on this stage and from the other speakers, I hope that we continue to have a very great conference. Thank you, ladies and gentlemen.
Thank you all to our wonderful audience. May I request you to give all our panelists a big hand. We've come to the conclusion of International Health Dialogues, the inaugural session. We started off with our Honorable Minister, we went on to multiple ministers, but let me tell you, the action is just beginning. We're going to have drone demos, we're going to have paperless hospital exhibitions, we have deep insights into AI, we will be sharing knowledge, having more conversations with all of you, hearing from scientists from Microsoft to Google. The action is just beginning, and in the next hall you have patient safety. Please feel free to check out both conferences. Please go ahead and tweet, get onto social media and tell people who are not here physically to join us virtually. I believe we already have 27,000 people logged on and the number is only growing. This is a movement. It's our individual knowledge coming together to create a collective for a safer, stronger, healthier, happier world. All the best to all of you. Thank you so much. Namaste. Thank you.
Thank you, ma'am, for steering this discussion. I request all our dignitaries on stage to please gather for a group photograph. Please give a huge round of applause to all our distinguished speakers who have spoken. For a group photograph, I request all of you to please gather. Please give a round of applause to our distinguished guests of honor, our distinguished speakers who have spoken to us about the initiatives being taken in their countries as well as digital health in India. We all look forward to greater cooperation for the Global South to come together so that healthcare is one which is accessible to all in the country and the gap is reduced remarkably. Thank you. Ladies and gentlemen, as the first movers in healthcare innovation and digital transformation, Apollo Hospital Group is working on exciting segments showcasing cutting-edge advancements shaping the future of healthcare delivery. It is now time for our Spotlight Showcase, Medical Aid on Wings, Drones Delivering Healthcare. This initiative represents a leap forward in healthcare accessibility, particularly for remote and underserved regions. Drones have emerged as game changers in delivering critical medical supplies, vaccines, and emergency aid with unprecedented speed and efficiency. I would now request Mr. Premanand to please come up on stage and talk to us about this exciting launch that is coming up. Please put your hands together and welcome on stage Mr. Premanand.
Thank you. I hope everybody is still active and good. Finding solutions to healthcare requirements in India globally requires an integrated approach. And at Apollo, we have been working for a few years now, trying to look at how to use drones in collaboration with World Economic Forum. We've done few pilots in some of the most remote parts of the country. And we have figured out a lot of use case for the use of drones within the Apollo ecosystem and with some of the state governments. It will be very exciting for us to showcase this, a real-time scenario from Delhi, our Indraprastha Medical Apollo Hospital. May I once again request our Joint Managing Director, Dr. Sangeeta Reddy, to kindly come on the stage once more. Sorry, ma'am, you need to keep climbing the stairs up and down. Thank you for that. So, can we get the key for ma'am to inaugurate and showcase this demo from Indraprastha Apollo Hospital? We have a drone installed which will move across 250 meters. It's a 5G enabled and GPS positioned AI drone which is transporting a biopsy sample within the hospital. We are ready to go, ma'am. So, there it goes.
You're watching this live. I just want to share with all of you that we had the privilege of working with the team from the World Economic Forum and with the drone company to create the protocols for appropriate use of drones in healthcare. So this one is now carrying a medical sample to move to a diagnostic lab for urgent testing. We also have the protocols for movement of organs, maybe from a district hospital to do the organ retrieval, come into the high-end tertiary hospital for an organ transplant. Drones can be used for defibs to carry and move them to a site, say in the middle of a road traffic accident, you revive a heart. So multiple applications have been listed. We wanted to share this with you. These protocols will all be available on the Transforming Healthcare with IT website. They're free for everybody to share across the world.
The drone is correctly moving from one hospital building to about 250 meters, and it will precisionally track, self-automated, and find the right landing spot, and it will land. So what are we looking at this drone implications? Not only for the hospital utilization of solving patients in most urbanized locations. We are looking at moving blood samples. We are looking at moving expensive drugs which cannot be stocked in remote parts of the country. So we are looking at public health systems to be effectively utilizing these drone systems along with telemedicine integrated, which should solve most of the remote parts traumatic requirements in healthcare. So it will take about another half a minute or little over that to find its spot.
Yeah. I think all of us know that drones have already been used in many parts of the world. In Africa, it is known that vaccine stockout was reduced by 75% because of the use of drones. This is a different kind of drone, of course, which enables point-to-point location and not just a remote launch into a wide area. So there are multiple different types of drones and many applications for these drones. We really elicit more conversation with the drone vendor. We are not the vendor. We're just showcasing that some of these can be used in different applications. I think the drone is landing right now. If people have thoughts, ideas, please go onto the chat box and share some of them. Who has already have experience? Who wants to do more? Who would like to partner? Who has a new use case? Please treat this as a collaborative initiative. And I often say that while AI is dominating many of the conversations, there are many unsung technologies, whether it's remote care, the Internet of Medical Things, the use of drones, augmented reality in helping treat patients, especially in recovery. Many of these are being showcased in the exhibition hall. So please feel free to move around, see there, talk to people who are on this journey. I very often say that conferences like these, we're all travelers on a common journey. And when we speak to each other, we help each other travel faster, travel smoother, travel with more purpose. So thank you all very much for being here and spending your time with us at this conference. The name of the technology partner is Tech Eagle. So let's give them a big hand and thank them for their role in making this happen and for supporting healthcare. One of the young engineers said that, ma'am, I'm much happier to be working in drones in healthcare than in doing hamburger deliveries. So I think they really have it right, that they're focusing on the most important thing. Yeah. Handing over to Prem.
Thank you. Thank you, Ms. Sangeeta. So for us, this particular application goes beyond the boundaries of our hospital. As we do more of remote healthcare work, the use of drone is going to be phenomenal in terms of, closed looping all the challenge areas of logistics, which caters to about 64% of India's rural healthcare. So this is where the collaboration is leading us to, beyond the boundaries of our hospital. So as you see, the drone is coming down slowly, and from there, the sample will be moved inside the hospital for further testing. Thank you. Thank you, everybody, for your patience.
The drone has reached its destination. Let's give it a huge round of applause. For the first time, we are seeing medical aid on wings, drones delivering healthcare. This is truly awesome. And we have many more firsts coming up during the day today. It's an action-packed day. But now we're going to move on to a session on making geography history, global digital health illustrations. This session will focus on how digital health innovations are transforming healthcare accessibility and sustainability on a global scale. Advancements in AI, telemedicine, wearable technology, and big data analytics are making healthcare more affordable, efficient, and patient-centric. So chairing this session, we have Dr. K. Ganapathy, Past President, Telemedicine Society of India and Neurological Society of India. Please give him a round of applause and let's welcome Dr. K. Ganapathy on stage. He is currently Distinguished Visiting Professor, IIT Kanpur, and the Honorable Honorary Distinguished Professor at Tamil Nadu, Dr. MGR Medical University, Chennai. Joining us in this session as speakers, we have Aditi Jayaram, Project Officer, International Hospital Federation and Geneva Sustainability Center, part of IHF, who will discuss healthcare sustainability and net zero strategies for global impact. Please give a round of applause and welcome on stage Aditi Jayaram. Please welcome Mr. Anil Srivastav, President, Open Health Systems Laboratory, OHSL, who will talk to us about a technology-enabled pediatric brain cancer network connecting Africa and South Asia. So please give a round of applause and welcome on stage Anil Srivastav. Please also welcome Mr. Eric Narnish, VP, Mayo Clinic Platform. Please give a round of applause and welcome on stage Mr. Eric Narnish. We are also joined by Mr. Raj Shah, Chairman, Health Council and Board of Director, Wheels Global Foundation, who will share his insights on providing technology-enabled remote healthcare in rural India through a US-based Pan-IIT alumni initiative. He is joining us virtually for this session. So please give a round of applause to all our speakers who are now on stage, and Dr. Raj Shah, who is joining us virtually. I will hand it over to Dr. Ganapathy to steer this discussion.
When I joined the medical college 57 years ago, there were only 3 groups involved in healthcare: patient, nurses, and doctors. Today, there are probably much more speakers who are not practicing clinicians inside the OT, the OP, the wards, and so on. This is what modern healthcare is all about. And I can't resist the temptation to introduce, though he's not the first speaker, Mr. Anil Srivatsava, who I understand is a pilot turned economist, turned World Bank, etc., who's now involved in healthcare. Similarly, on my left is a young lady who's deeply involved in healthcare, who's not actually treating patients. So this is what modern healthcare. And I'm also it's a great pleasure, sir, to introduce Mr. Eric Harnish, Vice President, Mayo Clinic Platform. We all have heard about the Mayo Clinic, and he is also going to talk to us on the global outreach of a specific platform in diversified geography. We all know that in the last 10 years, the Indian Institutes of Technology, which are the showpiece of India, are getting more and more involved in healthcare. In fact, medical colleges are very soon going to be operational in 3 of the original IITs. It's a pleasure to introduce Dr. Raj, a senior cardiologist based in the United States, who heads the Health Council of the Wheels Foundation. He's going to spend a minute or two talking about wheels before he gives us practical demonstration of how technology can be used in remote healthcare. And mind you, this entire project has been done, it's an ongoing project, it's been done supported by IIT alumni. And as Dr. Sangeeta and Dr. Preeta mentioned earlier in the morning, IIT also have realized that healthcare, I personally don't like the word industry, but healthcare industry is one industry which is recession proof, and all of us will require healthcare even before we are born and even after we leave the world. So the Indian Institute of Science is again building a hospital, and India's first MD PhD program is going to start from next year. So I would now invite Dr. Raj. You have exactly 600 seconds, sir, to tell us on how you're using technology in remote healthcare. Over to Dr. Raj.
Thank you. Thank you, Dr. Ganpati. And first of all, thank you so much for inviting me. Although I wanted to be there in person, but I just returned from India after 1 month, and particularly giving health track at Penn IIT World of Technology in Geo Center. So I could not come in person, but I thank you so much to you and the conference committee for inviting me and giving me this opportunity. I'm going to share a few slides with you and a very short video. So let's get started. I hope you can see the slides.
Yeah, we can see the slide, hear you loud and clear. Please go on.
Okay. And what I need to do is put it on a presentation mode.
Please go ahead, because we have a fantastic visual system here. So even in the other modes, it's visible beautifully.
I'll be talking, thank you, sir. I'll be talking on providing technology-enabled healthcare in rural India, a story from Wills Global Foundation. The inspiration came from our previous president, Abdul Kalam, who was addressing the 2006 convention of Penn IIT in Mumbai. And he sort of raised a question that all of you are successful businessmen from India. You are educated in India. As a matter of fact, all the Indian Institute of Technology, IIM, IIS, and for that part, government medical colleges, most of them are financed by Indian taxpayers. What have you done? What have you given back? And he sort of mentioned the areas like water, health, education, energy, livelihood, and sustainability. These are the areas which particularly in rural India needs help. And that was kind of a inspiration which made Penn IIT people to form a charity organization. And if you take the acronym with first letter of each of these 6 areas, that becomes Wills, and that was the start of Wills Global Foundation. Now, technocrats had done quite well in all the other areas except in healthcare till they made change in their board and invited healthcare, which is me and other doctors. And today we form Health Council with more than 100 members. And I'm delighted to say that Dr. Ganpati is also one of our member, one of our advisor, and guiding us with his extensive experience of healthcare technology in India. So now let's look at rural India. In rural India, the problem is we have no healthcare providers. We have no clinics, hospitals, pharmacies, medical supply equipment or anything. And even infrastructure is poor, no roads, transportation, telecommunication, or any communication. Now with this, we have 600,000 villages, almost 839 million rural Indian population who are living in poverty, lack of education, clean water supply, sanitation, everything. How we are going to reach them? And particularly, even if you are from India, I'm from villages, and get educated, very few people, as a matter of fact, to my knowledge, almost none, go back to live and raise family in this kind of condition. So till we transform villages, we're not going to have a good luck in providing various healthcare providers and facility. So only option we have is to use our technology, technology-enabled solution, which is possible to give easy access, lower costs, and still give quality care, and eliminate travel and weather barrier for patients, and make it convenient for them. And we can bring doctors or any of the Ayush providers to provide quality FaceTime. They can review the pre-visit data. They can do the flexible working hours and expand their practices. So this...
Dr. Raj, sorry to interrupt. Can you just put it on the slideshow, please? Presentation mode.
It is in the presentation
mode.
No.
Just check again. I mean, if it's possible.
It is in presentation. Let me see if I can do something different.
And the slides are very interesting, very informative. But we have a very large audience, so maybe...
If I can, hold on, let me see if I can do. Dr. Ganpati, it is in the, this is now the...
that's better. I think this is better. What you did now, this is fine. Just leave it like this. No.
Okay. Leave it like this?
Doctor, if you can click on top, just put it into the slide mode now.
Go down. Go down the notes, scroll, that's right, turn to the right. No, your mouse, go to the extreme end as we normally do. I think this is okay. Yeah, that's right. Click on that slideshow.
Yeah. That's
so it's okay. It's okay. I think we are spending too much of time. No, go back to the original. Yeah. Go back to the top. Display setting. Yeah, display settings. Please go to the display settings on the top, in the middle. Just under your name, Dr. Raj, just under your name, display settings. Next one. No, top. I think it's okay. We are spending time.
Is that better?
No, just go to display settings. In the middle, short, that's right. Click on that. Click on that.
Can you see this better now?
No, you have not clicked that. No, I think we are spending too much of time on this. Okay, can you do a remote control from here? Yeah, okay, leave it like this. It's okay. Please leave it like this and continue. Your flow of thought also will get interrupted. Sorry for disturbing you. Please go ahead. This is better. Okay. It's okay. Just leave it at that. Yeah.
Okay. So we can, and I have an example of the system that I developed. I have a passion for technology, and I've been working on it for last, you can say, 50 years. Of course, as technology advances, we are able to incorporate that more and more and make it possible. My first thing was to be able to see a patient, examine the patient, and evaluate them. So for that, I designed a system called SmartCare Doc in America, and I'm going to show you a short video.
Throughout history, healthcare has been delivered in person. However, cost, convenience, and geographical barriers often pose challenges for patients to access healthcare.
Can we increase the volume at this end, please?
Healthcare development, the Smart Care Doc system. This system offers a web-based smart clinic, app-based smart video call, and store and forward reports, images, and video clips for smart opinion, all HIPAA compliant, scalable, accurate, and cost-effective. It allows patients and providers to connect using any smartphone, computer, iPad, or tablet for secure face-to-face video visits and medical examinations by using integrated diagnostic devices from the comfort of their homes or wherever they are, without hassles or travel or high prices, in one streamlined environment, as if they are in the doctor's office. The Smart Care Doc system replicates the workflow of a typical medical visit and is easy to adopt and can be used in any setting, such as in homes, clinics, nursing homes, independent living facilities,
Yes,
schools, offices, or manufacturing.
Yes.
The system replicates in-person
Yeah.
medical visits by incorporating many easy-to-use features, such as
It's on the maximum volume.
Okay, that's okay. I think the audience has got the message. We can continue.
Okay. Okay. Okay, so I'm going to advance. And we created this televisit system, and we debuted that in 2 Walmart stores. We are the first in America to have a teleclinic in 2 Walmart stores. We saw more than 1,000 patients, presented the data, and we proved that it is effective, efficient, and easily accessible, cost-effective way to see patients and take care of them. So with that experience, coming to India after I became part of the Wills Global Foundation during COVID time, we had to create something for our rural system where it was not possible to create a brick and mortar clinic and put the system and have that excellent internet connectivity. So we created much better cost-effective system on a smartphone or a tablet with a software which can take all the triage information with their symptoms, their vitals, the vitals with using the Bluetooth connected devices to get the basic blood pressure, pulse ox, temperature, blood glucose, and even a rhythm strip ECG that can be taken and put into the software. With this information, then a helper at the village level will connect with the doctor online. Now, initially, we will give, Wills Global bears the cost of hardware and initial software implementation and training. And then it is sustained by collecting a small fee from patient. Half of the money will go to doctor's fee as a token. A small amount will go to the person who is helping at the village level, we call Sahayak. And small amount goes for support of the software, maintenance of hardware, and update. So this system we created, these are just the details of the incorporated devices. Now devices are directly integrated into the app and will pull in the data. Also, there is a multifunction single unit which can do all of them, including ECG, which we have incorporated. Down the line, more sophisticated stethoscopes, spirometer, ultrasound. This can be added depending on the need and where we are. The way the centers were created, we'll go and select a person who is a resident of the village, and he will be trained. His home becomes really the heart center, or we call it healthcare access for rural community, not really a cardiac center. And we will train them, we'll give them the kit and basic training, and we'll connect with the doctors who are willing to provide the consultation. With this system, of course, we follow the telemedicine practice guidelines created and published on March 20, 2020 by Indian Medical Council. We collect the data, including social determinants of health, including all the demographics with the water supply, the sanitation things, etc. They have it, all the disease screening for the anemia, hypertension, diabetes, for the family members, etc. And then publish that as a SEHU model, which was created by Health Secretary in Gujarat Social Enterprise for Human Upliftment. So this will be very useful going down the line to learn the prevalence and see where intervention is needed. Now during COVID, this is the most important. Because of the donations we received, we were able to create 306 telemedicine centers in 7 states in those villages, and we were able to provide free care, free teleconsultation to more than 15,000 patients during that year. We also were able to donate more than 300 oxygen concentrators, which was a dire need. And we also spent money to create a low-cost oxygen concentrator very quickly at IIT Kharagpur under the leadership of Professor Suman Chakrabarti. So this was a great activity which helped. Now our goal is not just to finish and brag about what we did during COVID. We want to continue provide this service. We want to create minimum of 10,000 such sites in the villages where there is no healthcare access. There is nothing. We will need the fund. We have 3-year program whereby we want to create 10,000 such sites. Now in each sites, not only just the treatment when they are sick, but also evaluate them and screening for mental and behavioral health, health education, prevention aspect going down the line. So this is our journey in last 5 years. Now currently there are 4 programs which I really want to bring it to your attention. One is a newborn nutrition. One of our physician, Dr. Rupal Dalal, observed that particularly in rural and tribal area, the way infants are fed is just a poor technique, not holding properly, not total amount of milk that should go in infant. It doesn't go there, and as a result, they get undernourished or malnourished. Their weight gain is less than 15 grams per day, which is normally WHO standard.
Dr. Raj, you need to conclude soon, please.
Yes, I have 3 more slides and I'll be finishing. And this program, in partnership with Madhya Pradesh government, will be training 10,000 ASHA workers and will impact 10 million infants in next 3 years. And as a result, 4 other states have lined up, including Jharkhand, Meghalaya, and Maharashtra state, where we'll be expanding this program. This is done through what we call spoken tutorials, a special training program created at IIT Mumbai. And with a small amount of investment, we are able to make a huge impact. And if we consider 4 states, down the line, 30 million infants will prevent undernutrition and malnutrition and stunted growth. We have undertaken, working with Samhita Foundation, to put our system in community service centers. I understand Indian government has built in 500,000 villages, where village entrepreneur has a computer, printer, and internet connectivity, and we will provide medical software and devices where villagers can get the services. We have incorporated mental health screening and training with yoga and meditation using Yoga Immortal under leadership of Ishan Shivanand, and my vice chairman, Dr. Bindu Kansupada, who has undertaken to spread this program of screening and treatment in schools and colleges, particularly medical colleges and IITs. And lastly, for the schoolgirls, distributing the menstrual pad by putting the dispenser in the girls' room so that they have easy access, and we can prevent many dropouts and poor hygiene. Many other programs you have undertaken, I won't go into detail, But just as a last slide, I want to say that as technology evolving, if you look at it, over the last 100 years, we have not adopted technology, but in last 50 years, since the advent of computerization, literally everything we do today, almost 90%, 95% of things in medicine are technology related or enabled by technology, including X-ray, CT scanner, MRI, now artificial intelligence, big data analytics, etc., whereby we can do so many things which was not possible before. I forgot to mention genetic engineering and nanotechnology and molecular technology. But when all said and done, the key for widespread adoption has to be the technology has to be accessible, affordable, means cost effective, available, and easy to use. And I think the future is bright for technology which will make this possible. And if you remember, if you know, e-Sanjeevani program started in 2019 during COVID.
Dr. Raj, I think we have to conclude, sorry.
So we will be finishing. Thank you very much for this opportunity.
Yeah. Okay. Thank you, Dr. Raj. Thank you so much. Can I ask the next speaker, please? Aditi Jairam.
Hi, everybody. Can you hear me okay? I can't tell. Yeah? Okay, there we go. That's a little bit better. Thank you, Hal. I'm also wondering if you can see me okay, because I've
Can we have the first slide, please? We are running behind time.
Yeah. So it's a little tricky to see me behind a dais is what I've been told. So I'm hoping you can actually see me up here. So my name is Aditi, and I work for the International Hospital Federation. We are an international community. We're a member-based organization. Kampe? Don't know. Okay. All right. Maybe that's a little better. So we're an international community of healthcare leaders. We've been around since 1929. An interesting fact, we're actually older than the WHO. We're coming up on 100 years in a few years, and so it's really an exciting time to be in the healthcare sector for us as well. And so the IHF itself, like I was mentioning, it's a member-based organization. Over the last couple of years, we said, you know what, we really need to start addressing what climate change looks like within the healthcare sector, because oftentimes we're front-facing when it comes to addressing climate-related events, right? And so we established the Geneva Sustainability Center. And now the GSC itself is only a few years old, because our board decided, okay, how do we start addressing climate change? And we put this organization together to help healthcare leaders specifically in these 4 domains. We want to start helping them with capacity strengthening. It's to be able to say, okay, let's sit down, let's talk about climate change. What does that mean for you and your hospital and healthcare organizations? We also do a fair number of global collaborations, which I'll talk about in just a second. And then we also do accreditation and certification, which we've recently collaborated with JCI to be able to roll out the new Global Health Impact chapter that's just been rolled out for this year. And action planning, which is through our Sustainability Accelerator tool. And that's really what I'm hoping to be able to talk to you about today, which is some of the data that we've been able to gather to help hospitals and healthcare leaders identify what it means to start addressing climate change, where they're doing well, and what are the gaps, right? So the SAT itself was launched in late 2023 in Lisbon during our World Hospital Congress. We represent right now 23 countries. So the SAT is a digital platform. You go online, you log in as your hospital, and what you do is fill out a list of questions. So there's a maturity level where you identify what your benchmark looks like after completing a list of 56 questions. And then after that, you go on and start so that's the quantitative side. Now that's the qualitative side. So once you start looking at the quantitative side, we want them to go through these certain set of KPIs. So there's 23 KPIs. They answer these questions. And the intention is to ensure that you're kind of building, these collaborative initiatives within the hospitals, because oftentimes you realize that departments can work in silos. And our intention is to try and kind of break that down and say, okay, let's come together, let's come to the table and talk about how we're performing across departments and across other verticals as well. And so the data that we do gather from this helps them set their strategic direction in terms of where they want to be able to go going forward. Now, all the data is definitely anonymized, and what's fascinating about this is that it also allows you to have a group dashboard depending on the number of hospitals that you do have signed up, right? So this is what the tool itself looks like, and it's across 3 specific domains. We look at environmental impact, and so the idea is to say there's a lot more that you can do beyond just turning off your lights and switching to LED bulbs. We also look at health equity and well-being, because we do believe that healthcare should be accessible and available to everyone across the board, irrespective of where they come from. And leadership and governance. So that's you people in this room. It's to be able to say, what is it that you're doing in your organizations? What have you already started addressing, and what needs to, what do we need to get started with? And so what hospitals do is they sit down, they fill out this questionnaire, which is the first level, which is that maturity diagnostic that I was mentioning. And we get a performance level. So this one is currently, as you can see, it's an intermediate. And so the questions itself are very straightforward. The idea is to be able to identify where is it that you've gone as an organization. And it's across these 3 domains. As I was mentioning, we have the environmental impact, health equity, well-being, and leadership and governance. And so this is 14 subdomains, and what I'm hoping to be able to do is talk to you about the results that we've seen across this. Now, this is data from 33 hospitals in 15 different countries, and most of the data, if it's above 50%, it falls within the intermediate category. So we realize that the idea is to give people the opportunity to get started, and the intention is not to be able to intimidate anyone and say, okay, you're doing terribly. The idea is to say, okay, where are you doing, and how is it that we can help you get better? Now, as you can see over here, leadership and governance is doing very well. So congratulations to most of you for having gotten started in terms of getting started with sustainability and working on decarbonizing within your own organizations. The one that's most heavily impacted, the domain that really does need a fair bit of help itself, is environmental impact. And so what does that look like? Really? I've had only a few. Okay, so things are constantly moving over here, as we can tell. So the intention really behind a lot of this data is to be able to say there's work to be done, and I wish I could talk about this a little bit more, but things, like I said, things are moving around. We want to look at procurement. We're doing excellent with health equity and delivery. And there's definitely space for improvement when it comes to employee engagement. And so my data takeaways are, let's talk about procurement. Let's look at what it means to start engaging your workforce, and what is low carbon clinical care. And out of all of these key takeaways, I think the biggest thing that I want to be able to say is, if you're not seeing savings, then you're not being creative enough with your sustainability initiatives within your organization. We'd love to keep talking. Please come visit us in Geneva at our World Hospital Congress. And thank you.
Thank you. Mr. Eric?
Hi, I'm going to speak to the diverse geography through an AI lens. And really, when Mayo Clinic thinks about diverse geography, the importance of that is we want effective and inclusive AI solutions in healthcare. So as we think about how do we transform healthcare globally, it starts with having an enhanced data diversity. So data representative of different patient populations. And really what we're trying to ensure is that there's this cultural sensitivity and inclusiveness of this data, get a heterogeneous representative sample. Now that's getting a strong diversity. The next thing that's important to Mayo Clinic is how do we drive innovation? And so we have collaborations with groups from around the world to drive that innovation and collaboration. So.
Yeah, my name is Anil Srivastava. I work with a group called Open Health Systems Laboratory. Open Health Systems Laboratory actually We try to find researchers all over the world by systematic search through the literature, find their interest, and bring them together into a team science collaboration and provide them the technology and support to make their research possible at the cutting edge. Much of our work is in the area of, all of our work is in the area of biomedical research, and we are very, very proud to say that with Apollo Research Academy, we're now collaborating in seeing how we can create an international cooperation in that area of the biomedical research. But one of the things that I wanted to talk, and I'll be brief because there's some change in the program, is we are involved with working with the Duke University, Bayer, and Apollo Research Academy in creating what is being called a global pediatric brain cancer network, which will connect Africa, the countries in the continent of Africa, and Asia, South Asia, and as a South-South cooperation. Our approach to it is basically we've been working for years together with NIH, the National Institutes of Health, in developing a telesynergy consultation system, which is an open system to bring all the groups together to create an open network with whatever tools and technologies they have. So that is what really we are working on, and I would be very happy to talk to anybody, because I'm one of the very strong believer that we have to create an open system which will allow us to connect whatever exists and whatever is going to exist and integrate it together. So with that, I would end. Thank you very much.
Can one of the organizers please take over? If there are any, I think we have till the organizers come. If there are any questions from the floor, we'll be happy to take it for any of the speakers.
Please give a round of applause to our speakers on stage. Thank you for taking us through this very interesting topic. And we all look forward to more developments in the field of digital healthcare. I request Dr. Ganapati, Aditi Jayaram, Anil Srivastav, Mr. Eric Narnish to please come forward for a group photograph. Please give a round of applause to all our speakers on stage. And we would like to thank Mr. Raj Shah, who joined us virtually.
Thank you.
In a few minutes, we will be starting with our next session on International Health Dialogue, Healthcare of the Future. I request everybody to please take your seats and settle down. We are expecting some of our delegates from the Patient Safety Conference to also come in. So I request all of you to please settle down. There are many seats which are available on the round tables as well. So I request everybody to please occupy these available seats and settle down. I request everybody to please settle down and take your seats. We are going to start with a very important session next. And this is a joint plenary with the Patient Safety Conference. So we're expecting some of the delegates from the other conference room to come in. I request all of you to please settle down and take your seats. I would also like to take this opportunity to thank our sponsors and partners. Our title sponsor, Microsoft. A big thank you to Microsoft. Thank you also to our platinum sponsors, GS Labs and JVS. Our gold sponsors, Abbott, Google Cloud, Hitachi, Medtronics, ResMed, Samsung, and Tata AIA. I request everybody to please settle down and take your seats. I request everybody please settle down and take your seats. We do have many unoccupied seats on the right side of the hall. I request everybody to please quickly settle in because we are about to start with our next session, and we want all of you to be in your seats and comfortable so that you can enjoy the speeches that are coming up next. They will be eye-opening because there's lots to discuss. I request all of you to please settle down and take your seats. All those who are standing and crowding the aisles on the left side near the door, I request all of you to please settle down and take your seats. We are going to start with the next session shortly. Once again, a sincere request to all of you to please settle down. Those standing in the alleys are requested to please take your seats. I request everybody to please take your seats. Please settle down and clear the aisles.
There was a time when life-saving healthcare felt like a distant dream for millions in India. Critical treatments often required travel abroad, and too often it was too late.
I request everybody to please settle down in the vacant seats. We are going to start the session very shortly. Please settle down and take your
Why can't
seats.
India provide the best healthcare for its own people? In 1983, his vision took form. A modest 150-bed hospital that sparked a healthcare revolution. Apollo has set benchmarks across pivotal centers of medical excellence, and the teams delivers clinical outcomes on par with the world's best global centers. From proton therapy to AI-powered diagnostics to robotics, Apollo invests in life-saving innovations, always putting patients first. Today, Apollo Hospital stands as a global healthcare leader. With its reach extending across the world, Apollo has positioned India as a premier medical ecosystem, offering world-class care to patients from over 150 countries, all at a fraction of Western costs. Its impact, revolutionary. Apollo accelerated India's healthcare growth by a decade, fueling a $375 billion industry and drawing over 157,000 international patients annually. Interestingly, before launching Apollo,
I request
Dr. Reddy
everybody to settle down.
Preventive
We have a
healthcare
number
as
of
India's first
unoccupied
master
seats in the front rows here. So I request everybody to please move up. You'll get a better view of the stage. You'll be able to listen better. So I request everybody to please occupy these seats, the front rows which are vacant as of now. And I request everybody to please settle down. We have a number of seats available on the right side of the hall. Those who are just entering into the hall, I welcome all of you to the International Health Dialogue, where we will be discussing healthcare of the future. I request all of you to please settle down and take your seats. I see a number of people crowding on the left side of the hall near the entrance. I request all of you to please settle down. We have a number of vacant seats on the right side of the hall. So I request everybody to please move inside and settle down. We have the front rows also which are empty. So please be comfortable and settle down. I request everybody to please settle down and take their seats. I also request all of you to please remain in this hall. The west zone of this building will not be accessible as we have the Honorable Prime Minister visiting the building for another conference. So I request everybody to please settle down for this time, because around 1 o'clock we request all of you to be seated inside the hall to follow the security protocols. All of us must be inside the hall here around 1 o'clock. And I hope all of you have had a look at the stalls that have been placed at the ground floor level. Maybe after a couple of sessions, when you have the time, do visit these stalls. So you'll find a lot of innovative ideas, products and solutions coming up in the healthcare space to inspire you. I request everybody at the back of the hall to please settle down and take your seats. Ladies and gentlemen, please give a huge round of applause to welcome our guest of honor and distinguished speaker, Dr. Jitendra Singh, the Honorable Minister of State for Atomic Energy, Space, Prime Minister's Office, Personnel, Public Grievances and Pensions, Government of India. Please give a huge round of applause to welcome Dr. Jitendra Singh at this conference here. I would like to invite our guest of honor and distinguished speaker, Dr. Jitendra Singh, to please come up on stage. I would request Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospital Enterprises Limited, to please accompany Dr. Jitendra Singh on stage. I would also request Mr. Puneet Chando, President, Microsoft India and South Asia, to come up on stage, and Mr. Harold F. Wolf III, President and CEO, HIMSS, to also please come up on stage. I would like to invite Dr. Preeta Reddy and Dr. Anupam Sibal to please come up on stage. We are very grateful to Dr. Jitendra Singh, the Honorable Minister of State for Atomic Energy, Space, Prime Minister's Office, Personnel and Public Grievances, for coming here. I would request Dr. Sangeeta Reddy to please welcome him and felicitate him with a small gift. We are very grateful to him for coming here and sparing his time to address the audience. We are trying to brainstorm on a number of ideas for digital healthcare, for healthcare which is accessible for all, and innovations that are required to make this a reality. And the Ministry of Science, Space, Atomic Energy is doing a lot of innovations to ensure that the benefits of these innovations reach everybody. So I would request Dr. Sangeeta Reddy to please welcome Dr. Jitendra Singh with a small gift from our side. I would request Madhu Shashidhar to also please come up on stage. I would request Mr. Sibal to please address the audience and give us the welcome address. Please put your hands together for Mr. Sibal.
Good afternoon, namaste. The Honorable Minister, Dr. Jitendra Singh ji, a renowned diabetologist, ace clinician, researcher, huge contribution to the world of diabetes. And then we are privileged to have had Dr. Jitendra Singh as a minister now for 12 years. And if we just look at the portfolios Jitendra ji has, earth sciences, science and technology, Prime Minister's office, pension, atomic energy, and everything else that the Prime Minister does. So for Dr. Singh to be able to manage all that and still find time for us today and always, it's indeed a privilege, Dr. Singh. Thank you so much for finding time for us. We have with us Mr. Puneet Chandok, the President of Microsoft India and South Asia. Welcome, Puneet. And Mr. Harold F. Wolf, President and CEO of HIMSS, who's been with us all week and will be with us for the next couple of days. And a very warm welcome to Dr. Sangeeta Reddy and Dr. Preetha Reddy and Madhu, the President and CEO of the Hospital Division. So going to request Ms. Sangeeta for her opening remarks as we start this session. Thank you very much.
Jitendra Singh ji, namaste and welcome. I also want to add that last year in Bangalore, we were so privileged to have you, and I think we're doubly lucky to have you with us for 2 conferences. Science and technology is indeed at the heart of healthcare transformation. Your presence here means a lot. Dear audience, we're really jumping in to a very serious and exciting session. Healthcare of the future, a glimpse of where we're going, what we can do, how we can make it happen together. I'm not really welcoming your physical presence. What I'm here to do is really ignite your intellectual presence and inspire your noble presence, because we're doing something so special. As we move, may I have the slides, please? As we move into the concept of the future of healthcare and look at a glimpse, I'm going to very quickly state some of the things you know, but really try and create this framework of what we can do together. Slides, please. Okay. So as we, everybody, you've been hearing from the morning, aging population, changing technology, artificial intelligence, so many things are happening. What are these drivers of change which is going to make transformation happen for us, and how can we ensure that we use these drivers of change step by step to create this better world? There's technology innovations on one side, there's regulatory and policy challenges and changes. You heard the ministers from Fiji, from Guyana, from Swaziland all say that they now all have digital frameworks. These digital frameworks, I'm going to, excuse me, can you give this to the minister, please? Because that's not visible. Please place this one in front. Can you move this? You can't. Okay. Okay. So the demographic and consumer expectations and this fact that the world is warming, sustainability and global challenges, all these are leading us to think of a reimagined care model, a proactive model, a value-based model, a patient-centric model, an outcome-driven, technology-enabled model with the patient at the center, or actually the healthy population at the center. When we look at regulatory and privacy challenges in front of us, data privacy and security is a big one. It was estimated last year that 190 million patient records got affected during the United Health breach. The HIPAA and the CDPR, these updates are mandating that we have tighter control on cybersecurity as well as on patient data. This framework is necessary. Our National Health ID of the Government of India is a critical enabler of this. Healthcare reform and value-based change, patients are looking for something different. Patients are searching for outcomes that matter. And in Ayushman Bharat here in India, we're looking for coverage of our entire population. Besides this, the other critical one is ethical AI and transparency and the ability to explain. AI and machine learning, as we've been talking from the morning, are transformational. I just want to say, in addition to what Jonathan said in the morning, the factor of growth of application of AI is not 10x, is not 100x. It's more than 1000x faster than humans' ability. But AI is not going to replace humans. It is here to assist and augment. And it is for us to build the AI models that we want, which are collaborative, which are representative of the population. So the time is now for us to stand up, speak up, share data, collaborate, and build these solutions. The healthcare market is estimated, the AI application in healthcare is estimated to be over $208 billion, growing at 37.9% is this data, but our estimate is it's almost double that speed. Genomics and precision medicine. The way you treated patients in the past is not what's going to happen in the future, and the cost of genome sequencing has dropped from $100 million to less than $600 globally, but in India, you know, we're able to do this for less than $200. This is the heart of personalized medicine. Data is driving this, science is driving it, but most important, the appreciation of the fact that gene presentation drives personal health care, and we need to enable this. Medical devices and robotics are becoming the next big area. Surgical robotics, because we are now doing telementored surgery. Proof of concepts have happened of skilled clinicians operating in one city while the patient is in another. Imagine when advanced surgeries and advanced diagnostics can happen in every village in India. Today we have the privilege of working with the government in over 3,000 primary healthcare centers. And whenever we are there, we dream of the fact that we can bring the most advanced care into those villages. Many of these steps are happening, and happening at a pace which is far faster. But also the beauty is that we're able to combine this with traditional medicine. Telemedicine and remote monitoring. During COVID, we saw this 38x growth in the use of telemedicine, including expands to rural areas. Many, many countries across the world adopting this. And layering on top of telehealth, you have augmented care, you have ambient listening, you have transcription. All these models are combining, and the telehealth market will grow to over $455 billion. So we're looking for us to come together to make this a reality for the patient in a framework of value-based care. It's not transactions for the sake of transaction. It is for provider outcomes, for patient-centric approach, for performance-based payment systems, because finances do drive the mechanism, and therefore, how do we bring appropriate care into appropriate environments? Provider collaboration is a critical area, from a GP in a village to a high-end tertiary care environments, a unifying record, a good communication system, a care pathway guideline, technology-enabled, but human-centric is really where this answer is. And quality and outcomes. The Patient Safety Conference is talking about monitoring quality, enhancing quality, using technology. Each one of these are coming together ultimately in a framework of core coordination. I want to move very quickly to one last topic before I conclude, and that is ethics. We need to ensure that as the world moves at this fast pace, we are enabling and embedding ethics and AI into every aspect of digital health and all care. The ethical considerations include all aspects of accountability, efficacy, accuracy, and then adoption. What is the value of a framework is when everybody knows what's happening. So whether it's the ASHA worker in a village or a doctor or a paramedic technician who's treating a patient at home, the adoption of appropriate care pathways and guidelines. Again, this morning you had a fantastic speech on early recognition of sepsis. If you find the onset of sepsis 24 hours before the normal parameters, you can change that patient's outcome and make the difference between life and death. Adoption of these AI parameters are critical. Explainability, so that people know and understand how we can use them, and suitability to which environment. This EASE framework is something that we have published. It's an Apollo Hospitals concept. Like I said, it's open and available for everybody to share, so that we are using an ethical framework, and patient privacy as well as appropriate use is completely adopted at every stage. Two more important parameters in our journey. One is to understand our aging population and the demographic, and the other is to look at customer expectation. But I also want to add one quick thought on mental health and holistic wellness. we must understand that our hospitals are advanced technological centers of curing, but we must build environments and societies of healing that keep the human being and the patient and the mind at the center of it. Not only is the knowledge and the appreciation and the family and societal support critical, self-care and awareness, but also we can use digital and research and innovation in this area as well. You will hear later this afternoon Dr. Alexis Calesi from University of San Diego speak about the brain as the last frontier of innovation. It is a fascinating speech. He's actually collaborating with Elon Musk in brain sensors and sensing earlier. So please don't miss that lecture. And finally, sustainability and global healthcare challenges. Climate change must change the way we look at supply chains and the usage, the way we are more aware of the fact that 5% of global CO2 emissions are coming from healthcare-related sources. The pandemic and public health awareness, the question we must ask ourselves every single day, if the next pandemic strikes, will we be more prepared? And finally, what are we doing for today's problem, which is AMR? There is a powerful antibiotic utilization AI framework to minimize the use of antibiotic and to enhance the effectiveness of antibiotic use. Each one of these aspects are explained. I don't want to take too much time when you have so many fantastic speakers ahead of you, but I request in the presence of the Minister a powerful push for a regulatory framework of antibiotic utilization so that we can reduce the impact of AMR. This is a critical one. Many areas we're talking about today, we cannot forget our basics. And AMR is one of those important ones. It's estimated that 10 million deaths across the world by 2050 if we do not handle the impacts of AMR. With this, I just want to say that the future-ready framework for healthcare is something that we all build together. We come into this conference as individuals with great thoughts, ideas, with organizations of great work behind us and teams. May we leave this conference as a collective and with a healthcare future-ready framework, which looks to enable regulation, to adopt, and all healthcare providers to use it, to support and seek the support of insurance and the payers, to accelerate the pace of pharmacy, the pharma and biotechnology, to build new technology and medtech devices and power these innovations so that, most importantly, we empower the patients to be healthier and happier. This framework of Future Ready has the enablers, which is the government, the healthcare engine, which is all of us, providers, payers coming together, tech companies, medtech, pharma. And finally, the outcomes of this will be the transformation of healthier, happier communities, faster survival rates, quicker recovery, early detection, proactive preventive healthcare. Each one of these is part of this healthcare future framework, which recognizes, most importantly, the care continuum, which starts with the healthy individual, goes on to the family practitioner, and connects the high-end hospitals back to every element of the healthcare ecosystem in a frameless network, because the hospitals of the future are digitally connected to the ecosystem or the healthcare ecosystem of the future. These are a few thoughts that we must come together for towards one thought, which is achieving healthy longevity. The convergence of science, data, and the concept of awareness and preventive care will lead us towards this healthy longevity. We will accelerate science and medical breakthroughs. We will share data and create personalized health environments, predictive analytics, and use wearables and genomics, all coming together with the idea that when a cardiothoracic surgeon has stopped the heart and is repairing 5 vessels, do you know what's going on in his mind? The first thing is, of course, please let this patient survive. Let me send this person back to his family. But the other thought when he goes home in the evening is, where was this patient when his first vessel got blocked? Let us push for early detection and prevention. Let's make diagnostics of the first beginning signs of all lifestyle-related non-communicable disease easy, affordable, accessible, available at every corner. and bring that together in proactive preventive healthcare towards healthy longevity and a healthier and a happier world. We're breaking the traditional boundaries of a hospital-centric care to build a seamless, tech-driven ecosystem, one that prioritizes prevention, empowers early detection, harnesses new age precision medicine, and creates healthier population. I hope this is our joint declaration for the future. I thank you all for your presence, your partnership, for the great work you're doing and the great work that you will be doing in the future. I thank all our speakers, sponsors, and especially convey my thanks to the Apollo family, and a very, very grateful thanks to our Honorable Minister for everything that he does as he advances science and technology for the benefit of humanity and for his presence here. Namaste and thank you.
Thank you very much, Dr. Sangeeta Reddy. I distinctly remembered about 12 years ago, you made a comment in a presentation where you talked about bandwidth, biology, and bytes. And there were many skeptics at that point in time, like, is tech really going to change medicine? And look at it today. We can get a whole genome sequence in 14 days at less than $200. And it's really defining the way we diagnose conditions and the way we manage them. Thank you very much for your remarks and setting the stage. Now, all of us here have one smartphone, maybe two. We also have a laptop. And if it wasn't for Microsoft, what would we do with those machines? So thank you, Puneet, for all the offerings that you bring and the innovation that you bring. May I invite you for your remarks. Puneet.
Good afternoon. Thank you. Thank you, Dr. Sangeeta Reddy, Dr. Preeta Reddy, Honorable Minister, sir, and all distinguished guests. It's such a privilege, such an honor to be here as Microsoft. I thought before I get started and talk about AI and healthcare, I thought I'll tell you a quick story. I usually get inspiration from books and stories, and I went back to a book that was written in 2012, a book called Nexus by Ramesh Nam. It's a fascinating, futuristic techno thriller, if you will. But there's a character in that book. Called Feng. And Feng is a brilliant scientist, but he's got a neurological disorder. And he's got a brilliant mind, but his body gives up. Right? And the book is about the struggle he has because his mind is still curious and active, but his body is completely immobile. And the protagonist in that book, a guy called Cade, actually comes up with what he called Nexus, which is neural implants. But basically what they do is they rewire his brain. They literally refire his brain once again. And I distinctly remember that moment when Feng moves his fingers for the first time after many, many years of being immobile, gets his body back, gets his energy back. And I think that to me was the miracle of technology. And the reason I'm telling you this story is because technology sometimes seems like technology is about control and power and capitalism. But at the heart of it, technology is about healing. Technology is about hope. Technology is about lifting people up. As Sangeeta said, I think that's one vision for AI that I always go back to. Can we heal the world? Can we bring more hope? Can we bring more energy back? With that, I thought I'll quickly touch on three things. First, what's happening in AI? Why is AI consequential? Second, what's happening in healthcare with AI? And then third is Microsoft and Apollo. What are we trying to do? Let me start with AI. There's a lot of AI washing going on. You can't be in a conference today and not talk about AI. But I genuinely believe AI is the most transformative technology of our lifetimes. I've been in tech for 25 plus years. I've never seen a technology like AI. It's truly a platform shift. And anybody who's been in technology knows Moore's Law. Moore's Law has run technology for the last 70 years, which basically meant that every 18 months, we could double the performance of the chips we were building. So every 18 months, with the same compute, same capacity, same capital, you could double your performance. But with AI, that's shifted. With these deep neural networks, we're doubling performance every 6 months. Every 6 months, we can double the performance of these compute capacities that we are building. And that has massive implications. And I think there are three implications for all of us to think about. One, for the first time, we've got the ability to manufacture intelligence. For the first time as humankind, we have the ability to manufacture intelligence, and there's more intelligence coming at your fingertips now with AI. Second is empathy. You think of technology, you typically don't think of empathy, but there's more empathy coming as well. These AI technologies, these co-pilots that we're building will have a personality, they'll have a tone, they'll understand your context. and they'll have a new way of connecting with you. And third is agency, which is when these agents, when these co-pilots start acting on your behalf with your permission but not your involvement. With your permission but not your involvement when they start doing things for you. So that's what's going on in the AI world. You'll see a lot more intelligence come in. There's a beautiful quote, I forget who said this, but somebody said that intelligence is a beautiful property given only to humans. That quote is not true anymore. It's not just only humans, it's machines now which are bringing intelligence to us. Second, a lot more empathy. Third, a lot more agency. And by the way, Sangeeta spoke about the speed of innovation. In the last 48 hours, if you haven't noticed, there's been a stunning innovation. All of us who studied chemistry, we knew there were 3 kinds of matter. Now we've developed a 4th kind. And this new chip that's coming out, and I don't know if you followed it, if you've not, go read about this, Majorana, which is taking us one step closer to quantum computing. We can actually put 1 million qubits on a chip now, potentially. And this is just 1 million qubits on a chip, but another thousands of qubits, logical qubits on the chip. Imagine the impact of that. All the problems that were out there which were unsolvable for us, this dream of quantum computing in the last 48 hours has changed. Again, so that's the pace of innovation that's happening around us with AI. I think quickly on healthcare, why do I believe it's a consequential opportunity for us in healthcare? I'm a data nerd. I'll give you 3 statistics, 80%, 70%, and 33%. And let me explain these to you. 80% of patients today claim some amount of dissatisfaction with healthcare. 70% of patients believe that they can use digital channels to interact with healthcare. And 33% of doctors today are saying, listen, we're burning out. So 80%, 70%, 33%. Bring these 3 statistics together, healthcare is crying for innovation. I'll give you another statistic, 33%. A third of the world's data today is created by healthcare. A third of the data that is being created in the world is coming from healthcare. More than 97% of it goes unused. More than 97% goes unused. And that's why healthcare is crying for innovation. There are 2 questions that we should think about. One is, can AI solve these problems? The 80, 70, 33% problem? The answer is yes. And it's already starting to happen. It's not science fiction anymore. AI is helping become doctors far more effective and efficient. My favorite story on doctors is you go to any hospital in India, the first-year doctors are out of work, the 20th year doctors are out of time. Because everybody wants to go to the 20th year doctor. Everybody wants to go to the HOD. Same with lawyers. You want to go to the best lawyer. Same with teachers. You have kids, you want to go to the best teacher for your kid. And now with co-pilots and with AI, we have the ability for the first time to bring as much intelligence, as much information, as much expertise that a 20th year doctor had to a first-year doctor. And I think that's the beauty of AI. The other question we have to think about is, given our context in this country, how do we truly leapfrog the West as we build healthcare in this country? And the answer to that is yes as well. We can make affordable healthcare a possibility in this country by bringing AI and clinical capacity together. And that's already starting to happen. Finally, the last thing, and that brings me to the partnership between Microsoft and Apollo that we are really excited about. This is the partnership that goes a long way back. In 2018, we came together to build the first AI-powered cardiovascular risk score prediction, which we were really excited about. And since then, we've been co-building. But now we're very close to what we call clinician co-pilots, going back to this piece around bringing information, expertise, judgment to doctors to make them far more efficient and effective. I started with the book Nexus. I started with the point that technology can help bring healing to the world, bring hope to the world, can lift people up. And partnerships like these, which we are so honored to, and a big thank to Dr. Sangeeta Reddy, Dr. Preetha Reddy, the entire Apollo family. As Microsoft, we are so committed to this. And we really hope that we can come together with Apollo and several of you and really bring healing, hope, and lift everybody up together. With that, a big, big thank you. Thank you for having us here.
Thank you very much, Puneet. And from Microsoft, we now move on to HIMSS. We have the privilege of having the CEO of HIMSS, Harold F. Wolf III. HIMSS is an organization which is transforming digital health globally with more than 125,000 members. It's a not-for-profit, and we are delighted to have Harold with us. Harold.
Good afternoon, and thank you so much for this opportunity to address such an important international dialogue around health, and a special thanks to the Apollo management and team that has done such a phenomenal job of building this conference up into something which is extraordinarily important and needed, and literally in every corner of the globe. I'd like to take a second just to give you an understanding of HIMSS. Our vision is to realize the full health potential of every human everywhere. And sitting inside of that is the absolute cornerstone of health equity. And our mission is to reform the global health ecosystem through the power of information and technology. And what you have heard consistently across the day fits right into that mission statement, which we're proud to support. HIMSS is a global entity operating on every continent. And because we are member-driven, what you hear from our advocacy and our thoughts and our frameworks and our maturity models are the culminations of experience from every corner of the planet. So let's talk just for a second about the challenges that are sitting inside every healthcare system, because this is something we are all facing. We continue, and this is a blessing, to have an aging population. People are living longer. India is absolutely no exception to the rule, and in fact is at the forefront when you look at the average age of death in 1947 versus where we are today. It has nearly doubled, in fact has doubled. When you look up at chronic disease burden, it continues to increase. There are two factors behind it. One, we're living longer. And secondly, we can diagnose chronic disease management better than we ever have before. So we understand the disease burden. We can see it and we can treat it. And advanced systems take a very important measure in that regards. But our challenges on geographic displacement are known well here. And they are not necessarily rural versus city. There are many people that live within the shadows of some of the great hospitals that do not have access. And so this gets back to our challenges of how do we take the incredibly valuable resources we have and stretch them forward to their maximum benefit of the population, our citizens, and those that look in our charge. Our funding models will remain challenged, and these will continue to come. And we have an issue of a workforce which in different levels are strained, whether nurses, physicians, practitioners at every level. We must find a way to take our encounter-based paradigm and move it forward. So, this word, anomaly, is really how most of us in healthcare think about our daily world. It is identifying in the individual or in the population the idea and the concept that anomaly has occurred or is going to occur. Because there is the norm, which is all of us, but when something is aches, when something pain occurs, when a sickness arises, what we do in healthcare is we work to identify the anomaly. And once we identify it, we bring it into a care pathway for the delivery of care. And this simple definition helps guide where we are headed in terms of our use of technology. And digital health transformation is fundamentally taking both the operations, the sustainability of practice, and we'll talk about sustainability in just a moment, and improvement of clinical capabilities to match the needs of our workforce and to extend these precious resources so that each and every one of us knows that the anomaly inside of us that is either here or to be defined can be brought forward. Now, sustainability, we have talked many times on the stage today about environmental, but it is really three levels of sustainability that we face in healthcare. One is the practice of how do we teach, how do we actually care for the population without stressing the resources that we have already under tremendous pressure. Second is sustaining the system itself, from a financial standpoint and from a structure standpoint. And then finally, the environmental, which to me is an underpinning and a lens, so that each time we make an investment, each time we come forward with an understanding of what we are putting in, we must do it through the sustainability of the environmental lens so that our changes support mankind. Now, we've talked about change, and I'm always reminded of this particular phrase that I would like to bring forward and remind ourselves. The incandescent light bulb did not come from the continuous improvement of a candle. It didn't. Because the leap between a candle and a light bulb, they are both illumination. But what we are asking for, and what we heard earlier, is the leap from a candle to a light bulb in a new way, because it will take a bold move, a bold change. This is where you really hear the desire and the impact of AI to be brought forward, because without it, we're just going to continue to see the candle improved. And in the middle, if you can't quite see it, it's a light bulb with a candle. And so that's really wasn't going to get the job done. Now, some of you will realize that artificial intelligence, it's already here. It's not new. In the rings that we wear, that are diagnoses, or our watches, or our phones, we're all using AI already. But I do want to break it up into 3 bits, because we have a tendency to merge it all together. One are the devices, which are critically important because they will engage the individuals and help us find the anomaly. The second is in operations. And this is where I see the deployment of AI extensively around the world, growing at a very fast pace. In some healthcare systems, literally hundreds of applets are running each day. So when a person walks up to the desk and they say what is ailing them and just a little information behind it, predictive modeling can tell us what resources they will consume. Do we have them on site in order to take care of them? What supply chain will be necessary to pull itself all the way through? How long they will be with us? And what degree of income or expense will come with that individual? And this is making a significant difference in our operational layer. And then finally, the third piece is the clinical decision support. And you've heard comments about it, which is true. But this is actually where the knowledge management and the suggestions come forward to help a clinician to make the right decisions. This is critical. So where does AI actually go? I think this is what our battle is in the next year, or actually a few, which AI becomes our next leap of scope of practice. We have made tremendous strides in bringing nurse practitioners forward to allow them to practice at the top of their capability, and physicians stretch forward as well. AI will come behind that to support our clinicians and allow us to move forward with grace and speed. But nothing will be successful with technology itself. Success is delivered through people, process, and technology. Our technology, whether in AI, machine learning, or the basic elements that are being brought forward, will only work when we train our staffs, our workforce development, and we bring our staffs along to maximize the use of these new technologies. Or we will continue to use old processes and stay with incremental gains of our candles versus our light bulb illumination. HIMSS does a tremendous amount of work in the frameworks. I encourage you to look on HIMSS.org. I won't go through each and every one. But I do want to leave you with this very important formula. This is NT plus OO equals COO. And this means very simply, new technology plus old organization equals a costly old organization. The investment we make in technology, the way we drive forward with our capabilities, will be paramount to the success in the implementation and the use of these brave new technologies that are in front of us today. And with that, I say thank you for your attention and being a part of this amazing opportunity. Thank you.
Thank you very much, Harold. It's now a privilege for me to invite Dr. Preeta Reddy, Executive Vice Chairperson of Apollo Hospitals, to say a few words. She has a very holistic perspective on how we practice medicine. So over to you, Dr. Preeta.
Honorable Minister, Sangeeta, Puneet, Madhu, Anupam, and Hal, what a presentation. Thank you. I decided a couple of seconds ago that I do not want to be a COO anywhere. So thank you for that intelligence. The presence of the Honorable Minister really takes us and validates the fact that we really have to move forward into a completely new realm of the way we deliver healthcare. We have to deliver healthcare responsibility. We have to deliver healthcare for a global population. But more than anything else, I think we have to focus on the fact that we want to keep them well. You know, if we can use AI, if we can use new tech, if we can use the wearables and the devices and the intelligence and everything which is available in the universe to keep that patient, that person needing healthcare out of the crisis, out of interventions, I think it would be a job well done. And all of us today here are committed to that. We're on the right track. But God forbid, if somebody really needs that kind of intervention, we have the blanket of patient safety, which we've been learning about, and we have the intelligence of artificial intelligence. But we as a human race have to realize that we have to drive that driverless car. Whichever way we do it, we have to get it right. And that's why when we talk about high tech, we always have to remember that it's the high touch which powers high tech. And so when people are frightened about artificial intelligence, when old organizations are concerned, can we adopt to this kind of technology? We have to be there to reassure them that while you're adopting to high tech, while you're moving to a driverless car, always remember that it is the human intelligence, the human brain, and the human heart which will control what you do, especially in a healthcare environment. So having said that, I think I'm delighted to be here, and this conference just takes us, and it's an added responsibility that we have to do what we do and to do it really well, because we don't do it for ourselves. We do it for the people, the millions, the billions of people who trust us and who need healthcare. And so it takes us on a path to see what is next, because we need to be agile, we need to be aware, and we need to be absolutely accurate in what we do. And that's where the fourth A, which is artificial intelligence, will come in and make us better providers, better human beings, and give us healthcare for the human race, for our future generations, because I think that's the responsibility. Thank you all very much, and God bless.
Thank you very much, Dr. Preeta Reddy. For those of us who've not had the privilege of hearing our Honorable Minister, let me say that he quotes facts, statistics, there's a lot of wit, there's humor, there's Indian cinema, there's a bit of medicine, there's economics, there's politics, there's a lot of wisdom. May I please invite the Honorable Minister, Dr. Jitendra Singh Ji, for his address. And the other very interesting thing is, his team gives him a written speech which he brings but never looks at.
Thank you, Dr. Sibal, for your kind introduction. I think you raised the expectation levels too high of the audience over here. So, Nevertheless, the chairperson of this afternoon session, Dr. Sunita Reddy, Dr. Sangeeta Reddy, Puri Chandok, Harold Wolf. At the outset, I must confess it's a unique privilege to be seated between one of the most illustrious health leaders from India, Sunita and Sangeeta. It's always a learning experience to be with them. And I also must compliment the Apollo group, indeed the Apollo family, for having organized this very thoughtful and appropriately timed two-day meet, as they carry the reputation which precedes them wherever they go. They always are ahead of others in organizing or thinking what others think tomorrow. So I must compliment you for that. And gives me a personal delight also because I have been associated with the Apollo family, I was just telling Sunita, for almost any number of decades, 3-4 decades, because my guide and Dr. Pratap Reddy happened to be very close friends. And therefore, Dr. Pratap Reddy enjoyed the reputation of doing out-of-box things, taking revolutionary initiatives. And they were, of course, the first ones to bring the health sector out of government domain when it was hardly visualized. And I don't know how many in this room are aware, but I'm sure Sangeeta and Sunita would bear me out, if not wholly, to an extent. When Pratap Reddy launched the first hospital, people would make fun of him. And some of my elders, because I was too small, a young medico in my, I think, first year, some of my seniors would tell me that during the inaugural ceremony itself, they could hear people whispering in the audience that, look here, Pratap is a very shrewd businessman. The day is not far when he's going to convert this hospital complex into a multiple cinema or something like that. Content. So Sangeeta is bearing me out. So it was such a difficult decision because you hardly had a standard healthcare option outside the government domain. You didn't have any medical schools outside the government domain, and he took up the cudgels to do so. And then, of course, first to move on with some of the latest state-of-art healthcare facilities, many of which have arrived in the government sector after they have actually successfully tried them. Their R&D component is very strong, and academically, of course, you can see from the nature of this two-day meet, they have been actively involved. And as far as the collaboration is concerned, while I said they were the first to move the healthcare sector out of the government domain, they also evolved a very beautiful model of striking a synergy between the government sector and the private sector, a very wholesome, a very compatible energy with the mutual benefit of the two. And therefore, this international health dialogue is happening at a time when India is placed globally as a cost-effective, quality healthcare destination. And increasingly, this is being acknowledged, recognized across the world. And the world is now looking up to India also because some of the recent success stories that have been registered, and they also look forward to emulate these. For example, before I take up some of the issues that have been raised by Sangeeta and also by Harold very nicely, I think one of the landmark success stories emanating from India is that of the Ayushman Bharat. And as a medical professional, most of you would agree with me, I think it's the only health insurance scheme of its kind, possibly across the world, or maybe the first one, which allows you to get yourself insured even for a pre-existing disease, which never happened, because as medical practitioners, we have come across so many cases. If you suddenly had a myocardial infarction, or you were detected having type 2 diabetes mellitus, or detected having a malignancy, and even if you went in for a treatment, the insurance company would try its best to prove somehow or the other that you had not disclosed the underlying heart disease, and therefore you were not entitled to it. You were entitled only if you came back with a healthy. So the healthy organ, according to them, was insurable, and by their standards, almost every organ would be unhealthy to one or the other extent. But here you have the malignancy detected one day. And the next day, you go and get yourself insured, and the third day, you get yourself in for the management. So that's, I think, the most beautiful enabling part of this insurance scheme. We have about 1.5 lakh wellness centers in the pipeline. And also, this is the government headed by Prime Minister Modi, which is first time set up a separate ministry for Ayush, the Oriental systems of medicine, which have increasingly gained acceptance across the globe now. Since I belong to a generation of professionals who have seen the transition happening, and we also have seen, to an extent, even we too could be part of that, who held a certain amount of contempt against the Oriental systems of medicine. But I think the turning point was the COVID. In the middle of night, I would get phone calls from some of my contemporaries who had moved over to US or Europe for several decades earlier. They would call up and ask me, can you find a booster in homeopathy? Can you find a booster in naturopathy? So faced with the threat of death, they recognize the value of the Oriental systems. And therefore, India is now, I think, the exclusive country which has this advantage and opportunity of providing this integrated system of healthcare. We have a national digital health mission because along with the traditional knowledge, which is our exclusive domain, we are also beautifully striking a fusion with the cutting edge technology. And already about 300 million health records have been completed. The recent budget announced by this government mentioned digital repository of traditional Indian knowledge. So look at the thoughtfulness with which the phrase has been coined. The repository is that of the traditional Indian knowledge, but the method of creating that repository is going to be digital. So that itself conveys a lot of connotations. In the CSIR also, because of multiple departments that I'm associated with, one of them being CSIR, we already have something called TKDL, Traditional Knowledge Digital Library. And as I said, 2014 turned out to be a turning point because we never had a dearth of potential in this country, or dearth of talent. We had the capacity, we had the passion. One of the departments they mentioned about during my introduction was that of space. So you could recall in the archive the pictures of Sarabhai carrying some of his stuff on the carriage of bicycle. So much of talent struck back because of the lack of an enabling milieu which is expected from the policymakers of the country, from the political dispensation. And that lapse was made up after 2014 when Prime Minister Modi came in. And therefore, it's not the age to talk without evidence, because either I convince you or you convince me, otherwise you'll go back home saying that I was just fulfilling my ministerial obligation by talking all these laurels. So if you see even statistically, there has been a series of evidence-based success stories which have enabled India to gain the kind of esteem which has changed India's perception in the eyes of the rest of the world. I think beginning from the vaccine story, which I think is very important from the point of view of the theme that we are discussing today, because India was never taken seriously a country or even a society which gave much of a priority to healthcare system. Leave aside the professionals sitting over here, even among the common men. If somebody fell sick, they would wait for 3-4 days before they saw a consultant. Otherwise, they wait for the mother's blessing to get well back. Or if they worsen, they curse their own previous janam karma. So ultimately, they had their homemade placebos both ways. But a country like India, which was never taken seriously by the world for therapeutic healthcare, but for curative healthcare, is today being hailed as a leader in preventive healthcare. So such a sea change is a 360-degree change. And that's happened because we have very successfully optimized the use of traditional knowledge and also the cutting-edge technologies in a synergized manner. We are the first to have come out with the DNA vaccine, gifted it to the rest of the world for COVID. We have now come out with the HPV vaccine, which is to be used in the prevention of the cervical cancers. We have also taken a lead as far as our biotechnology initiatives are concerned, because the entire growth hereafter is going to be biotechnology driven. The next revolution, of course, as most of the economists across the globe believe, is going to be bioeconomy driven, unlike the IT driven last revolution of the 1990s. And that is very closely related to the subjects, the devices, the instruments that we are talking about this afternoon. And if you take that, as I said, we have been taught not to speak without evidence as good students of science. Before 2014, we were just about 50 biotech startups in this country. Today, we are over 9,000. Our bioeconomy just stood at $10 billion US. Today, we are more than 130, 140 billion. Soon, we look forward to be $300 billion. In biomanufacturing, which has been referred to in one way or the other by speaker after speaker, I don't know how many in this room would be aware that we stand rank 3 India Pacific and among the first 12 in the world. And that has happened only the last 1 decade. So actually, we are in the right trajectory and we are moving very fast. There's been a quantum leap in the last half a decade or 1 decade. Very recently, just about 2 months back, we have come out with the first ever indigenously developed antibiotic called the nephromycin. Because all the other antibiotics which we were using till now, beginning from penicillin, which happened in the late 1940s, which was hailed as the queen of drugs, then the successive generations, the streptomycin in the beginning of the 1950s, and chlorphenicol, etc., penicillin, and so on and so forth. The salt would be developed outside, the trials would be done outside, we would be just manufacturing or even marketing. Here we have come out for the first time, the salt from here, and the marketing is being done by one of the Mumbai-based pharma houses called the Vocard that all of us are aware about. And we are also the first in the world to have successfully conducted the first phase of the gene therapy trial in one of the bleeding disorders called hemophilia, which happens as a result of the deficiency of clotting factor 8. I am glad that most of these departments are associated with me. The trials were done in the Department of Biotechnology, in the government sector, and the clinical trial was done in the private sector in the Christian Medical College, Vellore. And this doesn't need any more of validation from me or you, because last month, none less than the New England Journal of Medicine came out with a write-up exclusively dedicated to this trial. So New England Journal of Medicine, most of those who have been students of science, scholars of science would bear me out, is one of the oldest journals in the world. Belongs to the times when the entire science, including the medical science, was controlled by United Kingdom before it was taken over by the Americans somewhere in the late 1960s and 1970s. And the New England Journal of Medicine, the British Medical Journal, were the 2 oldest journals. So it doesn't require any more validation because it would not publish a piece simply by lobbying or some other consideration. So we were there. We have already completed in the government sector gene sequences of 10,000 individuals, Indians in this country, from different races. We calculated we have more than 4,000 different racial groups in this country. So this is a beautiful pool for research. The other day I had a group of some youngsters from Germany. They were keen to do a health project over here. They asked me, what disease would you suggest me to it? I said, you tell me the disease and I can offer you one. So it's a beautiful country for research, huge resource pool. It's also beautiful for dispensing health. So we, out of those 4,000 odd racial groups that we identified in this country, we have taken about 10,000 sample sequences from different races, not covering all of them. And I hope by the first phase, we'll reach about 1 million very soon. And as far as the use of the latest technologies is concerned, I think today we are at par with what is happening in the rest of the world. And I must compliment Apollo for having taken a lead there. The latest cancer options that are available across the world are available there. And I am sure what I'm saying is, it will be very well understood by those who have seen what was the scene like about 2 or 3 decades back. If a VIP had a heart issue, he would immediately be transported over to Houston for a bypass. So that place called Houston became well known in India because of the VIP traffic moving over there. But it's no longer so. And the artificial intelligence and telemedicine, I'll speak about it a few moments later because Sangeeta has raised some relevant points about it. But when I'm talking of the latest technologies we are using, I think it will be interest to many of you over here who have already had the holy dip or looking forward to have one in the next few days, is that we have come out with a purely indigenous, the first of its kind technology, which is taking care of the hygiene of the sewage disposal at the location in the Prayagraj. Because otherwise, I was telling the media persons also, you come here, take all the bites on spiritualism and everything else under the sky, but you never bother to think why there's no stink, why there's no disruption of hygiene, why there's no outbreak of epidemic. Because using nuclear technology, we have set up there what is known as fecal sludge transplant plants, treatment plants, so FSTPs. They diffuse the sewage because every day we are having almost 1 to 1.5 million liter of liquid fecal sludge emanating, and it would have caused havoc by now. So that is converted into an inert liquid which can be used for gardening, which can be used for irrigation. That's something which only India has come out with. So I don't know whether that clap is for the facility or for the Kumbh, but whatever it is, it flatters me. So the media doesn't report that because they are more interested in reporting who abuses whom, and then somebody abuses me, they come and ask me, how do you feel you are being abused? And I say, no, I feel very well. Because that's the best way to close the chapter. Otherwise, if I repeat the abuse, then the debate goes on till 9 o'clock in the evening. Nevertheless, now coming back to what we were talking, the point here is that we are now also no longer following the leads, we are also offering leads to others because we have our circumstances, because the Kumbh is something which will happen only in this country. Managing the fecal sewage of 50-60 crore is a privilege given only to us. And if you take it as an opportunity, it is a privilege to develop a technology also given only to us. And that is something which was realized even later on, because even in the pre-independence era, some of the diseases, they had researchers from Great Britain coming all over to India. In the General Hospital in Madras, if you go to the pathology section, you have a small plate over there. It's written, it is this room where Dr. Donovan worked and discovered the Donovan bodies. So most of the tropical diseases were in fact being studied even by the Europeans in India, even 100 years back, 150 years back. Now, as far as I mentioned in the beginning, I think, as I said, we had everything. What we lacked was possibly an enabling will which is expected from the policymakers and which happened after Prime Minister Modi came in. And therefore, I think it's important also to put on record some of the very, very important flagship initiatives by this government in the last 5-7 years before I move on to talk what I need to talk after this. Just to enumerate, we have the Mission Suraksha, which was launched during the COVID times. The monitoring of this was done every day, sometimes even personally by the Prime Minister. That's how we were successfully able to come out with the first ever DNA vaccine, because usually don't get such kind of a patronage from the political leadership. We have the e-Sanjeevani, where our 24 crore of teleconsultations have already been accomplished, and to provide accessible and affordable healthcare, we have 22 new aims. Even in the current budget, there is provision for new medical college. We have a scheme called Pradhan Mantri Swasthya Suraksha Yojana in order to upgrade the existing medical colleges, as was being discussed by the speaker after speaker. And of course, the initiatives like the TB Mukta Bharat, etc. We already have more than 5,000 world global potential health startups in this country, and our leadership in the G20 health group, of course, was noted across the world. We have come out with some of the futuristic initiatives. For example, we are the first, I think, in the world who have brought the biotechnology to get aligned with the space technology. So very recently, in fact, I only suggested that we have got the Department of Biotechnology entering into an MOU with ISRO, because now the time has come and you will be talking also of space physicians. And I'm sure in the conferences in the next few years, you will have one session devoted to that. So there will be new specialty coming up, space biology, space medicine, because the astronauts have started living over there longer and longer. And when you have the the space stations over there. Besides that, we have also started experimenting the SpaceX itself. We have experimented growing of some seedlings in the space milieu. So these are some of the initiatives which have been taken up or undertaken by India before anyone else did. We also have, it was this government which took the decision of one nation, one subscription, which is very relevant for all of us, because when we were scholars, students doing our thesis, dissertations, that was one of the biggest constraints. Most of the journals from abroad would come by the ship. They would arrive 2 months later. By that time, we would have moved on to the next generation. And if you did a thesis, your guide would ask you to consider the British Council Library. Once you went there, they would say, yeah, they have the book, but it's been borrowed by the consulate office in Calcutta, so you have to wait for another 2 months. So by the time it came back, it was underlined red, blue, black by different borrowers. Now it's no longer so. You have the IT and you are actually combining the two, and we have tried to simplify it on our part by coming out with this one subscription scheme for all the teaching institutions. But nevertheless, the challenges are manifold. And I was telling Sangeeta, this requires a very sustained effort, and it will continue, because we are different from the rest of the world in more ways than one. We are a world in ourselves. That's why we are also called a subcontinent. Now, if you, as a medical professional, I think the first two challenges are that our disease spectrum is biphasic. And I'll just take a minute to explain you how. When we started off as medicos in the MBBS, my seniors would tell me, if you read syphilis, you read medicine, because it covers virtually everything. Because that was the most amount of morbidity and mortality happened because of the communicable disease, the infections, the cholera, typhoid, tuberculosis was very notorious. We had some of the best sanatoria in India. The Chennai's Tambaram Sanatorium was considered to be among the best in the world. Yeah, and tuberculosis became a dead monster, even deadly monster, even known in the literature and society. If you had a triangular love story in a movie, you conveniently afflicted one of the characters with tuberculosis and got rid of one and had the other two happily married after. So, and syphilis was one disease. It started off locally, then in the secondary stage went to skin, tertiary stage went to brain, went to heart. So they said, if you read syphilis, you got. But by the time we entered into our post-graduation residency, the dictum changed. It was, if you read diabetes, you read medicine. Because you have neuropathy and nephropathy, everything hard everywhere. And we happily started believing that now that phase of non-communicable, the communicable disease is over. Somebody in a lighter vein wrote a piece that India has now entered into an age of civilized diseases. So we are now dying of diseases which the Westerners die of. A massive heart attack, or a massive, we don't die of tuberculosis. But that was not true. It was very short-lived with the eruption of COVID and what followed. Now you have, and that's why I say it's a biphasic spectrum, which only India has. You have the non-communicable disease equally number prevalent over here as anywhere else in the world, even more. Like, for example, type 2 diabetes, all the metabolic disorder-related diseases. And upon that, the irony is that the regional divide is gone. Earlier on, most of the metabolic disorders and the type 2 diabetes mellitus, etc., were confined to South India. That's why most of the research also emanated from that. It was not much heard of in North India. Now we have equally much. There was I did a paper in JAPI about 15 years back, breakdown in rural-urban divide. Some of the diseases were confined mostly to the urban areas, no longer so. Because in the rural areas also, you are having the similar kind of lifestyle. You don't grow your own vegetables. You take the same tin stuff which you are being served in the towns. So finally, that has multiplied our challenge. So it's a bi. And similarly, the other biphasic factor is the lifespan. Harold was mentioning the issue of aging. Harold, if you spare one moment from your AI-driven IT. So that is what he was mentioning. When the olders adopt AI, they end up as what Sunita said, old classmates. But what I was saying is, Harold was very nicely mentioning, very rightly mentioning about the issue or the challenge of the increasing number of aged. But here in India, again it is biphasic. We are known as a young country. And we take pride in saying so. And rightly so, because 70% of our population is below the age of 40. And that's why we say we are a young country. But that's only half of the truth. The other half of the truth is that if you take statistically, even though we are 70% below the age of 40, the absolute number of the elderly is also on the increase, which means that youngsters have increased, but the elders have refused to quit. So average lifespan at the time of independence was just about 50, 55 years. Now it's gone up to 65, it's nearing 70. And how does that imply over here? We are living long enough to have the disease of the later age, which didn't happen earlier because you died so early. You were saved of the disease. The only way out is they die early. So you don't get disease of the old age, which is not possible. Nobody would opt for that option. The other part is, and that is more challenging, that the diseases of the later age are now happening at the younger age. I think that is the most important challenge, which also I will come to that in a minute, what Sangeeta was also referring about the preventive part of it. For example, if in the earlier years, if you received a phone call, somebody getting detected as a diabetic or type 2 diabetic, you would visualize the face of an individual in his late 40s or so. Now it's almost even in the third decade happening, in the late second decade also. So that age, I think it's true democratization now happening. So nobody can accuse each other of the bias. So everybody is being equally treated by the nature. But that's a huge challenge for us. And that is not only the responsibility of a medical professional or the health leaders, it's a national responsibility as well. As sometimes I say in the context of diabetes, because that's the field I deal with, the diabetes is too serious to be left to a diabetologist alone. And that is after paraphrasing what Mark Twain once said in the context of economics. He said economics is too serious to subject to be left to an economist alone. If you do so, you have havoc. We've seen that happening in this country. Anyway, now that is also a national responsibility, because as I was seeing the brochure that Sangeeta gave me, they have more than once mentioned Viksit Bharat. Now, who's going to create that Viksit Bharat? These youngsters who are going to be in the prime of their career, prime of their potential, prime of their energy 20 years hence. So, preserving their energy for a bigger cause, it becomes our responsibility. We can't allow that energy to be squandered at the altar of metabolic disorders or the altar of the other disease. So that's another challenge now. And then, of course, the Indian phenotype is also different. We have a number of studies to prove even those who've gone to settle down in the UK, Europe, other countries for generations together still continue to have a greater preponderance for type 2 diabetes mellitus, for metabolic disorders, notwithstanding the rest of the factors having changed. And our biggest issue is, of course, the central obesity, which is now equally prevalent almost among the males and females. I mean, that's again very clear, because most of the other things are more in males and the females. There's hardly any difference. You have about 62, 65%, maybe little more in males, lesser in females. And central obesity, as all of us would know who have been dealing with this area, is an independent risk factor, independent of the overall obesity. A Westerner may look, now Harold looks bulkier than me, but inside I may be bulkier. In fact, we did that. We did a scan with Yagnik in Pune about 2 decades ago. We scanned n number of Westerners, n number of Indians, Asians, and we could prove that. The advantage we have is that you can choose a long kurta to wear, you can use a 6-meter sari to wear, and you get away with it. So, but this is what is causing fatty liver. Every third individual in India today has a fatty liver. And most of them not getting now non-alcoholic liver cirrhosis. The other day, I had a person who has been my patient for many long years, and he was quite distressed when he found himself having been detected cirrhosis. He said, "Sir, kabhi nasha nahi kiya, kabhi ye nahi kiya, kabhi ye nahi kiya, phir bhi ye ho gaya." तो मैंने कहा भाई तुम्हें किसी डॉक्टर ने तो कहा नहीं था कि ना करोगे तो नहीं होगा. So who are you going to? So the point is that these are multifactorial outcomes, but we have now identified some of the factors which at least if not wholly to an extent, can be controlled. And therefore, Indian solutions for Indian problems, Indian remedies for Indian diseases, and Indian data for Indian research. And I'm glad the Apollo is very illustriously contributing to that. And as I said, now there is also a huge rural-urban divide. Now, some of the issues which were raised by the earlier speaker, the use of AI. Now, to put it in a single sentence, after having heard what Sangeeta said, after having heard what Harold said, is that one has to be intelligent enough to use artificial intelligence, otherwise please don't use it. First, go through some parameter to prove to substance that you are intelligent enough. Because an ultimate model will not be AI-driven, it has to be hybrid-driven. Otherwise, it doesn't succeed. It ends up what Harold was mentioning in one of his slides. And we have had at least 2 such experiments done, because I keep on doing these khurafatis. One of the departments I am associated with is the grievance one. In this country, the governments never gave much of importance to the grievance component of the governance. The websites would remain unattended, unvisited. People finally stopped lodging the complaints or grievance. I thought this was not fair in a democracy, so we made it vibrant, we made it AI-driven. The result was every week we had almost 100% disposal of the grievances. The grievance number went up nearly 20 times because people were getting the response. Well, one day I told the secretary, I said, our disposal is 100%, but the complainant has a long face, he's not happy. He said, what is that? I said, because in the English language, no 2 words have a same meaning. So disposal does not mean having addressed his aspiration. So we, in fact, last year, somewhere around December, set up a human desk to intervene in that AI-driven process. And I said, after the disposal of every complaint, let a human being, a boy or a girl, work physically, call up the person and talk to him. Try to counsel him, try to suggest him, look, these are the options. Because what happens is that if I file a grievance, I would say, why I am not the proprietor of Apollo. I am as much qualified as Sangeeta and Sunita put together both. So I deserve more to be there. So I file in this grievance. And I believe, as a result of this, if not wholly, to some extent, I'll get some share of theirs. But what happens? The AI drives me into that circuit, puts me across to the concerned quarter, and they give me 1, 2, 3, 4 reasons. So these are the reasons you can't be where they are, and you are where you are. But that has not satisfied my urge or my aspiration. So that's one. The other one was, I think I'm possibly the only member of parliament who carries on a continuous telemedicine, AI-driven mobile clinic in my constituency. We prepare clusters of villages, the remotest villages, about 25, 30, and that we made that clinic run for 3 months in that cluster. It's a costly affair. It's about 50, 60 lakh per 3 months of exercise. It's a very lucrative health startup venture. We have about 2 techno-savvy boys or girl, and then we have 1 physical doctor there, who is, of course, an MBBS or an MD, and an AI doctor who speaks from the screen, can speak better Telugu than you speak, can speak in the language that you speak. So the villagers get a, treat of both. So first encounter is with the real doctor, who takes the history. The second encounter is the AI doctor, she is sitting in the screen and speaking in a better accent than you speak in your language. And the villagers feel so fancied about that. And that adds further. Then she decides, through the medium of AI, whom do you need to consult? A neurologist, a cardiologist. We have tied up with some of the hospitals in Bengaluru, Hyderabad, Ahmedabad, etc. And then you can, within 40-50 minutes, you get the prescription also after all the tests done. So if you don't have that hybrid model, you don't succeed. And that's why I said, if you are not intelligent enough to handle artificial intelligence, then you run the risk of being taken over by artificial intelligence and becoming artificial yourself. So you have first train yourself for that. So it's like that. The second is the AMR, very rightly raised by Sangeeta, antimicrobial resistance, has been there for decades now. And just the only option we find is to move on to the next generation. But yes, what she was trying to flag off is what would happen when the generations are over. Now the point is that, again, however much the effort made at the level of the medical professional or even the government, it would still require a lot of collective endeavor, if not for one generation, maybe for 2 or 3 generations. Because you need to have a kind of a social involvement in that, unless it doesn't work. In this country, you have as many number of non-degree holder practitioners as you have degree holders. You are regulating the degree holders. You are asking them if every 5 years you get your registration renewed. But you are not doing that for those who are not having a degree and still are more popular. And many of our young pass-outs find it difficult. They come back and tell me, look here, sir, what to do? We have a quack sitting by. He is having a larger patient followers than I. So unless that esteem in the society rises up, we would not be able to. So we need to involve the NGOs, the like-minded citizens. For example, you have those TV cameras put up on the roadside, on the crossings, so that you don't bribe a traffic cop if you violate this. But still, if the bribe giver is there and the bribe taker is there, they know how to manage it when it is out of the sight of the camera. And they do it. But similarly, if you do something like that in a place like London, the cop would take it as an affront. And there was a doctor, many of us may be knowing him also. He is no more now, of course. He was known to be a little disturbed psychologically. So he was there in London. He violated one of the signals. That's what I'm talking about 20 years back. And he was stopped by a cop. So he came out of the car and started arguing. So he started showing his finger and, trying to impose himself. Then the cop said, don't show me your finger, he said like that. You're trying to impose yourself on me. And our doctor friend caught hold of his finger and turned it around, fractured it. So what happened was, an FIR was launched, and the judge decided that doctor was insane. He needed mental counseling. So it won't happen here. It's a very convenient situation. The hand to be used for showing finger can be used just to put the hand in the pocket of the cop and give him what he's looking for. So this is just citing one example. So ultimately, once we have that kind of esteem, it will not happen. And that esteem will come with the passage of time, because we are still an evolving society. We have been independent and democratic only for just about 75 years, which is almost infancy in the age of a nation. When the histories are written, they are written in the eras, the British era, the Roman era, the Mughal era, and 70 years don't even find a footnote of a chapter. So we have to take it like that, not to be pessimistic about it, but it is going to evolve to that. And we have to, all that can we do is our generation to create, to make a continuous endeavor to create that kind of esteem where we do not indulge in a malpractice. And of course, the early detection, as was mentioned by her, also by others, is of course the key to all the diseases, particularly the kind of technology that's available now. But the point is, in India, early detection is, if it is not happening optimally, it's not happening simply because the facility is not available. Also not simply because the person is not aware or not adequately aware. It's also happening because of socio-economic factors. Now, as a practitioner for almost 3 decades, and my 99% of practice was diabetes, who are advised to take lifelong medication, I have known patients who would skip drugs for 3 days in a week, 2 days in a week. They had a calendar of medicine consumption, 5 days in a month, to save for the children's fee, to save for the installment of the flat that they lived in. And in the OPD, when I would find one of the young residents scolding the patient why he had missed drug in a very loud voice, I would quietly call him back. I said, don't pester him. He may not be able to afford it, that's why he's doing so. Not that he doesn't know the disadvantage of who would not like to take medicine. Who would not like to keep the disease away if he's made aware of that? But for a common Indian who has nothing in his possession, his self-respect is most precious. So he doesn't say that. And therefore, that is also a challenge. And that's why I said it's not something that you can leave only to the health leaders. And therefore, I think I should end up here because I was invited more in my ministerial capacity. The ministers are expected to light the lamp and say good, good, and push off. So, since having been a faculty for many decades, that habit doesn't go. But I would just conclude that to reach that goal of Viksit Bharat, which has been repeatedly mentioned in the theme of this two-day meet, I think it's essential also to ensure Swasth Bharat. And to ensure Swasth Bharat, we need to have a robust preventive healthcare system. And therefore, Apollo has always been taking a lead as a corporate hospital, as the Apollo pharmacy, then Apollo telemedicine networking, then transforming healthcare with IT, then HOPE program. So with all that record that they have behind them, I'm glad to know that Apollo Group, led by the two illustrious sisters, has once again picked up the baton and taken the responsibility of being the torchbearer of India's corporate health movement to reach the destination of Viksit Bharat. Thank you very much and all the very best.
Thank you so much, Dr. Jitendra Singh. And as I had said, didn't look at the script, and there were just so many wonderful stories and great experience. Thank you so much, sir. May I now call upon my colleague, Dr. Madhu Shashidhar, for a word of thanks, please.
Thank you. Thank you, Anupam. It's my privilege to thank this esteemed panel. First of all, let me take this opportunity to thank the Honorable Minister, Dr. Jitendra Singh. Sir, it's not always that we get a paper from NEJM quoted during a speech. I want to thank you for highlighting and laying the stress on equitable access to healthcare through programs such as Ayushman Bharat, and also, as you've stressed, the importance of innovation and biomanufacturing within the country. So thank you, sir. You know, conferences like this would not happen if organizations did not put patient safety and quality at the center of everything that they do. And this goes back to our chairman and his vision and the way he started Apollo, and how Ms. Preeta Reddy, Ms. Sunita Reddy, and other leaders within the organization have carried that vision through. So I'm extremely grateful for your stress, the stress that you place on putting the patient at the center of everything that we do. Puneet, you've been a great partner. Microsoft has been an incredible partner for us as we innovate within healthcare IT. You saw the example of the candle becoming a light bulb. I think it takes great organizations to do this and to have that vision and to make this a reality. I also want to thank Mr. Harold Wolf. In my career, I saw healthcare IT go from the basement to now being front and center. And I think organizations such as HIMSS have played an incredible role. So thank you for your leadership. Also want to thank the College of Healthcare Information Management executives for laying the stress on health IT and innovation within health IT. Lastly, Puneet, thank you for your presence here, and we hope to bring more innovations such as the patient co-pilot to fruition. Thank you all.
Thanks, Madhu. We're going to have the Honorable Minister release a book on healing smarter.
Please give a huge round of applause to our dignitaries on stage. Thank you so much for your insights on how the intersection of technology and innovation is moving healthcare outcomes to the betterment of patients. Please give a round of applause to the Honorable Minister, Dr. Jitendra Singh. And I request all of you to please join us for lunch. And I request all of you to be please back in your seats by 3 p.m. We will start with our next session at 3 p.m. The lunch is being served at the ground floor, so you'd have to proceed to the ground floor for your lunch. And please be back in your seats in the hall at 3 p.m.
May I just reiterate once again, post-lunch 3 p.m. sessions are going to start at THIT hall here. For IPSC, it's going to be in the plenary hall and the track halls on level 1 of the same building. See you all there. Exhibition is in exhibition hall number 14, where lunch is also served. Thank you.
Lunch for speakers is being served on the right, so I request all speakers to please head to the right of the hall, and for all delegates, the lunch is being served on the ground floor.
horizontal. Mirega
Welcome back. I hope all of you have had a hearty lunch. I request all of you to please settle down. We'll start the program in a couple of minutes. Those who are seated in the back of the hall are requested to move up closer to the stage. You'll have a good shot at seeing the presentations, perhaps hear the speakers better. So I request everybody to please move up closer to the stage. There is enough room to accommodate everyone. And I request all of you to please settle down. Please put your phones on silent so that you can hear the deliberations of the day without any interruptions. Welcome back. Earlier in the day, we've seen a very exciting launch of the drones transporting medicines and the critical cancer biopsy sample. And now we have another very exciting launch coming up. This is the Digital India Activator program by the World Economic Forum. This initiative is designed to accelerate India's digital transformation, fostering innovation, technology, adoption, and collaborative efforts between the government and private sectors to drive inclusion and sustainable growth. For this launch, I would like to invite on stage Pratyush Sharma, Lead Digital Health India at World Economic Forum. Please give a round of applause and welcome Pratyush Sharma on stage. Right. Pratyush, if you're in the hall, would request you to please come up on stage. And I'd like to give you an introduction for Pratyush. He is a versatile and result-oriented healthcare IT leader with around 18 years of rich experience in providing thorough and skillful advisory support to leading healthcare organizations across the healthcare value chain. He is a global healthcare consultant with exposure and experience in working with leading players in India, the US, and Middle East. So we'll just give a couple of minutes. I think Pratyush is in the hall and he's making his way up onto the stage. So ladies and gentlemen, please give a round of applause and welcome Pratyush Sharma, Lead Digital Health India at World Economic Forum. I would request him to please come up on stage and speak to us about the Digital India Activator program by the World Economic Forum. Round of applause for Pratyush Sharma.
Good afternoon, everyone. I am Pratyush, Lead Digital Health at World Economic Forum. I would like to announce that we have a key announcement from World Economic Forum. And World Economic Forum is a organization which drives public-private cooperation internationally. So for that, I would like to invite Dr. Shyam Bishen. Dr. Shyam Bishen is head of Center for Health and Healthcare at World Economic Forum. Dr. Shyam. I would also like to invite Dr. Anupam Sibal, Group Medical Director from Apollo. Dr. Madhu Shashidhar, President and CEO Apollo Hospitals. Okay. Mr. Jayesh Ranjan, Special Chief Secretary for Industries and Commerce, Information Technology, Electronics and Communications, Government of Telangana. Mr. Ashish Jain, Head Health and Nutrition, JSW Foundation. So I'm not sure if NHS CEO is already here or not, but if Ma'am Changsan is here, then I would like to invite her as well. Okay. I'll hand it over to Dr. Shyam to take it, to make the key announcement, please.
Thanks, Pratish, and good afternoon, everyone. It's a real honor to be here at THIT 2025. I must thank Apollo Hospital and the family for organizing such a wonderful event, such a wonderful gathering, and inviting me to participate in this. Well, for those of you who may not know WEF, who may not know World Economic Forum, we are a non-profit international organization for public and private cooperation, for public-private partnership. The World Economic Forum has already played key role in convening multi-stakeholder parties to the table. There are many areas of success from Israel-Palestine Accord on the political side, on the geopolitical side, quite some time back. Obviously, it's at a different stage now, but on the healthcare side also, we can mention a few which have worked really well in terms of Gavi, in terms of Global Alliance for Vaccine Initiatives, which is credited to save more than a few 100 million lives. That was conceived and launched at our annual meeting in Davos of World Economic Forum, and Global Fund and so on and so forth. So again, all of these were conceived and launched at our annual meeting in Davos through our public-private platform, public-private partnership platform. Now, World Economic Forum has many centers. We have a total of 10 centers, and Center for Health and Healthcare is one of those centers that I lead. Here in this center, we work very closely with governments, businesses, academia, philanthropies, and civil societies to shape the future of healthcare and unlock opportunities for global impact. My center is working in many of the areas that you heard from Dr. Sangeeta Reddy earlier today, be it digital health, be it climate and health, whether it's AMR or it's health equity. All of those areas are focus areas for our center. On the digital health side, we strongly believe that digital technologies, artificial intelligence, and data hold immense promise to improve health. And as mentioned by other speakers today, India is fully grasping this opportunity. Earlier today, we also heard from Dr. V.K. Paul already, who quoted our report from a few weeks ago, where I emphasized how India can be a global pathfinder in digital health arena. However, we believe there is still much work that needs to be done here. Unlocking the full potential of digital health requires a strong public-private collaboration, scalable innovations, and an inclusive approach that benefits every citizen. Today, as part of our Global Digital Healthcare Transformation Initiative, we are pleased to announce a Digital Health Activator Coalition for India, a multi-stakeholder effort designed to accelerate digital health adoption and create scalable, sustainable models that can drive impact at scale. In this effort, we are planning 2 initial action hubs, each focused on identifying and unlocking new opportunities to accelerate digital health adoption. These hubs will serve as test beds for co-creating and piloting innovative models that can then be scaled nationally. So the idea here is for us to work closely again with government, with businesses, with private sector, academia, and others to look at these hubs and create test beds for piloting new innovative models that we can scale up further. With that, let me invite a key champion of digital health in India, a leader who has transformed healthcare through technology and innovation, Apollo Hospitals. And for that, we have Dr. Anupam to share why the private sector is critical to this effort. After Anupam, we will hear from Jayesh Ranjan, who will provide an overview or will provide his views in terms of the role for public sector, and that will be followed by philanthropy from JS Foundation. Dr. Anupam.
Thank you very much, Shyamji. Good afternoon, friends. You know, Gandhiji had said that the future of India lies in her villages. India is 700,000 villages. Nearly 65% of healthcare in India is provided by the private sector, and we know that there is a huge urban-rural divide. So if we are really going to achieve universal health coverage, we're going to make sure that every citizen gets quality healthcare. How are we going to be able to do this? It's not going to happen by brick and mortar. It's not going to happen by conventional means. And we have a hugely successful example in front of us. If we look at how telephony has changed our lives, in 10 years, the cost of 1 GB data has gone down from $4 to 8 cents. The average consumption has gone up by 70 times. Every second, 3 Indians join the internet. Of them, 2 are from our villages. So if we really have to make sure that 1.426 billion people get appropriate healthcare, we have to go down the digital route. That is the only way we can reach out to the people across the length and breadth of the country. I'm really happy today that the World Economic Forum has launched this activator, this accelerator, to help us mobilize resources and teams to work towards that goal of reaching out to everyone across the country. We at Apollo have over the years embraced technology, not just in the way we practice medicine at hospitals and clinics, and we have more than 10,000 beds and we are present across all formats from primary care to secondary to tertiary to quaternary. But I think what has been very gratifying for us is that when someone at 12,000 feet develops an arrhythmia in Kelong or Kaza in the Himalayas in Himachal Pradesh, and that person would have died had there not been access to the command center in Chennai, 2,000 kilometers away. That is the impact of technology. And we are seeing post-COVID that patients, doctors, the community has accepted telehealth like never before. When Professor Ganapathy used to talk about geography is history, there were a lot of skeptics. And the patient really was very dependent on that touch sitting across the table. But post-COVID, when everything changed, we've seen the kind of traction that we've seen in telemedicine like never before. Whether it's teleconsults, whether it's teleradiology, the fact that somebody in a village has a cough, and obviously we are not going to have 700,000 radiologists. If through ML we are able to diagnose tuberculosis and provide anti-tuberculous therapy, well, that is technology really benefiting the individual at the rural level. Or if someone has a stroke in a small town and a CT scan is available but a neurologist is not, and the image can be looked at through WhatsApp, as simple as that, by a neurologist to decide, well, there is thrombosis and we need to thrombolize this patient, and do that in 4 to 6 hours, we will get that patient to recover from a stroke with no deficit. That's technology at play. And we are seeing that increasingly at Apollo. I mean, Vikram leads ATHS, some remarkable work done in Andhra Pradesh through our tele-ophthalmology project, through the urban health centers, some very interesting work happening in Jharkhand through our pharmacy work, through the digital platform in Uttar Pradesh, of course, Himachal. So there are numerous examples of how technology can really be a game changer. Our offering of Apollo 24/7, I think really amazed all of us in the kind of traction that we got, not just in consults, but also being able to provide psychological help to many individuals, follow up with dietitians, with physiotherapists, and of course, diagnostics and provision of medication. So we at Apollo are a firm believer of the power of digital technology in furthering the mission to reach every individual with quality healthcare. So really delighted to be a part of this initiative, and would like to congratulate the WEF team for bringing us all together. Thank you.
Thank you very much. First of all On behalf of the government of Telangana, I would like to express my gratitude to the World Economic Forum for realizing that states play an important role in actually grounding all these important national goals, national programs. And it is not an exaggeration to say that the action really happens in the states. So thank you for deciding to have the India Activator hubs in different states and for selecting Telangana to have the first hub of the India Digital Activator. So the choice of Telangana is also not a coincidence, not a surprise. In fact, Hyderabad, our capital city, is a city which is today recognized as a place where technology meets biology. We have a very rich legacy of life sciences. In fact, in the earlier session, Honorable Minister spoke about our prowess in pharmaceuticals, vaccines. Much of that actually happens in Hyderabad. You will be amazed to learn that 1/3 of world's vaccines are made in Hyderabad. 40% of India's pharma production happens in Hyderabad. So that is happening on the one side. And as many of you would know, Hyderabad is also a very strong tech center. So the perfect place to blend or to see the confluence of biology and technology. And therefore, the Digital Health Activator to have its beginning from Hyderabad is very, very appropriate. Some of you may be aware that World Economic Forum runs multiple thematic activities through its dedicated centers, which are called C4IR, the Center for Fourth Industrial Revolution. And again, I'm very proud to share that the Healthcare and Life Sciences C4IR for India is actually located in Hyderabad. We inaugurated it about a year ago, roughly around the same time. And in the last 1 year, we have made remarkable progress. And some of the work streams that we have chosen actually relate to digital. And lots of real-world evidence, sandbox, digital initiatives, creating a repository. Again, it was spoken about in the morning. We are actually working on a repository on hemophilia and so on and so forth. Lots of work related to genomics has been started under the C4IR. So the intent of the government, of course, is to bring all the stakeholders together. Apollo has a very significant and a very strong footprint in Hyderabad. They obviously will play a very important role in this activator. In the lunch break, I met representatives from other healthcare providers from Hyderabad. A big team is here. So I also assured them, I see them sitting there, that they will also have their say in how this activator actually functions. We also have amazing research institutions. Some of you would be aware, national and internationally acclaimed institutions like the Center for Cellular and Molecular Biology, or CCMB, Indian Institute of Chemical Technology, or IICT, the Institute of Life Sciences, and so many other institutions, Tata Institute of Fundamental Research. They also are located in Hyderabad, and they work in close tandem with the government. And most importantly, we have a very thriving startup ecosystem that focuses on life sciences, because we have the who's who of the corporate world and the research institutions in Hyderabad. Startups who are into medtech naturally gravitate towards Hyderabad to seek support, and the government has also created multiple institutions and programs to give a further push to these startups so that they become profitable, they create impact, they bring solutions and products which take care of some of the most pressing problems that people might have been facing for generations. And therefore, we are very excited that this activator is having its beginning in Hyderabad. In another 4 days from today, on the 25th and 26th, the annual flagship event that Telangana government hosts, called BioAsia, is taking place in Hyderabad. And during BioAsia, we will be expanding much more on what this activator will do, what are the priority focus areas, how will we bring all the stakeholders together. And I hope to stay connected with all of us. Many of you here would be keen to contribute to the functioning of this activator. So please stay connected and look forward to a wonderful collaborative endeavor, which, as Dr. Shyam mentioned, possibly can showcase how partnerships can be forged to tackle some very important public health issues in this manner using the power of digital and technology. So thank you for giving us this chance. And I would now request Ashish from JSW to share his perspectives.
Good afternoon, everyone. Thank you for inviting me. Thank you for this. Thank you, Shyam and Pratyush, for launching this India Digital Accelerator. I'm not sure how many of you have worked in the public health, but I'm assuming that most of you might have worked in the public health sector in the country. So I'll just take one step back, and it's like understanding the entire scenario in a way that way back when I started my career in 96, 97, and we were at the district level and we were trying to organize something on the challenges of maternal child health. We were knowing some problems are there in the district, in the facilities, at the community. But the possible solution, the problem statement, a consolidated statement was not before us. The resources to address those challenges, resources be it of the funds, be it of the materials, or be it of the trained human resource, we were not having it. We were all struggling to find out, and it was a remote district. But the country, the state, the districts, the institutes, the society, the community has marched towards some development, and today, while the country is progressing towards many more accolades, we have achieved certain things, which is a reflection that how all the initiatives which are happening, be it state level or be it the country level, consolidated for a specific intervention gives result. And that results, the measurement of the results is how we can see the reduction in the maternal mortality or the infant mortality. These are the examples that how entire machinery has worked together. So now you are having, the quality can always be challenged, but we can always say that the standard operating procedures at the highest level to the lowest facilities are available. People are trained. They are talking the same thing. When first time I went into the village with a vehicle, entire community ran away because we came there for the vaccination. But that is not the case today. The things has changed. The purpose of this analogy is that today we are exactly standing in the same conjuncture when coming for the digitalization of the processes. When we are having WhatsApp and all these things, when everybody is capturing everything on the mobile, still in the rural area, only 40% of the community, in my community where I'm working, 40% or less than 40% are having smartphone. What to do, how to do is again a problem. Best part is that we know what is the problem statement, we know the solution, we are having resources. And we are having the political will at the highest level. So the change of the position from 96 to 2025 is this, that we are having this problem statement and a possible solution. And I firmly believe, and in foundation, in GSW Foundation, we firmly believe that at foundation, we can always bridge the gap between the services, be it available at the private or at the public level, to the consumers, to the end users, be it the poorest of the poor, or maybe somebody who is in the need, because health is a need of anyone and everyone. It is not a luxury, it is a right, it's a need, it requires everyone. So at Foundation, with that passion, with that commitment, we are always there to facilitate those things which are going to bridge the gap, and we are having sufficient capacity to accept any failure also. If we do something, we fail, but we learn. We'll not do the same thing. So our position to implement the program is that, yes, we have to transfer the benefit. We have to transfer the benefit to the community, to the system, to establish a system. And at the same time, we are having capacity that let's do it mindfully. If we fail, we fail. So with that, we are at JSW, we are present across the country. We are ready to partner with any institute, be it government, be it non-government, be it private thing. Because another important thing for us is partnership is a key for us. We alone cannot do many things. Partnership is a key. So with partnership, with dare to innovate, with push the envelope more, we are here to support. And this is a good thing that WEF is as an aggregator is collating all the resources, all the things which are needed for the digitalization. And when I say resources, it's not just the funds, but it is the knowledge and other things. So thank you very much. Thank you for holding this workshop. Thank you, Apollo, for giving this space for this meeting. And I'm looking forward for the digitalization of health activities across the country. The few lighthouses can be a good place to visit, to revisit, to challenge the concept and take it forward. Thank you very much. Thank you once again.
Thank you, Ashish, and heartfelt thank you to all of our esteemed speakers, Dr. Anupam, Mr. Jayesh Ranjan, for all the three of you for bringing different perspectives here, from private sector, public sector, philanthropy. This is what we like to do, bring this, as I said earlier, bring these various sectors to create a strong coalition for our Digital Health India activator. So with this, our Digital Health Activator, actually this is the first Digital Health Activator that the World Economic Forum has launched around the world. We will be launching a few more. We will be launching this activator in other countries as well, but we chose India because of the immense potential here. One more thing I would like to emphasize, I know I'm out of time, but one more thing I would like to emphasize is that this Digital Health Activator is not just about accelerating adoption, but about complementing. It's also about complementing and strengthening the tremendous efforts that are already underway, especially by the government. We heard earlier from our Union Health Minister about Ayushman Bharat Digital Mission, about UHI and others. We want to make sure we work closely with Union Ministry of Health, as well as with the state governments like Jayesh Ranjan mentioned with the government of Telangana to strengthen the programs that are already underway on the digital healthcare transformation side. So without taking any more time, we just want to thank you all for being here, and we look forward to engaging with all of you in this journey and welcome your contributions in making India's digital efforts by truly transformative and a remarkable success. Thank you all.
Thank you. This is a very exciting foray where the Digital India Activator Program has been launched by World Economic Forum. We are now going to move on to a discussion, and this is an insightful panel discussion on public-private synergies for Viksit Bharat 2047, held in collaboration with the World Economic Forum. This panel will explore how public-private partnerships, PPPs, can catalyze India's vision of becoming a developed nation by 2047. Given the scale of healthcare challenges ranging from accessibility to affordability to quality and innovation, collaborations between the government and private sector can accelerate the development of innovative models, collaborative frameworks, and transformative strategies for universal, high-quality, and tech-driven healthcare. The objective is to craft actionable solutions that can foster sustainable growth, drive inclusive development, and build a resilient future for Viksit Bharat. So please give a round of applause and welcome on stage our speakers for this session. Please welcome our moderator, Pratyush Sharma, Lead Digital Health India at World Economic Forum. Please give a round of applause and welcome him on stage. Joining him in this discussion are Shri Jayesh Ranjan, IAS, Special Chief Secretary, Information Technology, Electronics and Communications, and Industries and Commerce Departments, Government of Telangana. So please give a round of applause and welcome Shri Jayesh Ranjan, IAS, on stage once again. Please welcome Mr. Premanand S., Chief Business Officer, Apollo Telehealth. Please welcome him with a round of applause. Please also welcome Ms. Shri Priya Rao, Chief Growth Officer, Women's Wellness, Karkinos Healthcare. And please welcome Mr. Anurag Vora, Chief Technology Officer, Bajaj FinServ Health. Please also welcome Ms. L.S. Chongsan, CEO, National Health Authority. Please give a round of applause and welcome our speakers on stage. Please give them a round of applause, a rousing round of applause. We are really looking forward to hearing their views on how the PPP model can work And I'm going to hand it over to Pratyush to steer this discussion. And we'll just get an additional chair also put up so that all our speakers are comfortable. So I'll request Pratyush to set the ball rolling, and I request our speakers to please adhere to the time of 40 minutes. Thank you.
Good afternoon, everyone. Thank you for joining us today for what promises to be an insightful and forward-thinking discussion. The topic is also very relevant, very critical, public-private synergies for Viksit Bharat 2047, especially in the context of driving the future of digital health in India. I'm Pratyush, lead digital health for World Economic Forum in India. And I have the privilege of moderating this session. We have gathered an exceptional panel of leaders representing forefront of digital health in India from both public sector and private sector. Let me briefly introduce them. We have Ms. Changsan, CEO, National Health Authority. We have Mr. Jayesh Ranjan, Special Chief Secretary to Government of Telangana. We have Ms. Sripriya Rao, Chief Growth Officer in Karkinos Healthcare. We have Mr. Premanand, Chief Business Officer, Apollo Telehealth. And we have Mr. Anurag Vora, Chief Technology Officer, Bajaj Finserv Health. So here we are going to, start about exploring how digital health can play a role, how public-private partnership can play a role in driving the digital health in India, especially considering our ambition of Viksit Bharat 2047. In my mind, Viksit Bharat 2047, for that to happen, we need to have a robust healthcare ecosystem, a healthcare ecosystem which is accessible, affordable, and also effective. And so without further ado, I'll probably get going into the discussion. My humble request to all the speakers is to keep it concise because I want to extract as much as possible from your experience and leadership. So let's begin by understanding what is public-private synergy. What does it mean to each one of you in the context of digital health and Viksit Bharat 2047? So I'd like to start with Ma'am Changsan. Over to you.
A very good afternoon to my esteemed co-panelists and the moderator, the organizers of this unique conference on digital health and transformation of healthcare through IT. This question, Pratyush, you've just raised is actually a very important one. And to me, if you ask me what is the most exciting opportunity for public-private synergy, I would say that it is the ABDM, what we have, the Ayushman Bharat Digital Mission. The very idea of public-private partnership is championed under the ABDM. And with this, we are expecting that healthcare delivery, the face of it would change. Just like UPI has transformed how we do our financial transactions, we do feel that ABDM is going to provide an ecosystem. And in this, the private, the public, and the insurance companies, all three would come together. ABM intends to build up a model, an ecosystem, which is both interoperable and which envisages standardization. So with this, we see that in the market also, the share of digital healthcare service delivery would increase. And we would be able to have a good partnership between the public and private. This is, I think, we can expect to see a paradigm shift in healthcare delivery. Thank you.
Thank you so much, and completely aligned with you. Like ABDM is a good example of public-private synergy, and for it to get to the next level, private sector adoption and public sector governance will be very, very key. So definitely pretty much aligned with you. I'll request Mr. Jayesh Ranjan to go next, please.
Sure. So, greetings to all the fellow panelists. Greetings to members in the audience once again. See, when I was up on the stage a while ago, I had mentioned that the digital activator that will be starting will see the participation of all the stakeholders in a very collaborative way. So I'll continue to expand on that thought. Now, if the digital activator has to really come out with very tangible outcomes, there are a number of steps that it needs to take. First of all, it needs to identify which are the most pressing public health challenges which population at large faces. Second, who are the solution providers who can provide solutions to those pressing problems. If they want to develop those solutions using digital, where is the data available? Who will make that data available? If they need to run proof of concepts, because health definitely is a very critical issue, it's a very sensitive issue, and without testing, without standardizing the protocols, we can't allow it to be scaled up. And therefore, you need an opportunity to test it out. Sometimes you are unsure about the regulatory aspects of certain protocols that you are recommending. So you need to build a sandbox. And then obviously you need to take it to scale. And obviously to do all these things, someone has to provide resources. If you are developing complicated computational models, etc., the computing infrastructure has to be provided. Someone has to subsidize it, because even now, despite advances being made in technology and knowledge, the cost of compute is still very high. So if you look at the entire range of activities, the entire value chain, so to say, there is a very clear role of what the public needs to do, the public sector that is needs to do, and how do we tap on the best expertise that the private sector has. So just to give again a very intuitive kind of an example, following the same chain of thought of this train of activities, the identification of which are the most pressing problems that people face, the public sector definitely has lots of information, lots of insights, but so do have private companies, including companies which are providing insurance support, because they would have dealt with millions of cases, and therefore they also have a good understanding of the kind of disease burden which prevails in our state or in our country. The solution provision part again has to be brought from tech companies, but of late we have seen that some of the most innovative work is being done by startups, by young innovators, young entrepreneurs. So who are they? How do we identify them? How do we kind of filter them to identify the ones which possibly have the best ideas that can lead to a workable solution? And then the rest of the things like proof of concept, it can be done in a public sector institution, it can be done in a private hospital setup, clinical setup as well. Data, again, the government itself holds humongous amount of data, but so do well-established institutions. For example, Apollo Hospital has access to humongous amounts of data. So how do you ensure that data is also made available? But again, lots of regulation needs to be put in place. Where is the data management framework? What is the data exchange through which anonymized, non-personal kind of data is made available? And if the concerns about security and privacy, etc., have to be met, what is the legal framework? Fortunately, the law is about to be introduced. So, I mean, everyone would have understood by now that every space in that chain has to be served in a very harmonious way between the private and the public. And the skill of this activator would be to bring the best of the public and the private together. And that is what we hope to do in our state of Telangana.
Thank you so much. And I think you have rightly pointed out that in the value chain, there are lot of interventions which are required, and private sector has a role to play, public sector has a role to play. And this activator is an attempt to kind of achieve that. So, we'll be inviting the right stakeholders to the room and try to solve some of these problems. Next, I will go to the private sector. I would request Mr. Premanand to go next.
Greetings to the audience and to my fellow panelists. We come from the private sector, and for decades, if you've seen in the public health system, it's always been the responsibility of the government to take care of 60 to 70% of the public's healthcare. And the intersection of, digital health now accelerated with AI and ML into it, and in the intersection point of public-private partnership synergies coming into place, for us, we see this as the platform for a natural evolution of next set of reforms in the public health system. And this is very important for, as per the learnings we've had doing multiple programs with various state governments and various donors, is that the government is evolved in a certain fashion, and the technology is getting accelerated in a phenomenal way. And to integrate the benefits of these technologies into benefiting the common man, the system will take time. So that's where digital health comes into play. And what it really is going to create a revolution, which I'm very hopeful, given that we've spent decades working in this space, is that accessibility issues, service non-availability issues, accountability issues, and accuracy and assurance issues. All of this is going to technically be enabled through this intersection of public-private partnership and digital health. And this is inevitable, and it will be accepted not only in India, globally. This is a natural process, and it is really getting accelerated. The second most important thing is, as a consumer, as a public, from wanting to I'm at the receiving end, the whole thing is going to translate into empowering him. He's going to demand services, and it will obviously, this has happened across in multiple other sectors, what technology has done. But in healthcare, if you primarily see, the transition has taken some time, like the advancements which we have seen, public-private partnership, especially infrastructure. There's phenomenal growth. The India story itself is very big. The airports, the bridges, the roads which we see. But in healthcare, this has been pretty slow. But all of a sudden, we are seeing in the last few years, there is a multiple opportunities, and the way it is fluctuating, it will not only fluctuate in terms of how existing models are prevalent, it will challenge even the private and the public health system, and it will lead to a price discovery which will normalize the way how healthcare spending is happening in this country. So this is very exciting times for people who are working in digital health, developing applications, and especially for the public health professionals. The importance of getting private services to co-create and work with government existing infrastructure and bring in innovations is going to be all-time high. And I think it's going to be really good for the people. Thank you.
No, thank you so much. I think your last point on private sector coming together with public sector to co-create some of these solutions which can work at scale will be the key going forward. So thank you so much for that. Shripriya, over to you.
Thank you, Pratyush. And very happy to be part of the co-panelists here. Greetings to each one of you as well as the august audience. I do not wish to repeat because there's a lot that has been said already, but I'll probably summarize a couple of key pointers. Because I come from an oncology health-related area with respect to Carcino's healthcare. I want to highlight just 2 points specifically. If one were to go into Tata Memorial Hospital in Mumbai, about 10 years ago, we saw 300 new patients coming into the system, and post which there have been several centers that have been established in Varanasi, Assam, Tirupati, many more centers, and we still do not see the number of patient load coming down. Now, a lot needs to be done in terms of democratizing care to be taken to the rural parts of India and being able to build that affordable, accessible care closer home. And none of this is going to be possible unless otherwise we are able to bring a technology solution which in fact connects the dots between each of the centers from a rural-most part of let's say Telangana to the parts of also other areas where somebody from a Karimnagar in Telangana could come into a Hyderabad and still go back and avail services or vice versa. So a lot needs to be done. We are ABDM compliant and one of those major contributors, but the challenges that exist in terms of being able to integrate multiple maturity systems that exist in the health systems that operate across the country, which is so varied, and bringing a normalized path to be able to get there is going to take some time. Additionally, I think you brought out a nice point, Prem, with respect to how a lot has to be transformed with respect to bringing a paradigm shift to thinking about health. Today we are going into health systems to be able to take a curative approach, but how can we go into a more preventive approach, moving away from illness to wellness? And that's a very unique opportunity for us as a country with aging population. Around the time when we get to a 2047, when we're talking about a Vikasit Bharat roadmap, that's not going to be the time where we will have the same age population, but we would have a slightly aged roadmap. And the birth rates are also coming down. So given that, I think there is going to be a role that we all have to work in terms of catalyzing the prevention roadmap with blended financing models. And we can't just be looking at current concepts with respect to curative healthcare. I'll close there.
Thank you so much. I think reaching the remotest of the places and rural areas, technology is going to be the key, and obviously public-private partnership can also play a role there. So over to you, Anurag. So you can share your perspective on the topic.
Hello, yeah. So in terms of when we talk about public-private and say models of the way UPI succeeded, the first thing which comes to mind is the way UPI was built. Let's build UHI. And then you can say we can build interoperability of services. We can do like there is a bank account, let's build a health vault account. But I would say the UPI succeeded, and what we have to learn from UPI is we have to follow the money. What I mean by follow the money is UPI had something for everyone to gain when they used UPI. It gave someone convenience, it gave someone direct subsidy, it gave a lot of benefits to every player involved in the ecosystem. So when we have to look for adoption of, say, ABDM, I think we have to also look at what is in it for everyone. It has to start with the money, where if I am submitting a claim from provider to using NHCX protocol, it should not have shortfalls. It must get approved if I submit through that protocol. And my claim should get settled sooner. If that benefits comes, then the adoption of those protocols will automatically increase and people will come to that. It will reduce the overall cost of the ecosystem as well once they are adopted. And if we are using Abha ID, another big spend of people is on Ayushman Bharat is covering the secondary care. But on primary care, there is no wallet concept. If you are able to bring a wallet which can be spent only on healthcare, it's a locked, so we have to ride on top of UPI and follow the principles of UPI with the money, not in terms of just architecture. Architecture is important but not sufficient. So.
No, thank you. I think a very interesting concept, follow the money. We keep hearing this in movies, but I think even in ABDM we can probably try this. So thank you so much for that. Now we'll probably go into, want to learn from your experiences and leadership in driving some of the initiatives. So I'll request Mr. Jayesh Ranjan, like Telangana excels in both startups and life sciences. But to boost the digital health innovation for Viksit Bharat, how do you bring together everybody, like the startups, the life sciences companies, healthcare providers, and government, to kind of come up with the indigenous digital health innovation? What will be the role of public-private synergy here?
So, thank you, Pratyush. So, see, in Telangana, our engagement with startups, particularly life sciences startups, is as old as the state has been. Telangana has been formed about 11 years ago. And since that time, we decided to focus on supporting innovation, entrepreneurship. Government has created fantastic institutions like the T-Hub, T-Works, etc. And we have also co-opted various other incubation and innovation spaces which exist in other facilities like CCMB, IICT, etc. And today we have a very vibrant ecosystem in which startups are supported right from very early stage to a stage where they require access to data, they require access to compute, they require partnerships with public health institutions, private health institutions. Lots of corporates today support and partner with startups. Apollo has a long-standing program in which startups are mentored and supported. Other hospitals like AIG, KIMS, etc. also work with startups. So in the last decade or so, we have been able to create a very congenial ecosystem. And there are certain elements of our startup policy itself which are very special. So for example, even if you have a brilliant solution or a brilliant product, startups typically struggle to acquire their first customer. Finding the first customer, getting the door opened, so to say, is always a challenge. So in our startup policy in Telangana, we have given a guarantee to the startups. I mean, of course, the guarantee is there only for homegrown startups, that is startups who are incubating or accelerating or who have an office in Telangana, that if you have a solution or a product which is of relevance to the government, and obviously what is relevant to the government is something which matters to the people, which has a public impact, which has a social impact. So if you have something which is of relevance to us, we will procure it bilaterally. You don't see, some of you would be aware, government procurement processes are very complicated. You have to participate in a bidding process, and startups typically don't even qualify. They are not even found to be eligible to be a part of the bidding process. And of course, if you qualify, you have to outcompete everyone else. Typically, that outcompeting happens on the basis of price, which again is a big challenge for a startup. So in Telangana, we have done away with all this procurement process. If you're a homegrown startup, having a healthcare solution which is of relevance for us, we will bilaterally procure it. And I can share this with you. In the last 11 years or so, at least a dozen plus solutions have been procured from startups bilaterally, and some of them have been scaled up also. For example, we have found out a very good solution. This is just an illustration. There are many such, but I'll make this example. So as you know, anemia is very common in rural areas, and anemia goes undetected and unattended because we don't have so many diagnostic labs the way you have it in city. Every street has a path lab or something. So a startup which actually was incubated in T-Hub, they fabricated a device. I think it's made of some composites, and you need to place it under your tongue for some seconds, maybe 30-40 seconds, and then you remove it, and then you see what color it is. The more pink or the more red it is, that indicates the kind of health of your blood. And if it is not that red or that pink, it shows that you are anemic. And this was done 6-7 years ago, and at that time the accuracy was about 80%. And again, through improving the technologies, improving the fabrication, the component of that product itself, the accuracy is now more than 95%. So imagine, without needing any blood sample or anything, you can detect anemia at scale. So many such solution providers have been discovered through this process in which government provides complete facilitation and support. And that is why we are so confident that once this digital health activator begins its journey in Hyderabad, in Telangana, there will be a steady flow of young innovators, entrepreneurs who will be coming to Hyderabad to test their ideas, to take support. And hopefully what can be scaled up in Telangana can be scaled up for the whole country and the whole world.
Looking forward to that. I think my last question to Pam Chungson. How is NHA leveraging public-private partnership to drive the adoption of digital health in Tier 2 and Tier 3 cities and rural areas? Because that's where I think the need is maximum, but the resources are limited. So.
Yeah. So, ABDM has been implemented by NHA since 2021. And the last few years, we have tried very hard to push for its adoption, not only in the public, but also in the private sector. So one is that we have this, what we call the incentives scheme. And in this, we are providing a small token amount for creation of health records. I mean, just to go back, I think all in the room might be quite aware of the ABHA, the unique ID that we assign, which is Aadhaar eKYC based. And we have been able to create about 75 crore such ABHA IDs. And we have been able to link a huge number of electronic health records using this ABHA. But it is not just the creation of this alone, it is also when, based on this ABHA, the health transactions are done in a digital way. Now you're talking about these rural areas, Tier 1, Tier 2 cities. I do agree that in some places, yes, technology, access and availability, the internet connectivity, these are still a challenge. There are many parts in our country where we still have this as a very rare and challenging facility. But NHA has been trying to develop through ABDM, we call it microsite scheme, geographical areas. And in this, where there are healthcare providers and where there is interoperability, under this we can have, these 120 microsites that we have developed, we are trying to nudge for the electronic health records of the people for exchange in terms of starting from when you register in a hospital, at an OPD, to inpatient, to sending of lab records. And through all of this, yes, my co-panelist said, yes, the architecture, the use case is definitely more important. I do agree. But the architecture is such that there is a flow of this digital information with consent, of course. And even in the rural areas, with our flagship program, National Health Mission, many of the health records under different important programs like NICSHE, TB elimination, and then RCH, reproductive and child health, UWIN, which is for universal vaccination of children. So these, and NCD portal. So these, in these, ABHA IDs are being created, and there is already a basis and a provision for exchange of this information. But what we need also is, we have been also encouraging state governments that they have their healthcare solutions ABDM enabled, so that all these records that we are creating, they don't go into individual silos, but they are able to talk to each other. That in the government sector, and then in the, across, not just limited to the primary healthcare or secondary like we have in PMJY, but also across private and public. So there is a flow of information, and even eventually even the insurance companies, which is also the most important pillar. So through all this, I think we are endeavoring to, start to close the gap, close the loop in terms of digital healthcare service delivery.
Thank you. I think we are almost out of time, so I'll just request one sentence from each one of you as a concrete call to action. So probably we'll start with Mr. Anurag. Just one sentence, please.
Would be to introduce a cashless OPD wallet. Would be my number one ask.
Shri Priya?
I take a slightly different perspective. A lot of work is done with the innovation and grant funding that is coming our way. Academia putting a lot of efforts towards research. I would recommend a better model towards bench research to bedside way forward, to be able to bring more research orientation which can actually benefit the patients rather than just a research orientation from an academic's perspective. And genomic atlas for the country becoming a roadmap. We've seen COVID really taking 6 months to take shape with respect to vaccine. But an HPV vaccine which was introduced 2008 is yet to be introduced. So a lot can be done with respect to bedside research coming to a bedside roadmap.
Mr. Premanand, in one sentence, please.
I would strongly urge in terms of policy reforms to accommodate private sector in the healthcare service delivery in a calculated manner, which is seamless and it's fast.
Ms. Junction?
What we look forward to most is that we build healthcare services, digital healthcare services, but which should be citizen-centric. It should be based, focus on what is the need and how it is going to facilitate the citizen. We often come from our level, say in the public, the government, what suits us, what we need for better governance or for other things. Similarly, in private sector also, concerns might be something else, but what is most important is the citizen. And I think in healthcare, that is what we need to focus most on.
Mr. Ranjan?
So my call for action would be to very quickly pick some very strong public health use cases and let us showcase how technology can bring solutions to those.
Thank you so much to our exceptional panelists for a truly insightful and wonderful session. It is clear that public-private synergy is not optional. It is definitely required to really get the potential of the digital health for the Viksit Bharat 2047. With that, I conclude the session. Thank you so much. Thank you, everyone.
Please give a round of applause to our esteemed speakers on the stage. I request all of you to please gather in front of the tables for a group photograph. Thank you to all our speakers. We'll now move on to our next session. And this is on hospitals adopting digital health, challenges and successes. This session will delve into the transformation of hospitals through digital health, focusing on overcoming operational challenges, ensuring robust data security, navigating regulatory frameworks, scaling technology adoption, optimizing cost, and driving workforce upskilling. Moderating this panel, we have Dr. Madhu Sachidhar, President and CEO, Hospitals Division, Apollo Hospitals. Please give a round of applause and welcome Dr. Sachidhar on stage. Prior to joining Apollo, Dr. Madhu held various roles at Cleveland Clinic, including President of Cleveland Clinic, Tradition Hospital. Dr. Madhu is a practicing physician with US board certifications in internal medicine as well as pulmonary and critical care medicine. Joining him on stage for this discussion are our esteemed speakers. Please welcome Dr. Ritu Mittal Garg, Chief Growth and Innovation Officer, Fortis Healthcare. Please give a round of applause and welcome Dr. Ritu Mittal Garg on stage. Please welcome Dr. Nandakumar Jairam, Healthcare Advisor, Sham Rad. Please welcome Manish Goyal, Chief Operating Officer, Mayo Clinic Platform. Please give a round of applause to welcome our speakers on stage. Please welcome Dr. Jaroslaw J. Fedorowski, President and CEO, Polish Hospital Federation. Please welcome Dr. M.I. Sahadullah, Chairman and Managing Director, KIMS Healthcare Management Limited. And please welcome Dr. Murli Srinivas, Group Chief of Medical Services, Manipal Hospitals. Please give a round of applause to welcome all our speakers on stage. I would hand over to Dr. Madhu Sasidhar to steer this discussion forward.
Does it work? Okay, good. Well, thank you for that introduction, and it's an incredible panel. So we'll start off, and maybe I'll frame this discussion, and I really look forward to hearing from each one of you, because I think you've heard this throughout the session today, the incredible promise of digital technologies, the ability to utilize artificial intelligence and AI tools, remote telehealth, and all of this is predicated on digital transformation, which affects every aspect of how we provide care, right? Everything from clinical care delivery to the bedside to how we manage the workforce, how we manage the cost inputs for healthcare. So really look forward to hearing your experiences in driving digital transformation. So I will hand it over to each one of you to share your experiences, and then we'll hold some questions at the end, and hopefully even take some questions from the audience. So Dr. Fedorowski, if I could hand this over to you for you to share some of your experiences from Poland. Yes.
Thank you so much. I wonder if my presentation is going to be available, but of course I'm prepared to...
Perfect. Do we have slides for Dr. Fed?
I'm prepared to speak as a panelist, so if it doesn't come, I'm really happy to be here. I know that people are coming from far east like Fiji, but there are also people coming from relatively far west, that is Poland. We have something in common history. I just read that Poland and India, the first signs of the human presence were dated 75,000 years ago, both in India and in Poland. So a very common history in that regard. What we're doing in Poland, briefly speaking, we're a Central European country and a member of the European Union. We spend about 75 billion of US dollars on healthcare. So I know India is spending about 120 billions. Of course, we are much smaller. So I think the amount of money per capita that Poland is spending is about $2,000 per capita per year. But we think is, of course, not enough to be able to provide optimal healthcare. What is optimum is, of course, a big point of discussion. So as we are the member of the European Union, and I'm one of the very few representatives of the European Union, also representing International Hospital Federation as a treasurer, so I have all kinds of money, hospitals worldwide with me. That's a joke, of course. By the way, so all of those organizations are looking into digital transformation, and in Europe we're quite advanced with regulations. Sometimes we think the regulations are a little bit too much, because the European Union has enacted AI regulations in healthcare. It's very mature. We think it might be too restrictive at some points. We're dealing with some challenges with regard to the protection of of data. So GDPR in the European version is quite strong, and then we're dealing with that obstacle as a challenge, not as a problem, but as a challenge. What we have done in Poland is, in your pursuit of the universal coverage, we are already there. We have the universal coverage, so everybody has the coverage, but the approach is a bit different. In India, you have the approach that is a certain amount of money, quite specified for the family. Our approach is that everybody has the access to what is called a basket of services. So people who are covered by the universal coverage by the government plan, but it's of course financed from taxes, so it's citizens' plan. Government doesn't have its own money. So those citizens are covered fully for all of the services that are within the basket, and basically they cover all of the modern technologies that are there. That could create some waiting lines, but they're much shorter than in the UK, for example. And our discussion on the advancement in technology is about AI. We have the coalition that is within ecosystem of the Polish Hospital Federation. We are a relatively small NGO covering 550 hospitals, so maybe large, actually. It's a non-governmental organization. And we have the coalition that is publishing a white paper in AI in healthcare. We have lots of technology for telemedicine that is, of course, accelerated during the COVID times, but our ideas for the Polish Hospital Federation for telemedicine came before COVID. So we were actually predicting perhaps that we would need to accelerate modern technology for telemedicine. We're quite advanced with wearables. In Poland, we have a number of companies that are producing advanced devices for technology and telemonitoring, like wristbands and vests and all of those wearables. That's quite advanced. And we also are looking into the nationwide system that has already been enacted. We have the electronic prescription. That is a nationwide prescription, so I can open my phone. I got the prescription for me and my father because he gave me the permission. There has to be a permission. So we have a national e-prescription. We have the national e-referral form. And our system for approving the medical documents is very unified because any citizen can connect to its own bank, and the bank will simply quickly confirm the identity of a person. So it's several clicks, but it's quite fast and very proficient because everybody has, almost everybody, most people have the bank account, and we also have the electronic ID. So there's an electronic ID on the phone that you could use for encounters in healthcare. And perhaps last but not least, the economic growth in Poland is quite dynamic, is the highest in the European Union, and has been like that for a number of years. And we recently are actually distributing the recovery fund, that is the European Union distributory recovery fund post-COVID, and the amount of money that Poland is distributing for improvements in healthcare is 4.2 billion euros. 4.2 billion euros. That's considerable amount, and huge part of that is going into further digitalization. So we think that the hospitals are the hospitals are adopting the technology. They have perspectives of money. Large hospitals are the leaders. Large university hospitals in Poland, they combined, they produced a net profit of about $100 million last year. So the small hospitals that are not connected, they don't work together, they seem to be in not the greatest position. And my last sentence is about a different spirit, which I am actually more in favor of what you have in India, that you speak about how to cooperate the public and private, and the discussion in Poland is right now how to separate private from public, which I'm not in favor, because our federation, we're not even talking about private and public. In the Polish Hospital Federation, our vision is a sustainable healthcare system above divisions. So we try to avoid private-public nomenclature. We think about good quality, hospitals, patient care, and all of those things. So happy to be here and glad to share more experiences. I had some slides with information about what we're doing, but I think that the panel discussion should suffice. And I'm open to link with you on the LinkedIn. I'm quite active there. Already posted number of thoughts from this conference. Thank you, Apollo Hospitals, and thank you all of the Indian hospitality here. It's great to be here.
Thank you, Dr. Fedorowski. Incredible perspective on the Polish health system. And I will have some follow-up questions for you. I would also ask members of the audience, as you hear through our panelists and their experiences, if you have questions, please write them down. If we have time at the end, we will take some questions from you as well. So thank you, Dr. Fedorowski. Let me just hand it over to Dr. Saudullah and would love to hear from you, your journey on digital transformation and where you see yourself and the path ahead. Over to you, Doctor.
There's a little transmission problem. Yeah, I think, digital transformation of the hospital is, I'm from Trivandrum, Kerala, and we had a good experience in this one because our hospital is about 23 years old, and KIMS Health. And anyway, thank you, Mathu, the chair, as well as the, the co-panelist. And thanks, Apollo, for inviting us over here. In the last, from the very beginning, we were oriented to digitalization and trying to adapt totally an electronic medical record and so total digitalization. It did not happen until about 12 years ago. And 12 years ago, the outpatient was completely digitalized, so no one has any medical records at all, and we don't have any medical record rooms, and no more medical record or ward clerks. And it took about another 2 or 3 years to implement the inpatient digitalization. And and in the last 8 to 9 years, we do not have totally, it is except certain occasions of legal, cases or some of the accident cases or consent forms. Otherwise, we do not use paper at all. The total adoption of CPOE had been done for the last 8 to 9 years. And, no paper is kept in the consulting room. I'm also an internist like Dr. Madhu Shashidharan, and we don't have any paper in the consulting room at all. And all the lab, all the RIS, LIS, all completely OP, IP, totally integrated, so that except what I said that, certain areas where we need to have consent forms and all, and otherwise is paperless and totally filmless. Probably many other hospitals in India might have adapted that, but the adaptation was made easier 100% by my staff, my doctors. And that is what that complete credit goes to them. And it is not like scanning and doing it. Everyone enters directly. And that adoption, many people, when they come and see, they cannot believe it. Many people thought that it is being scanned and done. And we also have, CPOE totally, and a continuous training and development was the main reason we could achieve this. Otherwise, it would not have been possible. So After this adoption, we also looked into IoT, and there's a lot of IoT facilities we are using it now, and especially tracking the samples of lab, the pharmacy, drugs tracking, even the shifters who are going, we still have a lot of shifters, patient shifters and all, and when they are tagged and they are tracked, and that is where we are using the IoT devices, and it is very effective, and as well as it has been very guest friendly. The third thing which we said, only a couple of things more, is that we also have an artificial limb center. And I always, talk about this 3D printing of, and I couldn't believe that I could do that. So with a Japanese company, we now print the artificial limb above knee and below knee. And, I myself stood there and watched that. It is an amazing thing. So these limbs are printed on the basis of the photographs and computer images which you make it. And that's the third technological adaptation we have done. But the most important point I want to underline is that the training and development which is going continuously by our IT department. So now comes the AI. And so the AI, probably a little too much AI, even today on the way coming to this conference, I had one call from somebody in Dubai and saying that they have developed a startup and they want to come and see me at all. And so Kerala has got one of the highest number of startups in India. And so sometimes I feel that it is important, it is nice to have, but is it a bit too much at the moment is something. But anyway, we also started going to AI, and with the electronic medical record completely adapted now, we are trying to integrate AI in many areas. Some of the areas is that doctors do spend a lot of time for entering. So the first thing is that voice recognition, and so that they can, when they have a conversation with the patient, that will be converted and typed into clinical information in the format or a template which you have made. And we have started that in one hospital, and that is working very well, and so we are trying to adapt in the other. The other second AI tool we have tried and successfully is that billing of the, to avoid the medication errors and all that, the medicines which is taken and then given to the patient and then is completely billed. So there is no ward clerk or anybody to enter. This all is being entered by AI, and this avoids a lot of billing issues and cancellations and discharge medication issues. And the third one we have tried is discharge tracking. And by the time the doctor says that, okay, the guest is ready for discharge, from there we could cut down from a 2.5 hours or 3 hours time to now averaging 1 hour. And so because this is very well tracked by some of the AI integration. So few areas where we have tried out, it is very successful, and so we are going in that direction. And even pharmacy, drugs, the drug interaction is one of the area we really want to spend time on it. So I think AI is coming up, but we have already stabilized and consolidated on the electronic medical record, and pretty much we are paperless. So this is an experience I wanted to share, and we have used this Japanese system, and that's how it is done. Thank you.
No, thank you, Dr. Saudul. I mean, what a fascinating range from complete digitization of your patient medical record to the use of IoT and technologies such as 3D printing. One particular thing, and I want to understand what your magic is how did you get your doctors to adopt 100% CPOE? Because you must have some secret there. I've struggled, and it's not easy.
I know you will ask that. I think I'm a practicing doctor, and I am also the chairman and the managing director, and so I have the experience of having worked in an American hospital with, the EMR. And so from that time, I thought it's convinced, but there were problems that patient, we spend a lot of time typing out and, and I remember we went to Thailand, Bamrangrad Hospital. There, I remember I went with Sangeeta Reddy, and she said that, let us go there and find out. They said they are paperless. And finally, when we went there and looked at it, they are writing it, scanning it, and feeding into it. So this is not paperless, and this is not the way to do it. And so we came. In fact, we went out unannounced, and then the CEO knew that we are there, and he came and received us. So I think what we have done is that continuous training and development. In the first month, anybody joining, the nurses and the doctors, they will have a full orientation on typing the information. In fact, one of the oldest doctor we have is, our cardiology chief, Dr. Vijay Raghavan. Even he adapted typing out. There are certain people who are not adapted with it, and they are helped to by one or two nurses or ward clerks. Otherwise, I will say 99% of the doctors are entering directly. Now we have come out of the tablets, and so they can enter from the tablets also. Until then, it was only desktop and as well as the laptop. And now the tablets also, and very soon we are thinking that we can enter from the mobile itself, and they can enter from even home. So the adaptation is only because of the commitment of the doctors. And once they knew the advantages, and I did not have to go after them. Thank you.
Very, very nice. Thank you, Dr. Sadullah. I'll now turn this over to Dr. Murali Srinivasan to understand a little bit about how he is using AI, primarily around optimizing costs and some AI implementation challenges.
Thank you, Dr. Madhu, and thank the organizers for giving us an opportunity. Greetings for all of you from Manipal hospitals. As a clinician, I always used to wonder, whether all AI and ML is only for the engineers, and maybe it's only for, if at all, it's only for, some back-end work, not for clinical use, Until, because I also handle a bit of medical capex, selection when we had a presentation on ortho robo. And then I realized in ortho robo, many a times, most of the orthopedicians say we do better job than as good as a robo. And maybe many a times, it takes a lot of time and so on. So what happened is when I listened to it and when I did a lot of research on it, I understood that for an ortho robo, when a lot of things go in, a lot of data has to be fed in. So meaning, for example, most of the advanced ones, you will have to take X-rays, CT scans, and then feed into it. And then what that does is that analyzes the race. There are so many races among us, human race, meaning Asians, it sees what type of race that knee belongs to. In that, what type of shape, what is biomechanics, various other aspects, which probably are much higher than what we could normally think through. And then finally, it looks at where is the cartilage damage, which part, and what this thing. And then finally, it gives suggestions on the prosthesis, how it should be aligned, and so on and so forth. And that's why, when it comes, to this, the final results, very well used, the robotic probably is able to deliver much better outcomes if that is well utilized. So that opened up a lot of thought process. And then, I strongly believe that if we don't partner, with AI, ML, and I'm using some of this interchangeably, clinically we have to partner with them, to deliver the best care for our patients. So having said this, being also wearing an administrator cap, we said, how can we look at some of these aspects in two aspects? As I said, I'll cover two, I'll touch upon two aspects. One is cost and another is operational efficiency. And then maybe I'll give a couple of suggestions, how do we go forward. Now, one of the important aspect, people talk about is that I've spent so much on, the digital infrastructure and this thing, so it is not adding value. That is one part of it. Second is, how is it able to add value in reducing cost? So I'll give you 2 or 3 examples, which, we have sort of done. Of course, for this, it's very important. You should have a system which is robust and also is able to have a little bit of learning. May not need a very high-end level of artificial intelligence. I'll start with estimation. Today, most of the times, and I'm sure in the years to come, with so many schemes, you have the GIPSA, you have Ayushman Bharat, so many others coming in, cost is going to play a major role. And estimation, many a times, there are challenges. Challenges because of, one, comorbidities, one, other associations, one, sometimes, you open up and find something different. I'm talking more for elective procedures. Of course, in emergency, we probably may not be able to really give. And then there is also surgeon or inter-doctor variability. So there are a lot of these things which goes into an estimate, which makes actual estimate, quite difficult to come closer to the real. If you give too high, then the patient, you lose the patient or, the patient. So then the good systems is able to pick up, where the doctor behavior and also looking at comorbidities is able to give us some idea whether your estimate is closer to what that is estimated. Now, after estimate, the patient comes in. I'm just taking 2 or 3 parts as the patient journey. And one of the, again, major problem for all of us is the use of consumables. While, again, if very, very important for all of this is to have interfaces. Every step what we use, if we are able to somewhere digitally link or have an interface. I know Dr. Sahadullah and others also talked about RFID and other things. That is a little higher level, but somewhere if you are able to have an interface, that data is captured. And the second step is someone to analyze. If we are able to do these 2 things, you would know how many reagents you have used for how many tests. What is the level of consumable for a particular procedure, maybe a CABG. And then, today, people are also, I was told, someone demonstrated also that they are developing applications because many a times the staff nurse is busy, they are not able to enter everything into the system. So you just need to take a photograph and that learns over a period of time. At the time of surgery, what has been used, after surgery, a photograph, what is left over. So it knows what is used, what is returned to a good extent, it is able to calculate. So again, there is a lot of amount of an AI and an ML, which is able to sort of help you to optimize, certain costs of consumables and so on. And the same can also be adopted if well planned for OT turnaround time. Many a times, challenges are in cath lab and OT between cases. There are, turnaround time is high and so on. Third is on efficiencies. As I said, one part is clinical cost, third is on efficiencies. Operational efficiencies, all of us know, can be built very, very high. I'm giving a very simple, this thing is appointment scheduling. All of us know a neurologist, I'm talking because for my own specialty, probably takes a much longer time than a dermatologist. It's 2 ends of a spectrum. But many a times we tend to give a 15-minute slot or a 20-minute slot. And even in a neurologist, some of my colleagues do very fast, and some of us take a longer time. So again, the system can learn and say, okay, the appointment scheduling can be done. So the doctor's time could be used efficiently. So in a nutshell, if I have to say, that one is identify or at least all the important touch points, which is a bottleneck, and try to digitalize them. Having done that, I think it's also very important, someone has to look at the data on a periodic basis and also analyze and take corrective measures. Most of the time the data is lying and maybe we look at it a little bit, but we are maybe reluctant to take corrective. So unless we do this, I think, we may not achieve what is needed. The last point I would want to also say is...
Dr. Sri, I'm so sorry to interrupt you.
Yeah.
I'm being told that we are running out of time, and we
sure.
have two panelists. So I'm going to come back to you if there's still time left, but if I can maybe hand it over to Dr. Ritu Garg. Ritu, I know you've been driving a lot of innovation and innovative practices within your group. So maybe share a little bit. I'm told we have about 5-6 minutes, so we'll have to go through this quickly.
Thank you. So I think just like everybody else, as a healthcare provider, I don't think we have a choice, and I think digital transformation is for real. We've all adopted it, it's part of the DNA. In fact, what I feel is that clinically, medicine has always been about innovation. I think the medicine has evolution been always there, right from generics to innovators, or from open surgeries to lab to robotics, or the research that happens on the medicine side. I think it's only the delivery side and the data which was lacking, which is now fueling innovation and transformation. At Fortis, we set up a separate innovation vertical just so that we can have a focused approach towards it. We also encourage a lot of bottoms-up innovation. So idea is to start thinking about it and changing the culture and the DNA of the organization, where every single person who's next to the patient, right at the wards, right from the GDAs to the nurses, can participate in this transformation. So we routinely run innovation challenges where we kind of encourage people to come up with what they are facing right now and what can change. And this has been phenomenal success for us, and some very, very interesting ideas that have been institutionalized have come through that. We are also now part of IHH network, so we've started actually running these challenges now at international level, globally, across our markets in Malaysia, Singapore, India, Turkey. And we've actually now this year put a sandbox where we have put in a fund which is there for anybody who's got an interesting idea and which we feel can be transformative for the organization to work with. So there's a judging panel, and we do all of that as well. So that has been, so all we have done is institutionalized this transformation and not just kept it as a top-down somewhere out there, but to say that this is to become part of life, just as any of our other functions.
Fascinating. Dr. Nandakumar, go ahead. So I'll hand it over to Dr. Nandakumar. Maybe from your experience in Shamrad, and one thing that we've perhaps not touched on is that workforce how do you prepare the workforce to be good consumers of AI? So if you could just tell a little bit about how you're thinking about that.
So introducing AI requires a commitment that is considerable. There needs to be a change in the mindset of the workforce, and also there needs to be an understanding in the workforce that this is not something that they should be fighting or afraid of, that they will lose their job. It is something that will be complementary to them and increase efficiency and productivity of all concerned. Firstly, there has to be a change that is instituted by the leaders of an institution. They must be convinced that AI is good, and they should permeate their message to every level of the staff. The second, the infrastructure in the institution has to be appropriate, like a high number of internet and so on and so forth that is required for AI. For the staff itself, there is a three-pronged suggestion that I would make. First, is to equip them with the knowledge of AI, its benefits, its limitations, its dangers, because we all know it is an extremely valuable tool, but it can be equally harmful. Understanding this is of vital importance. Second would be domain-specific training, which is training in a specific service or department, like a cardiac cath or a pathology service. These things will differ in the way they use artificial intelligence. Third would be hands-on, and a hands-on training is extremely important. One important aspect that should be kept in mind is to allow interaction between the AI technicians and technologists and the staff. This is vital because the technologist has to understand the medical aspects and the medical staff will have to understand the technology that goes into it, and this creates a synergy that is best carried forward. Lastly, I would say there is an evolution that AI is seeing in every aspect of its function, and therefore constant update and explaining to the staff that this dynamic change is something that they should adopt is extremely important. I did overlook mentioning one thing, and that is reskilling. It's almost like unlearning how you work and relearning, which is extremely difficult for some of the workers, especially those who have been in work and service for more than several decades. They would find it difficult, but persistence, training, and following all these principles would, in my opinion, be the best way forward.
Thank you so much. It's been a wonderful panel. Do we have time for one question and one response? So this has been fantastic, and what a range of experiences from everyone on the panel. I do have one question, and it has to do with ethical use of AI, right? We look at the opportunity, we look at the potential, but we understand that error is inescapable, and perhaps we need to treat AI like we would treat any physician. Some sort of peer review, some sort of rigorous ongoing analysis. Can any one of you share an example perhaps where you've had to deal with ethical issues in AI and maybe how you've thought about it or solved for it?
So I think it's a brilliant question, and in this whole frenzy of data and AI, I think ethics is extremely important, and I would divide that into 2-3 aspects of it. One is definitely the data privacy and security, and thankfully now we have a data protection law. We also have at Fortis, for example, a data protection officer whose only job is to make sure that the data is secure and private, and it's not misused by either the vendors or by anybody else. So there are very strong guardrails around that. Second would be also the creeping of bias, to what you exactly said. Just as we unfortunately face in the publication where the data is many times Caucasian, and a lot of protocols are made without the equity of regional preferences. Similarly, the LLM models that are getting trained may not be getting trained on an equitable set of data. And when the skew happens on AI models, then they can get compounded significantly. So even a minor error may lead to somebody losing lives. So in my view, the only answer to that is a very strict human oversight. We use AI extensively for mental health, so we use it as a psychological first aid. But to be able to do that, we had the entire clinical team doing extremely deep testing of the AI models before they allowed that to happen, with regular audits and making sure that algorithms are tested very, very deeply like you would do in any other research, and making sure that there is always an intervention by a human at a low threshold, so that there is no, so if there is, for example, even a hint of a suicidal tendency, then it needs to be flagged right there and sent to a human interface to be able to manage that.
Brilliant answer, and I think the takeaway is a high level of self-regulation, constant awareness, audit, reporting, transparency, and at this stage to always have a human in the loop. I want to thank the panel. It has been an incredible discussion. Thank you all.
Please give a round of applause to all our speakers on stage, and I request all of you to please gather for a group photograph. Thank you. We will move on with our next panel since we are running a few minutes late. Our next panel discussion is from data to diagnosis, AI's role in health research. Now, AI-powered imaging tools can help detect diseases like cancer, Alzheimer's, and cardiovascular diseases early on. By predicting how molecules will interact, they reduce the trial and error experiments. AI is accelerating drug discovery as well. This session will explore the transformative role of artificial intelligence in health research, from leadership strategies to AI-driven precision medicine. Chairing this session, we have Dr. Risto Mittunen, visiting adjunct professor, University of Colorado, Denver, and former president of the International Hospital Federation. He is going to be chairing this discussion. Please give a round of applause to Dr. Risto. He is an internationally experienced senior executive leader and teacher in healthcare services industry. We are also honored to have a lineup of distinguished speakers who will be sharing their insights. Please welcome Mark Harrison, Managing Director and CEO, Health Assurance Transformation Corp., who will discuss leadership lessons in digital innovation and its impact on healthcare transformation. We also have on stage with us Professor Wendy Chapman, Center Director, University of Melbourne, who will address the challenges of AI adoption for patient-centric care. We have Spiratan Bakas, Joshua Edwards, Associate Professor, IU School of Medicine, who will provide an in-depth perspective on federated learnings. And we have Dr. Abdullah Al-Hawsawi, CEO and co-founder, Genomics, who will highlight how AI and genomics are revolutionizing precision medicine. So I'm going to hand it over to Dr. Risto to steer this discussion.
Thank you so much. I noticed there's a slight change, missing Mr. Tom Navasero. He will not be here. Thank you. So great to be here. We are changing the format in that this will not be a panel, but a series of presentations. So you have 10 minutes each, and we all know we are run a little bit late here, so please pay attention to your time. We are actually missing one speaker, so that might give us a couple of minutes then maybe for questions or discussions. So thank you for the nice introductions. You have seen it all, I will not repeat it. So the first speaker will be Mark Harrison. We heard Mark's talk this morning already, excellent talk, and now obviously Mark's going to continue a leadership lesson. So Mark, please, the podium is yours.
Well, I will be completely candid that I had thought this was a panel discussion, not a presentation. So I'm actually happy to give you a couple of moments on leadership approaches, and I'm happy to answer questions either from you or from the audience as well. So if there's a mic runner who might be limbered up for the audience, I would really appreciate it. I actually find that the leadership approach is no different for the IT and AI world than it is for any other sort of leadership. One needs to be clear, they need to be organized, and people really listen to what you say and what you do, and they deviate from the standards when you do yourself. At Intermountain and at Cleveland Clinic and now at HATCO, we're extraordinarily crisp and clear in terms of what we believe. We have clear theses about what IT and AI should do for healthcare, and they are as follows. We should make sure that health systems become resilient in an era where they are actually highly distressed. We should make healthcare more equitable. We should make healthcare more affordable, and we should make it of higher quality. We are very careful to make sure that our actions and our words are consistent, and we're very rigorous to make sure that economically the underpinnings are sound. Let me tell you a little bit about the healthcare transformation that we are leading and that I'm leading, and I think that may actually spur some questions and some commentary. The company that I've just started, which most of you don't know anything about, very different from a traditional not-for-profit or for-profit healthcare system. The thesis is that the thin margins and poor quality that are generally seen in most healthcare systems can be remedied with careful application and interdigitation of IT, particularly AI, into the regular operating model of the system. In order to make the transformation, it's absolutely imperative that the leader does not empower the team to overlay digital solutions on top of weak operations. That's probably the most common mistake that I see and we see as we work with our 25 partner systems in 4 countries around the world. What you end up with is just extraordinarily inefficient systems that are then amplified by technology. So our approach generally is to go ahead and make sure that operations are optimized in traditional ways with usual scorecards, and then begin to feather in technology, particularly AI-powered technologies, in both diagnostics as well as clinical care. The other mistake that we commonly see is to push digital solutions onto clinical workforces as opposed to have them pulled into workforces by clinical leaders who have respect from their peers. So let me pause there for a second and see whether you have any questions for me. And again, apologies that I was unaware that I was supposed to have slides and a formal presentation. I'd be happy to answer questions either from my colleagues or from the audience.
So basically, I would like to make a very simple question. Just,
Yes, please.
I'm not an advanced user of AI, but my personal experience, depending on which system I use, say ChatGPT or Copilot or whatever, for the same question, I get different answers. So is there a bias in AI depending on your own surroundings and where you pose the question and which system you use?
So the question, as you all heard, was around bias in AI and the large language models. So I'm going to answer that in 2 parts. So first, if you want to have the best possible result, you ideally train from proprietary data that is not on the web. And a good example of that are the agentic models that we've helped create, where we actually use real clinical data, not data that is parsed by the web. Second, all data eventually becomes exhausted unless it is constantly replenished. And the best models have access to new and ongoing addition of data. Finally, I think people probably, in my estimation, are too concerned about hallucination and other limitations of some of the large language models that are commercially available. And in a co-pilot model, like you described in the last session, I think they're quite safe and actually can save enormous amounts of time and give very good results. I'll give you a very practical example. A team I was working with was trying to understand what a clinical protocol would look like for ARDS. And then the question was, should we impanel a team? Should they review the literature? Should we come up with best practice? And as somebody who sat on many clinical protocol panels over the years, they're incredibly frustrating. They actually are often so dumbed down by consensus thinking that the protocol is really lousy in the end. Compare that to asking a commercially available model to, with a smart person, not somebody like me writing the prompts. In 1 minute you had the answer and it was 90% correct, and experts could go ahead and come up with a refined version very quickly. So, you know, the way I frame AI and all technology is it's like a hammer. You can use a hammer to build a house, or you can use a hammer to beat somebody over the head with it. And things can be used for good or for evil, and it's how the human beings who oversee it moderate and govern it is that determines the result.
Okay,
Clear
thank
answer?
you, thank you. We probably will have a round of questions then after the presentations. Thank you. Now you can make your choice, depending whether you will have slides and stuff, if you want to keep sitting or then standing. It's up to you. So, yes, please, the next speaker will be Wendy, and let's welcome her. The podium is yours.
Okay. I'm hoping my slides will come up. Oh, there it is. I'm noting that a lot of us have accents different from the place where we work. Not Mark, but everyone else on this stage does, so apologies that I don't have an Australian accent. But I'll tell you where it all started for me, and this is where it started in some ways for Mark as well, and this is with Homer Warner. And in 1961, he published the first paper where he used real data on patients and compared it against a Bayesian algorithm for diagnosis, and you know, compared how well that did against human doctors. And he said old cardiologists were just shocked that you could use a computer that could perform better than them. And this was in 1961. So AI's been around a long time, but it's not in common use, at least in clinical care for diagnosis and treatment types of decisions. And there's a lot of reasons for that. And so that's what I want to focus on, is that gap. But we can see that the role of a clinician is changing with AI. And it's been that way all along with all kinds of technologies. Every new technology changes the way people practice. And when we had UpToDate, we don't have to memorize as much. With clinical trials, you have to now start to read the literature and learn about what the evidence is. And as you start to get more AI in place and decision support in place, it's the AI human teaming that we have to figure out. And that means what the clinician does in their time is different, and the skills that they have are different. And we need to be able to be training people for those as well. It also changes the workflow and the governance. And you'll see that this was in California, protests by nurses because they were not able to override the AI. They had to do exactly what the AI said. Physicians could override it. And in Australia, a similar thing where they weren't given enough leeway, and it caused extra work because they had to constantly be telling the doctor about things that they knew weren't a problem. So AI brings up a lot of different issues. And patients, the role of patients is changing as well. And patients are using AI, and there's a hashtag patients use AI, and they're using it in many different ways. You might remember the story in the news last year of a little boy who had chronic pain for a long time, went to many, many doctors, and his mother finally fed all his records into ChatGPT, and it found the diagnosis that he actually had, and now he's being treated for that. Well, we did a small review of the guidelines for AI implementation into healthcare. And each one of these rows is a guideline. The darker color means something's mentioned a lot. So the columns are the types of things that are being recommended. And the dark blue means it's mentioned a lot, the light blue means it's mentioned a little, and the white means it's not mentioned at all. And not surprisingly, just like any other digital innovation, on the left side, you're talking about the technical accuracy. You should measure accuracy, you should look for bias, and then you start to look for how you train people to use it, and then how you implement it into healthcare, and then what benefit are you getting from it. And the further you get to the right, the less even the guidelines are telling us that we need to look at, much less that there's any evidence there. And so I want to focus on that right side of the graph because that's where there's a big gap. And so I think there's 3 areas in this short time that I'll touch on. And the first is legal. I'm not a lawyer, but I spoke to the Supreme Court and magistrates of Victoria a couple of weeks ago, and that about healthcare AI, and it was very fascinating. I recommend this podcast if you're interested in this topic. Now, there's no case law in AI and how that's going to be used in healthcare. And, you know, this was built for men, this lectern. I can't see my slides down there, but just so you know. Just the equity. It's okay, I can't see over the lectern. But if you think about a use case where radiologists are using an AI that was provided by the health system to look for, you know, cancer, let's say, or masses in chest x-rays, and neither of them identify a cancer, and now the lung cancer is delayed, that alters the patient outcome. Is the radiologist negligent? These are the types of things we have to be looking at. Well, what if the radiologist doesn't use the AI and the AI would have found it? When does it switch so you have a duty of care to use the AI and you're not using it? These are things that we're going to be seeing come up in the near future. And so, you know, this is from Eric Topol. We still lack definitive proof that these approaches, these AI approaches tested in research studies or pilot programs will achieve the same success in the messy realities of everyday care. Everything's evaluated in the lab and on retrospective historical data and not as part of the team and part of the workflow. And so that's a big gap. So that leads to the economic part of it. And we've heard this a few times today. This is Nigam Shah at Stanford, why AI is good for our health but may hurt our wallets. And regulatory approvals examine if they work, but not whether they create value in the form of better quality of care for patients relative to the cost. And they also don't take into consideration how an AI tool will fit into the existing or new workflows. So these are gaps in our evaluations of AI. And finally, the workflow, the implementation. It's been our assumption that a human plus a computer is going to be better than the human alone. But there have been 5 studies so far that show that that's not true. There are some that show that it is true, but there's a lot to learn about this. And they're showing that the human plus the AI is worse than the AI alone. That kind of boggles the mind, but if you think about biases and the kinds of biases that humans have, it can make sense, and the lack of trust, and maybe this will change over time. But there's just a lot to be learned about what it means to team with an AI tool. When you think about building a user interface, will the output of the AI solution change the decision making? If not, why would you even put it in place? Because it's going to cost a lot of money. What value does it add? What's the best way to engender trust and interpretation? What's the best way to deliver it? Who do you deliver it to? Do you give them a number? You know, when do you give it to them? What color? What format? What's the optimal workflow? What's the best governance and escalation when the AI says something is wrong? And should it be used alone? Should it be used before the doctor makes the diagnosis? Together? After? These are all things that are unsolved, and they depend on your local context. They aren't things that you can just say, oh, it's Stanford, they did it this way, so in India we're going to do it this other way. So I think there's just a lot of work to do to really figure out how to use AI. And at the University of Melbourne, we've developed an infrastructure called the Validitron to help people do this, whether they're researchers, government, or industry. And so we work with a lot of different collaborators to try to help people figure out how to answer these questions in the preclinical space before you introduce it into the clinical space. And so it's really helping debug it, de-risk it, and figure out the best way to implement it, and answered all types of questions like what the workflow should look like. So we have a simulation lab with a bunch of different clinical spaces that are immersive. We have a home environment so you can look at telehealth, and you can really, and then we have a digital sandbox so that you have all the different AI tools, EMRs, messaging tools, telehealth, so that you can really figure out what should this look like in my environment, and have people have the pull from the clinical champions co-design what it looks like, and so that you've at least knocked over a lot of the barriers that you're going to face, because for 70 years we've had AI and we've tried to implement it and we've failed over and over. So let's learn from those mistakes and figure out how to do it better. Thanks.
Thank you so much, Wendy. So, quite interesting points. And actually, I think I'm going to save my question to all of you after the talks as something I just want to hear from you all. So let's, at this phase, move directly to Spiridon. And do you want to go to the podium? So the floor is yours, please.
Thank you. First, I would like to start by thanking the organizers for giving me the opportunity to be here today and talk to you about the past and the future of federated learning. As a full disclosure, I have to admit that I'm extremely jet lagged, so please, if something that I say does not make sense, please excuse me. And just to put things into context, I'm a computer scientist by training, not formal medical education here, but I've been focusing throughout my career in the design, deployment, and particularly benchmarking of AI methods before they were called AI to address clinical needs. So the rest of my talking is going to be split into 3 components. Number 1, explaining what is federated learning in a couple of slides for those that are not aware, and then talking about the past and the future of federated learning. So starting about what is federated learning, single institution AI studies, we all know what these are about. We identify a retrospective cohort on someone's hospital to train and generate an AI model. It works to a certain extent, but the problem with this is that the model performance itself is limited by the data that we feed into the model, meaning that the accuracy of the model is determined by the size of the data. The more data we give to the model, the better it will perform. And then the generalizability of the model depends on the diversity of the data. So the more diverse patient populations we feed into the model, the more generalizable it will be. So to address this component, we established multi-institutional collaborations. The current paradigm for that is by sharing data, calling up our collaborators and asking them to share their data in a centralized location. At the very best scenario, create a repository so then we can go and tap on and generate an AI model. It works certainly better than single institution studies, but still it doesn't really scale easily due to all these concerns mentioned in this slide. So here comes federated learning to facilitate these multi-site collaborations without sharing data while capturing diverse patient populations. Federated learning as a concept was introduced by Google in 2017 in a statistical conference, the use case being to improve their autocomplete functionality when they type messages. So that functionality that we have that predict the next letter or the next word when we type a text message. The idea is that instead of learning from one individual's typing habits, they will learn by multiple people. As you can imagine, if they were asking to share the data from your phone to a Google server, that wouldn't really go far. Instead, they were training a model locally on each one's phone, and then they were sharing the model in a centralized location, aggregating to create a consensus model. Of course, this Google use case we're talking about billions of users that we don't have in healthcare. We have far more finite number of users and collaborators, but still intrigued by the idea. A year later, my group in collaboration with Intel were able to introduce federated learning in healthcare when we presented the first results of federated learning in the MICAI conference in 2018. So what happens really here in a very high level view, we have our collaborators on one side of the screen, the data owners, so-called, and we have a centralized server that we define a model, and we ask them to train this particular model. Then each individual of them, they train the model locally to learn and generate their local model updates. As you understand here, the red collaborator creates the red model, the blue collaborator creates the blue model, so on and so forth. Then once they create and train the local model, then they share the models in a centralized location, that aggregator, to create a consensus model, which is then be shared back to them for further training or for use. So that's kind of the concept of what is federated learning. So from that point, what is the past? What federated learning has helped us achieve so far? Let's go back to that feasibility study that I mentioned. So we took the use case of neuro-oncology of defining tumor boundaries in MRI scans, and we had data from 10 collaborating sites with varying contribution of patients per collaborator. And we compare the data sharing paradigm with the federated learning paradigm. Striking finding here, I will spare you the details, is that the federated learning model performance reached 99% of the model trained under the data sharing paradigm. So from that point, I'm not going to touch upon why neuro-oncology and why this particular use case. I want to give a big shout out to NIH's funding program on informatics technology for cancer research, which awarded us funding to develop an open source software infrastructure to facilitate and disseminate tools for cancer research. I'm just going to spare you the details about the complete infrastructure. I've included in this slide links and publications of all the software tools that we've developed. So this really infrastructure enabled us to conduct the largest real-world federated learning study globally. We're talking about 71 collaborating sites around the globe to develop an AI model to determine the boundaries of brain tumors when importantly the data were never shared outside the acquiring institution. Federated learning here really enabled the largest imaging study of glioblastoma that was ever conceived. So up to that point, we knew that in the literature there were studies that were involving a few hundred patients. Here we reached 6,300 patients worth of data that the model learned from using federated learning. So federated not only facilitated big data analysis, but expedited it. And I have this figure here to show you 10 years that we're trying to focus on this particular use case, that we try to pool data in a centralized location to create, to develop models to really address this problem. And after 10 years, we were barely able to break that 2,000 cases point. Now compare these 10 years with 10 months of the federated learning study to understand the impact that federated learning can have in healthcare. So from that study, we currently have an ongoing effort that we are touching upon recurrent glioblastoma, again hitting upon brain tumors, very point solution, very specific use case. There's nothing in particular about brain tumors that make federated learning work. We've seen the similar results on breast cancer risk assessment, on prostate tumor definitions, on detecting lymphocytes across 12 different anatomical sites and cancer types. But it's very important to see that others are also using this open source infrastructure. So I'm talking about a Montefiore health system, a health system of 11 sites in New York, that they've put in their workflow our software infrastructure for predicting death in COVID-19 patients, but also the Frontier Development Lab of NASA that they're using the very same software infrastructure to assess and understand the physiologic effects of cosmic radiation to astronauts and transfer data between ISS and Earth. So that's kind of the individual use cases that we've seen so far of federated learning real world, predominantly coming from our group. What are a few considerations that I would like to put together? I've kind of tried to summarize it into 6 main considerations for future deployment of federated learning in healthcare, starting by about optimization of real-world deployment. And what I mean by that, we have on one aspect of the spectrum our talented researchers and tremendously expensive equipment that we develop such models. And on the other hand side, we have the clinical environment that we're talking of a fraction of the money of worth of equipment. So you understand we have this tremendous gap that we need to bridge here, that we have these wide and thick models. However, we need to develop methods to make these models thinner, optimize them to be able to run them on the clinical environment. So we see such results already with some methods giving kind of 50% less requirements of computational resources that are required on this space. A second consideration is involvement of leadership and information security groups from institutions. I think they heard this concept before on a couple of panels before our session here. Otherwise, we end up kind of really waiting a lot for the IT department to deploy such solutions in an operationalization way, which was actually alluding to a question that I had for Mark. I'm going to pose that in a few minutes. Third consideration is about invested collaborators. As you understand, we don't have access to the data, as I mentioned before. So really examining and accusing the data is like peeping through a keyhole, try to understand if the data is really what we require. So we need collaborators in such environments that are invested in this problem to be able to address and confirm that the data that they feed into the model, it's really the data that they should be feeding to the model. Fourth is a level of trust, and that's very important and sensitive topic. We explicitly put together a publication with in a pre-competitive setting with a couple of collaborators in this setting that we try to identify threats for stakeholders, threats for the data, threats for intellectual property, together coupled in tandem with mitigation strategies and paired for each one of them, but also associated with the computational overhead and the performance overhead of all of these and how these come into play together to have as a consideration depending on the use case and depending on how you want to apply AI in healthcare. Fifth is the handling stragglers. Depending on equipment, depending on amount of data, depending on geographic location, some people train faster than others. This is a tremendously important consideration to have during a federated learning setup as to whether we wait for all or whether we exclude some. And there is a lot of research currently on this space, on understanding whether we should wait for people or not, depending on their level of contribution, trying to quantify the membership value of each individual collaborator. Last but not least is that the data is not independently and identically distributed across the globe. What I mean is that the proportion of disease, according to institution, is not going to be the same across multiple collaborators. Something that we don't see in a centralized paradigm, that we have all the data in front of us and we know the two distributions. So take-home messages here, I would say there's certainly a need, as we've seen also from earlier talks, on the assessment of generalizability, but also on bias and inequity for underserved populations, but also developing tools for automated QC, for drifting and bias and calibration of model. There is also a promise that we see on federated learning as a paradigm shift in such collaborations that can enable and facilitate and expedite also big data analysis, as I think that I convinced you, offers a solution to all these concerns that I mentioned before, and also perform in par with data sharing. Importantly, it can contribute on monitoring performance of the model post-deployment or even post-clearance. So all these to put together to address big data analysis, to address optimally clinical questions. Now again, where do we go from here? I think I mentioned a few one-off or point solutions. I think what we're shooting for and what we need to where do we need to go from here is towards a persistent consortium for AI in healthcare. There is not going to be much, as also others mentioned before, from these point solutions. We need something that is more persistent, something that is a continuum. So we need a service there and partnering across academia, hospitals, big tech, importantly, and pharma. So for that, I would like to thank you for your attention, and also our funders that put food on the table, and our collaborating group. Thank you.
Thank you. Thank you so much, Spiridon. So we need to speed up, so we go directly to the next presentation. May I call to the podium Dr. Abdullah is going to talk about genomics and AI. So please, the floor is yours.
Thank you very much. I would like to thank the organizing committee for inviting me for this amazing event. And it's as someone who not only has founded a genomics company, but someone who's deeply involved in patient safety within my country and globally, it is very nice to see that we have actually two events. We have the THIT event as well as the International Patient Safety event, which I think they connect to each other. So what I'm going to talk about, I know that I'm the last speaker, and I promise you I didn't want to escape, but you know, I was told that the session was going to start at 5 p.m., so I was in a workshop at level 1. I'm going to talk about the AI's impact on genomics and precision medicine. I will just go into some details about the gut microbiome. This is something that we're doing in Novo Genomics, and then just conclude with some future perspectives. So I'm going to ask you a couple of questions. First of all, did you know that more than 90% of the population, so that is 9 out of every 10 people here in this room, has at least one, if not more, variant that in their genetic makeup that will have an impact on their response to medications. So as a practicing clinician, someone who prescribes medication all the time, I didn't know about that, I would say, 10 years ago. Especially for different medications, think Plavix, think warfarin, think statins, think beta blockers. We could be giving medications to patients that not only that would not help them, but could hurt them. So genetic makeup actually is extremely important, and pharmacogenetic is something that should be mainstream. What about bacteria or the microbiome? Did you know that every one of us has trillions, and yes, with a T, trillions, a million of microbiome living within our body and on our body, and that has a big impact on our health and well-being. So for decades, we have practiced in healthcare the one-size-fits-all approach, which I think in 2025 and moving forward does not cut it. I truly believe that we're the last generation that does not have a deep understanding of our health and wellness, based on our genetic makeup and our microbiome makeup. I think the future generations will have that understanding early on from the time that they were born. And rather than waiting for, someone to be sick and then we intervene, newborns will go home with their whole genome sequenced and their microbiome sequenced, and they will put them on, we will put them on a personalized health and wellness. That's my personal, belief. So this is a very busy slide, and I'm not sure that it projects well, but AI has disrupted the, genomics industry. Every one of us has 3.2 billion base pairs in our DNA, and human beings have 25,000 genes. If you look at the microbiome in our body, we're looking at tens and millions of genes, and I mentioned, trillions of bacteria. We need help. We need AI to be able to help us. So we have the technology that can help us throughout, different parts. I just want you not to forget the microbiome. I think the impact of the microbiome, and specifically things like the gut microbiome on the health and wellness, is just getting started. I think that's going to be a very positive disruptive force in improving health and wellness. So things from disease risk prediction, like BRCA1, BRCA2 for breast cancer. What we're doing in Genomics is also something called the polygenic risk score, which as a concept, it will also transform genetics from being a specialty that focuses on rare diseases into actually a specialty that focuses on common diseases. So we're introducing to the market in Saudi polygenic risk score for coronary artery disease, breast cancer, and prostate cancer. So guess what? Even if, quote unquote, your lipid profile is within normal, if your polygenic risk score is high, you should actually be on statins, because that would be very beneficial for you. Again, personalized, not one size fits all. I've spoken about pharmacogenetics, and I will come to the microbiome. So you can think about the AI's impact on genomics throughout the healthcare continuum. From the promotive aspects, I'm sure many of you are familiar with 23andMe, DNA Fit. So using your genetic makeup to personalize your nutrition. There's nothing called, the ideal diet for everyone. There's an ideal diet for me, an ideal diet for you, based on your nutrigenomics and based on your microbiome. Preventive healthcare, non-invasive prenatal screening is something that is becoming mainstream to screen for diseases like Down syndrome. So it gets done through the 10th week of pregnancy, and it's a very good screening method. And then there's early disease detection, using also AI for medical imaging and diagnostics. Precision oncology, that's another activity that we're working on in collaboration with a company from Korea. Again, doing genetic sequencing for the cancer tissue and genetic sequencing, pharmacogenetics for the chemotherapy, and then personalizing that for specific cancers. And it was brought up in previous discussions by other speakers. Drug discovery is also a big benefactor. So the gut microbiome, again, one just trivia, out of every 10 cells in our body, 8 or 9 is bacteria, including the whole microbiome, and 1 or 2 is human. So we're more bacteria than human. And the microbiome views us as a host. And if we're good to our microbiome, we will be healthy, because the microbiome does not want us to die as a host. So there is an exploding, literature on how the microbiome is helping with whole host of diseases, not just for the gastrointestinal tract, but even beyond, including, mental illness, including things like autism. So these are some of the different applications when it comes to AI and microbiome. So decoding the genetic makeup of the microbiome is something, and I mentioned, we have 25,000 genes, but in our body, the gut microbiome alone includes tens of millions of genes. Personalizing health insights, so it will help for giving everyone, a do and don't on what to eat and what not to eat. There's a very interesting, concept called precision probiotics. So based on your gut microbiome profile, you also can benefit from a specific probiotic. So rather than a one-size-fits-all approach to probiotics, you can actually have a precise probiotic for you based on your gut microbiome. Precision medicine applications as well. So one of the therapies that has been there for a long time is the fecal transplant. And now with the advancement in microbiome, it's actually becoming even more practical and acceptable in delivery. Biomarker discovery, there is some research that is happening also with one of our collaborating researchers looking at the gut microbiome and colorectal cancer and the association between the two. So very exciting to see what would come out of that, and we could potentially end up with screening, tests for colorectal cancer based on the gut microbiome, and chronic diseases, big association with metabolic syndrome and other, chronic diseases. So this is the final slide. The integration of AI in genomics, multi-omics, and microbiome promises groundbreaking advancements that will make healthcare more efficient, enhance early disease detection, and further innovations. Actually, this is my last slide. So the future of precision medicine is here. So think about AI, genomics, omics, and microbiome. This will lead to unparalleled medical advancements. We will end up having personalized health and wellness, faster diagnosis, smarter decisions, precise and effective treatment. I think it's time for us to stop practicing one size fits all. Thank you.
Thank you. Thank you so much. Very good presentations. Now, I have been informed that we don't have any time for questions, so we just have to hold with those. Thank you so much for the excellent presentations. Raised a lot of ideas, and those were really superb. Thank you all. So here we come to the conclusion of this session.
Thank you. Thank you to Dr. Risto and all our distinguished speakers on this panel for sharing their thoughts on the adoption of AI and how, it's now treatment can be customized using AI for the patients. And like the last slide said, one size fits all medicine may soon become history. Thank you all for coming here and sharing your thoughts with everyone. Please give a round of applause to our speakers here. We will now move on to our final panel of the day today, and the topic is Healing with Tech, the Path to a Sustainable Health Future. Remote patient monitoring, smart supply chain management, and energy-efficient healthcare facilities are making healthcare facilities more sustainable. Please put your hands together and welcome our session chairman, Srini Mahalingam, Senior VP and Business Unit Head, GS Lab, GABS. Please give a round of applause and welcome Srini Mahalingam on stage. He's a business leader with 22 years of US healthcare industry expertise implementing complex business and digital transformation engagements. Joining us in this discussion are Dr. Santosh Dixit, PhD, Chief Domain Expert, Innovation Labs, Persistent Systems. I'd request him to please come up on stage. Please give a round of applause and welcome Dr. Santosh Dikshit. Please welcome Mr. Sanjay Murdeshwar, Regional President, Danahi Corporation. Please also welcome Dr. Shivashish De, Head Clinical Affairs South Asia, ResMed. Please welcome Tarun Pratap Singh, AVP Head, Pre-Sales Cybersecurity Practice, Hitachi. And please welcome Abhinav Rastogi, President and CEO, Temple University Hospital, Inc., who is joining us virtually. I'll hand it over to Mr. Srini Mahalingam to steer this discussion.
Very good evening. I'm actually standing in between you all and the awards session that's going to happen immediately after that, and I'm sure that you are eagerly waiting for that. But I promise we will be on time and we will keep this very interesting because we have great speakers, experts in their area, right, are going to be part of this session. So, ladies and gentlemen, once again, I'm Srini Mahalingam from GS Lab GAVS, where we focus on the digital transformation for healthcare. And I'll be very happy to introduce my first speaker. He has to join virtual. Are we connected? Okay, in the interest of time, maybe we'll switch, right? I'll maybe welcome Mr. Santosh Dikshit, right, who's the Chief Domain Expert on Healthcare and Life Sciences and Innovation Labs Persistent Systems. So please go ahead, Mr.
Santosh. Thank you. Good evening. I think the previous session was probably a very good foundation for what I'm going to talk about. So my topic is AI for precision medicine. I would request the slides to come up, please. In the meanwhile, I am the Chief Domain Expert for Healthcare Innovations at Persistent Systems. Persistent Systems is a global systems integrator. We are a 32-year-old company based out of Pune, India, and now with a global presence and very strong footprint in healthcare, data analytics, AI, and a lot of research. As you can see, some work here. In this entire effort, we partner very closely with Google. And this is the work that we have recently done with Google. So I would also like to acknowledge the tremendous support we have received from Google as part of the presentation. In the given time, I'm going to give you some glimpses of precision medicine in the age of AI, and particularly with reference to Gen AI and how does it play out in today's situation. Having said that, I'm going to show you some demos. So I'm going to keep it less slides and actually show some prototypes in motion. You can see the magic that comes out of AI. Like I said, a quick reference to Persistent. Very happy to be here. Very grateful to the organizers for giving this opportunity. What I'm going to talk about, and I'll get to the point. The modern biology is multidimensional. It is very complex, and it is best reflected into cancer research. And cancer research, as we all know, I mean, apart from the impact on lives and families, etc., it is also a big scientific enterprise by itself. And why is it so? Because conventional cancer treatments have failed. They have failed because they were generic. Whereas now, in the last 5 to 6 years, the whole era of precision oncology, precision medicine has come about. So what is exactly precision oncology is individualization of treatment using either a genetic biomarker or a protein biomarker or now even imaging biomarker, right? So that level of individualization is bringing the precision into the precision medicine. And I'm going to talk a little bit about that. But underneath the precision medicine revolution is also a data revolution because everything is data driven right now. And that by itself brings tremendous opportunities, but there are also challenges. And what are these challenges, right? So let's quickly take a look at modern day treatment of a cancer patient. On your left hand side, you will see the multimodal data sets that typically are part of electronic medical records. There is imaging, there is radiology, pathology, liquid biopsy imaging, then there are genomics, all kinds of omics, there is electronic healthcare record, there is family history, the whole 9 yards of data. And every data piece is important here. And more importantly, that data needs to be integrated because you have to look at the data in totality. And if you look at the central part of the diagram, this is the mind map of a treating doctor. The doctor has to synthesize all that data together, create like a intellectual model in his mind, and that too in real time, fraction of seconds. And with very, very less margin of error because you are dealing with life and death situation here. Right? And then on the other hand side, there is a tremendous explosion of technology, all kinds of technology, audio, visual, textual, imaging, etc. So I think this is sort of the landscape that we are currently dealing with. And I just want to go a little bit deeper into this landscape and tell you how we are looking at this landscape from an innovation point of view and therefore business point of view. So quickly, this is the modern view of oncology hospital. It's only representative. You can even think of any therapeutic area here. On your left-hand side is basically a physician-patient interaction. This is mostly conversational AI. We all know that there is a tremendous problem today which is called physician burnout. Doctors don't have time to interact with the patients because they are buried in notes-taking. So can you bring conversational AI to solve that problem? Number one. Second big problem is the speed at which diagnosis happens and lack of expertise that typically slows down the process and the human subjectivity in the diagnosis process. The third is taking what is called as objective decision making. That means can you match a genetic profile or a pathology profile to a particular drug? That is the holy grail of personalized medicine. And can you do it at scale, at fast, without any particular error rate, right? So these are certain problems that we are facing today in today's world. And our hypothesis or premise is that AI can try to expedite these processes, make it better. And nowhere we are saying that it will replace a doctor. I think that's a false premise. But can you make it better, right? So that's my hypothesis here. And in doing so, we collaborated a lot with Google. And Google has been very generous for us in terms of our collaboration spirit. We work very closely with Google Research, DeepMind, and a lot of these groups. What they do is they create all these mathematical constructs we call as foundation models. And then the persistent team, which includes domain and technology experts, we create accelerators out of it. You will see a few accelerators today. And then these accelerators are they're further taken into the business discussions as such. And you can see I've just put a representative tech stack, the services that we have utilized with Google. And there is a lot of experimentation here until we come to a good understanding of the technology. So this is what we call as like a technology and domain research with the help of Google. I'm going to consider 3 scenarios which are very typical to a cancer patient journey. The first scenario is called imaging-based cancer screening. And my surrogate here is, let's say, John Doe or Hari Singh, since we are in India. And I'm going to talk a little bit about what happens in real life and what AI can help you solve that particular problem. So you are going to see a short 2.5-minute video. This is the application of AI and generative AI for lung cancer screening. Lung cancer is my representative cancer. Of course, this can be extrapolated to any other cancer, but we are going to tell you a story of a lung cancer patient here. And the accelerator that you see it's called Can Imagine, maybe a word play on can, cancer, and imagine, about imaging. So let's see what this accelerator can do for us.
Hello, everyone. We from Persistent Systems are introducing Can Imagine, a Google-powered Gen AI-enabled platform for early detection of lung cancer via improvement in chest X-ray screening protocol. WHO Globocan estimates lung cancer as the leading cause of mortality globally. Higher prevalence is attributed to smoking and pollution, lack of awareness, shortage of radiologists, and inefficient screening programs. Our Can Imagine platform is designed to overcome these challenges by leveraging Google's ML embedding models and Gen AI technology. Imagine 57-year-old Hari Singh visiting hospital to seek medical advice for his respiratory problems. With the EHR console, the doctor can either record or upload a pre-recorded voice note. Gemini's multilingual tool facilitates generation of electronic health, record from an Indic language voice note validated by the doctor. The EHR dashboard displays medical details of Hari Singh and an AI-generated summary in multiple languages. Then the EHR similarity check tool compares available EHRs from hospital repository to predict the lung cancer risk. Then the doctor advises Hari Singh to undergo a preliminary screening with the chest X-ray. Now the radiologist uploads the digital chest X-ray image to the radiology console. It identifies abnormalities suspicious of lung cancer using a deep learning faster RCNN model integrated with GradCam layer, represented by bounding box and heat map. Further, the radiologist generates medically descriptive response using a fine-tuned Google Polygemma model. A rigorous fine-tuning process included use of annotated NIH chest X-ray dataset, 13 dataset versions, 19 model iterations, and expert validation. This fine-tuning resulted in 70% more accuracy than the base Polygemma model. Additionally, Gemini model summarizes collective responses generated by upstream ML and Gen AI models. The radiology console also identifies similar chest X-ray images from available repository using Google's Foundation model. Comparative image analysis with Gemini model enables radiologists with improved and objective decision-making. Radiologists can communicate with smart AI assistant via speech or text prompts to describe the chest X-ray image in medical vocabulary. Finally, radiologist generates an editable draft report, later converted to final standard report of Hari Singh with Gemini-enabled key entity extraction. In summary, our CanImagine can smartly utilize scalable Google infrastructure with multiple AI services and tools to accelerate medical consultation, improve second opinion process, increase speed and accuracy of analysis, and expedite automated reporting. Powered by Google's AI technology, CanImagine can be implemented in chest X-ray screening protocols for early detection of lung cancer with significant improvement in access, efficiency, accuracy, and affordability.
Right. So this is the first step of diagnosis, imaging-based diagnosis. What we quickly learned here is that AI can do electronic healthcare record collection using conversational AI. It can create a second opinion kind of a system by looking at retrospective images. It can read an image very well. It can call out good, bad, ugly into that image. And then finally, it can read an image with a large multimodal model, and it can generate a draft report that can be further sent to a human expert for, right? So you can see the automation that can be improved in the entire process. For lack of time, I'm not going to go into pathology, but similar construct can be created for pathology. Typically, what happens in pathology, you saw that red spot in the chest, right? With the help of a CT-guided biopsy, a sample is taken, and that sample is then microtomized. That means it is thinned, sliced thin, and then it goes to a pathology lab. It is observed under microscope, and you look for normal versus abnormal patterns. And these normal versus abnormal patterns can be identified with the help of AI. And you can have a similar image processing algorithm that you just saw, where you can actually call out that there is a confirmed cancer on the image, and then you can generate a report further, right? And partly a process in this entire activity is also taking the sample and giving it for genomic analysis. Our previous speaker told us the great benefits of genomic analysis. So in genomic analysis, you isolate the DNA and you look for certain telltale biomarkers. Let's say in this case, lung cancer, the most famous biomarker is EGFR gene, epidermal growth factor gene. And you look for the mutational analysis of that particular gene, right? So that is a typical pathway for pathology. I'm not going to go there. I want to show the last part of this demo is where you use the genetic information or the pathology information that comes out of this analysis and how it is used for clinical decision making. And that's the word we call translational research. And the concept here is called evidence-based medicine. It's very common to doctors. They typically want to take decisions based on objective evidence-based medicine. So I'm going to show you a demo of how AI can be used for evidence-based medicine for treating patients. So I'm going to skip module 2. Let's go to module 3. And again, let's see a quick demo.
Generating actionable insights from large, complex, and heterogeneous biomedical datasets is a big challenge for the biopharma industry. AI-powered data analytics using knowledge graphs has proved to be a game changer to overcome this challenge. A knowledge graph comprises of knowledge base that uses graph database technology with graph-structured data model to integrate multiple datasets. In today's era of precision oncology, oncoclinicians depend on objective evidence obtained from various tests for life-saving clinical decisions. We have created OmniKG, a cutting-edge knowledge graph platform for evidence-based medicine practice in precision oncology. In OmniKG, we have integrated well-curated, public databases with molecular and clinical pharmacology profiles of anti-cancer drugs. Then, we applied AI tools to enable data analytics for generating clinical insights. We demonstrate the utility of OmniKG in multidisciplinary tumor board setting for evidence-based clinical management of an advanced-stage lung cancer patient. This patient has not responded to conventional cancer chemotherapy drugs. Hence, the oncologists would like to apply evidence-based precision oncology algorithms for choosing alternative drugs. Let us understand OmniKG workflows and features. By entering patients' clinical data, OmniKG generates a disease-specific knowledge graph instantly. OmniKG now displays complex relationships between various nodes, namely disease, organ, gene, variant, along with efficacy and toxicity of cancer drugs. OmniKG indicates that pemetrexed, a potent anti-cancer drug, has clinically favorable evidence to justify its use in lung cancer therapy. For example, Level B evidence from clinical trials confirms significant efficacy, and Class 3 evidence from FDA DILI database indicates lower liver toxicity. Using ToxaBuddy, a generative AI-powered virtual assistant tool, OmniKG searches all integrated databases in real time and identifies multiple drugs with favorable clinical attributes. Using AI-powered natural language processing, OmniKG compares pemetrexed with other anti-cancer drugs by extracting key information from their respective FDA-approved labels. Finally, using all objective evidence from OmniKG, oncologists from tumor board arrive at a consensus recommendation to initiate pemetrexed therapy for the lung cancer patient. OmniKG provides time and cost advantage to oncologists for accurate decision-making that will ultimately save the patient's life. Persistent Systems has a strong track record in AI-powered knowledge graphs applications for biopharma industry. Let us help you apply our expertise to overcome your challenges in big data analytics for biomedical datasets.
Yeah, so last 30 seconds of my talk. The modern view of precision oncology, precision biology, medicine, whatever you want to call it, is integration of all the data sets that can come from what we call as a unified view of a patient. If you see here, you have imaging, you have multimodal omics coming into picture. And then this creates a significant fertile ground for research, right? So precision medicine is not only for clinical applications, but this is also for driving what is called as the next generation research. And these are the areas where we are currently working very closely with Google. I'll be happy to talk a little bit about it offline if anybody's interested. And for all this good work, we have been recognized by Google with multiple accolades. This is just to show that I think when you sort of chase a very good combination of AI and very good understanding of medicine, I think some really good things happen here. With this collaboration with Google, we have been able to generate significant business, both in India as well as outside, and we'll be happy to talk about it. I'd like to thank the organizers and the session moderator for the opportunity. I don't know if we have time for questions, so we can talk about it. Okay. Thank you so much.
Thank you, Mr. Santosh. It's a great use of AI in the clinical research. I think our next speaker has joined virtual. It is Mr. Abhinav Rastogi. He is the president and CEO of Temple University Hospital, which is one of the Philadelphia region's most reputed academic medical center. Mr. Rastogi, are you able to hear us?
Yes, I am, Srini. Can you hear me?
Thank you. Yeah. We can hear you, and thank you so much. Unfortunately, Mr. Rastogi couldn't join us in person today, but he has joined from US virtual, and it's probably around 7 o'clock now, and he has been ready to join us from 6 a.m. his time. And sincere thanks for that, Mr. Rastogi, and over to you.
No, happy to do it. Thank you very much. Again, I want to thank you and the organizers for allowing me to join virtually. You know, Delhi is home to me. I was looking forward to being there in person, but could not be there, so I apologize for that. Srini, can we request the slides up, please, if that's okay?
Are you controlling that? Slides there?
While they bring up the slides, in the interest of time, I think you said there were awards following my talk.
Yeah.
So if you can still hear me, I'm just going to start talking and then, we'll catch up with the slides, if that's okay?
Yes, please.
Okay. So again, like you said, I'm Abi Rastogi. I'm President and CEO of Temple University Hospital, located in Philadelphia. Philadelphia is one of the top 5 cities in the United States. People know New York, Washington, D.C. We're only 2 hours away from both those cities, located again in Philadelphia on the East Coast. So Temple Hospital is a part of Temple University, which wanted to show you a few slides on the programs that we offer.
Mr. Rastogi, could you please share the slides from your machine? I think that will make it easier.
Let me see if I have them here. Hold on. Yep. Again, apologize for not being there.
Yeah.
Can you see my screen?
Yes, we can see your screen. Please go ahead.
Perfect. All right. Yep. All right. So like I said, Philadelphia is the second largest city on the East Coast. It's the hub for a lot of Fortune 500 companies, top 10 cities for startups. We have a lot of incubators here. We have a lot of universities in Philadelphia, including Temple University. And Temple University is one of the top 50 public schools, according to US News, as well as the top 100 national universities in the United States. We offer a wide variety of I'm sorry, I just got a message. Do I need to allow you to take remote control of my screen?
No, you can share and just go ahead, Mr. Rastogi.
Okay, perfect. You can still see them, right? Okay.
Yep.
So some of the programs that we offer, especially medical related, are dentistry, School of Medicine, pharmacy, and these result in the largest provider of these programs in the United States. So under the university is the Temple University Health System. We're made up of 6 different campuses, as you can see. Again, I won't go into all of them, mainly because of time. But I will point out Fox Chase Cancer Center. Mr. Dixit just spoke about lung cancer, and Fox Chase is one of the only designated NCI cancer centers that's freestanding in the United States. It has won Nobel Prizes, and I'll touch a little bit on cancer as well. We have the largest lung transplant program in the country. We do about 120 to 130 lung transplants a year in the United States. And so lung cancer obviously is one of the top things that we work on as well. Again, some of these awards, in the interest of time, I'm going to skip on them. We have been recognized through national and international organizations on various metrics, and so Temple is one of the leaders in a lot of these. So why the need of AI? The need of AI is really based on a few factors. And again, Santosh mentioned a few of these. Physician burnout is definitely one of them. Because of the electronic medical record, your work does not stop when you leave the hospital. You take your work with you home, so you're typing on the EHR. We have something called a pajama report, which means that physicians are at home at night, documenting in their electronic medical records of their patients. And so there's obviously a lot of burnout, a lot of volume that they're taking care of. It also is because of a lot of physicians shortages. There's going to be at least 100,000 fewer physicians than we will need in the next 10 years. 22% of our physicians are aged, or in the United States, are aged over 65 years, and another 21% are between 55 and 64. So if you think about it, close to half the physician workforce in the United States is going to retire within the next 10 years. So there's going to be a huge physician shortage. like Santosh said, we're not looking to replace physicians, but we're looking to make them faster, more efficient, so that they can take care of the aging population, again, not only in the United States, but across the world. And how do you do that? You do that by augmenting the physicians with technology. Healthcare has been one of the last adapters of technology in any industry. You look at manufacturing, you look at even agriculture, all of them have adopted technology much better than healthcare has. So we need to now start augmenting our physicians, our clinicians with technology so that we can, see more patients. Not only with the physicians, there's also high vacancy of non-physicians. Our nurses and our technicians have seen the highest turnover and highest vacancy post-COVID in the last 2 decades. So again, that's the need for AI. So what are most hospitals doing? Most hospitals are again trying to dabble into AI, try to see a lot more, new programs, new initiatives, and there's a ton of them. So this is just a short list of what Temple has been working on, which is in production. The first one you see on there is a bridge, which is ambient note-taking. So again, instead of having the clinicians type, we have ambient, which sits in the room, and documents just like Mr. Dixit demonstrated in the previous presentation. Along with that, we have One Line Health, which is really a pilot that the physicians are using to, again, not only do the clinical documentation, but also do documentation that then changes into coding. In the United States, we get paid on DRG, which is based on how you document and how you code. So we're augmenting, again, the physician's note with coding information. And then there's a bunch in radiology. Radiology has been the most advanced in AI, and I'll go into details on a few of them in the next few slides. Other things that are under evaluation. The first one on this list was really intriguing to me, so I wanted to touch on that a little bit. Vista AI. So when a patient gets an MRI, you have different slices of the MRI. You have different ways in which the patient gets moved within the MRI to get different sections. Vista AI is able to let the clinician or the technician know how they can take different images and combine them together to give a better view of that MRI study, so it takes less time of the patient in the MRI. Some of the patients are claustrophobic, so they don't want to be in the MRI machine for a long time. We also don't have a lot of resources, meaning we don't have a ton of MRIs. So with this, we've been able to reduce the time a patient spends within the MRI machine. Another one on this list to highlight is InBio, which focuses on ILD, institutional lung disease. Again, because we have a large group of lung patients, that is something that is helping us with getting patients through the transplant evaluation and getting them to transplant in the right setting. Clinical research. Like I mentioned, we have Fox Chase, which is the NCI designated cancer hospital. We also received the Nobel Prize in one of our medications that was developed at Fox Chase. Imagine if you can have AI that helps you reduce the burden through technology on supported clinical trials. That's what we're trying to do with Flatiron. And Flatiron is helping our clinicians at Fox Chase do a lot more clinical trials. And then if you augment that with Deep 6 AI, again, these are examples, which helps you recognize your patient population and be able to engage them into the clinical trial. So what happens really is that you can start a clinical trial, but it's really engaging the patients and informing them and highlighting the right patient to get them into the clinical trial, which is what most organizations, have issues with. So Deep 6 helps us go through the patient chart, identify the patients that are coming to clinic the next day, lets the clinical researcher know which patients to talk to about which clinical trials, and then get them. So we've seen a really high success rate in engaging our patients and involving them in clinical trials post the implementation of Deep 6 AI. Keeping with clinical research, Temple is a non-for-profit organization, but we have for our first time invested in a Series A company, which is Segment. Segment was listed as one of the top AI and data products of 2024. What it really does is, because again, with clinical data, you need to blind the clinical information because of HIPAA requirements. Segment helps take away, what 6 of those employees were doing, which is to de-identify the data, and within microseconds is able to de-identify films, clinical documentation, and upload them into third-party tools so that we're able to de-identify our patient data when we're looking at evaluating AI products. So this is one of the first that Temple has invested in as a Series A. Like I mentioned, I'll go into a few of the radiology tools. Transpera helps with pathology reports, with mammograms, sorry. So 2D and 3D mammos, when these images are imported into Transpera, it then helps evaluate with our clinicians. We currently have about 8 physician shortages in our mammo department within just Temple. In the city of Philadelphia, your wait time, and I know in India it's very different, but here we have huge shortages, and a lot of our images actually go overseas to places like India and Australia to interpret them. But those images need to then have to be reinterpreted by our radiologists the following morning. Along with Transpera, they're able to read these images much faster, and we've seen about a 62%, just like the study that they had done, in reduced workload of our radiologists. So again, what I'm trying to help you understand is with the shortage, AI is not going to take away the physician's job, but is helping them becoming more efficient so that we can treat more patients, have early detection, and be able to treat these patients at the right time in the right setting. AI Doc is another one that we're working with. This really looks at multiple different images, including chest x-rays, and has been, just like the demo that Mr. Dixit showed, is able to identify and help the radiologists become a little bit more efficient. I'm not going to go into some of the other radiology things, but I will focus on CoreLine for a second. CoreLine, again, focuses on lung cancer detection. In Philadelphia, most of our lung cancer is detected, just like India, in late stages, late 3 and 4. And because of that, it's our experience that having these patients come in and be able to identify the cancer early helps with earlier interventions, and so they don't have to go through mortality, which we're seeing a significant decrease in mortality by implementing these these products. Again, I'll leave with the last slide. Srini, you're on. I just want to give, I don't know if Mr. Hermeet is on, but give GS Lab and GAVS a huge shout out. One of the things that I would say is that as most hospitals are going through the AI journey, that is not what we do for a living. We treat patients. There's going to be a lot of new startups that are coming up. Most of them are not going to be around in the next year to 3 years. It is our duty to save our patients' data and to be able to make sure that it's secure. So GS Labs and GAVS has really helped us secure our data. I stole one of these slides from them, so I hope you don't mind. But really what I would encourage is, as more hospitals go through this journey, please make sure that your data is secure. In the last 2 years, 92% of the healthcare organizations that have been interviewed have said that they have had some sort of a data breach in the last 2 years. An average cost of a data breach is about $5 million. If you're United Health, your data breach could be as high as $2.5 billion. So it's worth investing and making sure that your data is secure before you go down this journey. With that, Srini, I'll hand it over to you. Again, I apologize for being remote and went through the slides really quick, but I know that there's much more in the program that's more exciting, so back to you.
Thank you, Mr. Rastogi. That was really excellent presentation, and you covered both the patient care and clinical research and also bridging the gaps between the care and the research, right? Thank you so much for that insights. I know you have some busy schedule today, but it will be great if you can stay with us for the rest of the session, but feel free, Mr. Rastogi. Thank you once again.
Thank you. Thanks.
I would like to welcome our next speaker, Mr. Sanjay Murdeshwar, who's a regional president from Danaher Corporation, and he has been part of Novartis and AstraZeneca in the past, and he has an extensive experience in life sciences. Mr. Sanjay. And I know Mr. Sanjay has a flight to catch, so he'll keep it short.
I'm extremely motivated to keep it short. Well, I think I'll just try to, just change the agenda a little here, moving from data to sustainable healthcare. My little understanding of sustainable healthcare is the fact that we need to provide quality healthcare for the present generation, but at the same time not kill the future generations. It's as simple as that. And I come from a company which is Danaher Corporation, which is probably one of the world's biggest life sciences and diagnostic innovation company. We're $24 billion with a market cap of nearly $200 billion. And 90% of the world's biopharmaceuticals, cell and gene uses our downstream and upstream technologies. Most labs, private and academia, use our instrumentation of life sciences businesses. And of course, most hospitals and clinics use our diagnostic equipment. But I think very strangely so, talking about sustainability is very important for us because you may be surprised to know that in healthcare industry especially, it actually generates 55% more greenhouse gas emissions than even the automobile industry. In fact, one inhaler, just one plastic inhaler, in fact creates more carbon impact than a car which travels 180 miles. So you can imagine the impact of just the healthcare industry doing what we're doing. So it's very paradoxical that we are here to treat patients and to provide great value to our patients, but at the same time, we do not help with their future. And I think this is for very simple reasons. It's because I think the healthcare ecosystem is a very fragmented ecosystem. We have manufacturers, we have providers, we have service providers, hospitals, physicians, and so on and so forth. And somehow I feel the incentives are not always aligned. And therefore, it's very important that I think the value chain across all of the healthcare delivery system needs to have better collaboration. And I think it needs to have better collaboration. That's because it's very difficult to assess the return on investment on sustainability because it's such a very complex supply chain of healthcare that we provide. It's also because there are different jurisdictions all across the world on regulations on how healthcare is provided, just in India or across the world. And last but not the least, there are huge challenges in data fluidity. Data is very clearly succinct, but it's trapped in very small areas and that cannot be used across to make sure that we can create better sustainable models. And therefore, what I would like to propose is, I think very simply, that we need to move from a linear economy of healthcare to a more circular economy of healthcare. What that means is focusing a little more on reuse, to repair, to refurbish, and recycle. That may be not the best business model for a company that manufactures diagnostic equipment and bioreactors and so on and so forth, but that's the best way to move forward. And I think here, it's really about designing out waste, it's about designing out pollution, it's making sure that most of the products and materials in use are in use as long as possible. Hospitals will know this on a day-to-day basis. There are a huge amount of consumables, reagents that are used, huge amount of waste that are created. And therefore, one of the areas which I would like to propose is to talk about each of these entire ecosystem from product to a service environment where customers access products not as a tangible asset, but really in areas of leasing, in renting or subscription, because this will promote resource efficiency, across huge areas. It'll extend product life cycle, it optimizes utilization rates, and it certainly reduces over consumption. And all of this can be brought together by digital. I'm not the digital expert here. There are a lot of folks here who have talked about it. But very simply, things like the Internet of Things, what we can use is just smart monitoring and preventive maintenance, which can create predictive algorithms due to which the operational lifespan of assets become longer. Once they become longer, so you can use it much for a longer period of time. We can talk about more resource efficiencies where we source the materials sustainably and production processes become specific so that they can minimize resource input. Just to give you a perspective here, I think the amount of plastic that we use in manufacturing of diagnostics, instrumentation, or any other instruments used in labs, equipped around the world is quite horrific. And what can we do to reduce the size, to make sure that filtration can be done with higher material quality? There's a lot of research being done in that area. And last but not the least, using blockchain. That's very useful for especially traceability and transparency of operations across the entire biopharmaceutical, diagnostics, healthcare delivery system. So just a couple of examples is, just the use of ML classifier that enables fast and accurate and affordable classification of brain tumors. There were some examples earlier. We have a couple of companies which do that on a regular basis around the world for most hospitals, especially for genome-wide DNA methylation profiles. More advanced biosensors for TB detection, because it leverages advances in nanotechnology and nanomaterials. Again, using lesser material you use, and therefore it's much easier to make sure that it's substantially friendly to the environment. And last but not least, using what we call as specifically digital anti-cancer 3D in vitro models. I think something which was already shown earlier that can mimic tumor microenvironments compared to the traditional 2D models. What we do is a lot of digital twins so that you can design a lot of these optimization of supply chain across for biomanufacturing, cell and gene manufacturing, making sure that each of the reagents, consumables are done in a very, very systematic and optimized manner, and you can do what we have to do on a computer or a laptop. Because finally, as technology is really moving towards very simply, that discovery is becoming more of a computational challenge, rather than, I think, the old days of sitting in labs with lab coats and with test tubes. And therefore, with that, I'll stop, because again, in the interest of time, but very clearly, hopefully we can hold the healthcare systems for the present generation, but more importantly, create very sustainable solutions that we can still survive to help the next generation too. Thank you.
Thank you, Mr. Sanjay. Well, we have been talking about patient care a lot. I think this perspective of care about environment also is very important. Thank you about that. Now I'd like to welcome Dr. Subhashish, Head of Medical Affairs, India and Southeast Asia of ResMed. Please take over. Again, sorry about it. In the interest of time, you will have about 5 minutes. Thank you so much.
So, very good evening, and thank you for having us here. I'm Dr. Subhashish Dey, and I represent ResMed. Can we have the slides up? Yeah. So maybe in the next 5 minutes or so, we'll try to speak about the patient-centric digital health initiatives which we have, and what has been the ResMed experience on this part. So ResMed is a global leader in connected care and digital health, and we primarily operate in sleep health, in respiratory health, and we also have a SaaS business which specifically caters to the US market. And as you can see, most of the devices are connected devices, so we have tons of data, close to 21 billion nights of sleep data with us, sitting with us. At the same time, when you look at, and particularly from ResMed side, when we look at sleep health, we find, there is a pandemic which is kind of going on right now. So we currently have almost 1 billion patients who are suffering from obstructive sleep apnea, close to 800 million patients who are suffering from insomnia, and of course, close to 400 to 500 million patients who are COPD patients. But for today's sake, we'll try to focus only on obstructive sleep apnea and what has been our experience around it. And as you can see, this is a disorder which typically happens when we are sleeping and there is an obstruction in the upper airway, as a result of which we do not, we are not able to take enough of breath and we get micro-awakenings. And these micro-awakenings can happen multiple times in a night, leading to different conditions which are connected with cardiometabolic disorders. And however, the mainstay of treatment of this therapy has been positive airway pressure devices. And what we know that, if someone has used this device for more than a year in a compliant manner, there are healthcare benefits associated with this device, both in terms of morbidity and in terms of mortality. So, however, having a device is very challenging. You need to get used to the mask. You need to get used to having the device getting used each and every night, right? And there is also a lot of troubleshooting which happens in the initial few weeks of the therapy. And when this troubleshooting doesn't happen, there is decrease in compliance and adherence of the patient. So ResMed in its ecosystem had two apps which were working already. One was the MyAir app. It was the patient coaching, patient engagement app, which actually nudges the patient to take the therapy. And then we also had another, patient-facing, HCP-facing software, which is the AirView. Mainly, it's a remote monitoring platform where we can also do the prescription changes. So when we started thinking about the, next generation device, we started thinking that, okay, what can we do to make the patient more adherent to the therapy? And that's where we thought that, why not bring all the components together, which includes the PAP device, digital therapeutics, remote monitoring, and of course the best-in-class mask which we have. And what we came up is something what we call as AirSense 11. This is the next generation PAP which ResMed offers to its patient. And I'll just play a short video to give you an understanding of what this device offers. So in the past 2 years, we have conducted several big data analysis with this ecosystem. And what we found is that, there is almost 87% compliance with this particular ecosystem when we use this, right? And last but not least, this is my last slide, and I'll stick to that 5 minutes. So when we look into the entire journey of the patient, which starts from initiating the therapy, first few weeks, and long-term adherence, I think this ecosystem is currently working. And that works because we have merged not only the Internet of Things, but we have tried to bring in the digital therapeutics and the remote monitoring together with this device. So thank you so much.
Thank you, Dr. Subhashish. Short and sweet, and thanks for that. Next, I would like to welcome Mr. Tarun Pratap Singh, AVP Head of Pre-Sales Cybersecurity Practice, Hitachi.
Slide, please. Good evening, everyone. So here, I am representing Hitachi Group, and it is like one of the subsidiary Hitachi System India Private Limited, and it is about cybersecurity practice and provide the solutioning of AI. So we have exclusive partnership with the multiple OEMs and provide the solution in the field of AI. So agenda here, I just want to describe Hitachi Group, then artificial intelligence, India AI market trends, our AI portfolio, and the AI use cases. So Hitachi Group, as you know, is a very bigger name, and it's last 1 century. It started from 1910. It has 4 entities: digital system, green, connectivity, automation system. And the heart of this all 4 entities is a Lumada that is nothing but is a digital data system powered by AI. So what Hitachi Group is working is initially working from the AI. It is maintaining the Lumada, that is the heart of the Hitachi Group, and it is providing how to build, how to maintain the society problems and work in a social innovation business. Hitachi System India part of the digital system, and I am representing Hitachi here, which include the 5 pillars, and one of the pillars is a generative AI. So we are working on the generative AI last 1 decade, and especially the industry, if you can see here, the healthcare. So we are providing the services to the healthcare in the field of the AI. Here you can see our customer base, Cipla, Fortis, Medanta, Greenmark. So it's like, because we have a lot of customers here, but because of the spaces we have mentioned. So everyone knows about AI. AI is nothing but like, it is not a new technology. It is started from the 1942, but people knows about the ChatGPT only these days. What is the market demand of the AI solution? So increased demand for the smarter solution and automation and efficiency. That means in the field of healthcare, people want their devices automatically efficient, smarter. This is the market trend right now. We have mentioned in the left-hand side, you can see the India trends. 48% of the company is use AI right now. And one of the companies, the healthcare, 39% have an integration with the AI. And the 12% organization is a future consideration of the AI. In the right-hand side, you can see that every year, 33.28% growth we have from 2022 and expected to be 2028. So you can see the graph that AI market growth in 2022 is 680 million and will be expected till 2028 is 3,935. This is a Hitachi portfolio. We are providing a services in the market. We have an exclusive partnership with the OEM. We are providing the consultancy services, integrations, customer AI solution and infrastructure. That means we are also developing AI tools in the organization of multiple organizations. We are also providing a support in our organization. So here is, we have mentioned 3 use cases that we already have providing a services. This is one of the use cases, is a patient 365 platform. That is nothing but we want a single dashboard that is used by the hospital. You can see the real-time monitoring of the patient. That means one single dashboard can tell the history of the patient and the data we collect from the HIMS and from the internal hospital, external data from Arogya, like the government ID and the cloud data. So anything that any patient attend, any labs, diagnostic system. So we collected data, and this solution we already have in one of the client. And so single dashboard can be helpful for the healthcare system. For the patient point of view, patient also can see the history. And the third is the output alert and notification. That means you can receive an alert and notification even in a hospital, even in a patient. The second use case is discharge summary generation. That is also a solution point of view we have deployed in a multiple hospital. That means if patient want to discharge, it will take around 1 day, but from this solution, it can be discharged in 10 minutes. The third is a visual inspection deep learning, that is predictive maintenance. That means we have a lot of machines in a healthcare system, but the alert system should be generated before the machine is going to the wrong direction. So preventive maintenance, one of the solutions we implement in one of the hospital. So because of a very less time, thank you very much.
Thank you, Mr. Tarun. It's very tough to moderate the last session of the day. It's tougher than implementing AI. Anyway, thanks to all speakers for a great insights and sharing the knowledge. On behalf of all the speakers, I would like to thank Apollo Hospitals and THIT for giving this opportunity for all of us, right, to be part of this massive knowledge sharing event. Thank you once again. Good evening to everyone.
I would request all speakers to please gather for a group photograph. Thank you. As we wrap up the discussions today, we will move on to the THIT 2025 awards session, co-presented by Microsoft. We are honored to have Mr. Naveen Balluri, General Manager, Health and AI, Microsoft, who will be coming up on stage to present the awards. So please put your hands together and welcome Mr. Naveen Balluri on stage. So let us begin Transforming Healthcare with IT 2025 awards. And the first award is for Best Community-Based Health Initiative. This is awarded to Prabhat Healthcare Program, Hindustan Unilever Limited. Please give a round of applause to the winner, Hindustan Unilever Limited. I would request the team of Hindustan Unilever to please come up on stage to collect the award. Please give a round of applause to the winner for the Best Community-Based Health Initiative, Hindustan Unilever Limited, for their program, Prabhat Healthcare. Congratulations to Hindustan Unilever. Our next award is for Best Digital Technology Solution for Hospitals, and the award goes to Koita Center for Digital Health, IIT Bombay. Please give a round of applause to the Koita Center for Digital Health, IIT Bombay. Congratulations. The next award is for Best Digital Transformation in Healthcare, and the award goes to Code Blue Technologies, Blue Plus. Congratulations to Code Blue Technologies. Please give them a round of applause. The next award is for the Best Mental Health App, and the award goes to Pulse of Wellness, Empathy at the Core, HR's Commitment to Mental Health, Apollo Hospitals, Ahmedabad. Congratulations. The award for Best Use of AI and ML in Healthcare is awarded to Baby Memorial Hospital. Congratulations to Baby Memorial Hospital. Our next award is for Excellence in Healthcare Training and Upskilling, and the award goes to MedLearn Private Limited. Congratulations to the team of MedLearn. Award is for Excellence in Mobile Healthcare and Community Outreach. This is awarded to BSS Microfinance Mobile Medical Units. Congratulations to BSS Microfinance. The next award is for excellence in rural healthcare delivery, and this is awarded to Credit Access India Foundation Cancer Health Check Program. Congratulations to the team of Credit Access India Foundation. The next award is for Best Healthcare CSR Project, and this is awarded to Fujifilm India for Where Innovation Meets Care project. Congratulations to Fujifilm. Is for Health Tech Startup of the Year, and this is awarded to Inara Skin App. Please give a round of applause to the winner, Inara Skin App. The next award is for Innovative Patient Engagement Solution. This is awarded to Highway Infrastructure Trust. Congratulations to Highway Infrastructure Trust. Please give them a round of applause. The next award is for Outstanding Contribution to Preventive Eye Care. And this award is given to Spandana Spurti Digital Dispensary. Congratulations to the team of Spandana Spurti Financial Limited. Please give them a round of applause. For the next set of awards, I would like to invite on stage Girish Kulkarni, Chairperson, Chime India, and Jayaprakash Trivedi, Board Member, Chime India, and Mr. Kumar KV, Board Member, Chime India. I request all three gentlemen to please come up on stage to present the next set of awards. Along with you, sir. Along with Mr. Naveen Valuri. The next award is Chime CIO of the Year 2024 award, and this one goes to Srini Venugopal. Congratulations to Mr. Venugopal. And the next award is Chime Project of the Year 2024 award. This one goes to Nightingale, AI-powered digital platform for nursing excellence from Baby Memorial Hospital. all the award winners to please come up on stage for a group photograph. Please bring your trophies along. And I request you to please come up on stage quickly so that we can take this group photograph. Please give a round of applause to all the winners of the evening today. All their hard work has paid off and they have received a lot of recognition for the good work done by them. Yeah, I request the winners on the sidelines to please come up for the group photograph. Congratulations to all the winners of the evening. I would like to thank Mr. Naveen Baluri, Mr. Girish Kulkarni, Mr. Kumar KB and Mr. Jaiprakash Dwivedi. Thank you all for encouraging all the winners here and presenting the awards. This concludes today's session. Thank you all for your participation. We look forward to seeing all of you again tomorrow right here at THIT. Please do remember to carry your access badges and check out the stalls at the pavilion. We look forward to seeing all of you tomorrow again. See you in the morning.